Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
This meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, you know, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hi everyone, and welcome to the 2024 Men's Health Conference. We're so excited that you've joined us today. Thank you so much. We're really excited to present all of this information to you. And we're going to be covering things like addiction and recovery. We're going to do a deep dive into BPH and look at Aquablation. And then we have a special celebrity interview with Mr. Shannon Sharpe, who's a 3-time Super Bowl winner, and he's in the Hall of Fame, and Dr. Mark Moyad is going to be interviewing him. And then we have an extended Q&A with Dr. Mark Scholz and Dr. Mark Moyad. So before I get into the conference, I just wanted to thank our sponsors who made this free for everyone here on our YouTube channel and at our website, PCRI.org. And our sponsors are Bayer, Janssen, and Dendreon. We really appreciate their support, and thank you so much. You can check out their information at PCRI.org, and you can see it on the front of the website. Just click on the image on the front of the website, and you can learn more about the entire conference, the agenda, the speakers, and so much more. There's a lot of resources there for men's health, and I suggest you go there and check it out. It's a really great way to build up your education. So let's begin. Our first speaker is Dr. Emmett Lee Rice, and he's going to be talking about addiction and recovery and giving us some practical information on how to either help ourselves or our family members. He is the CEO and the medical director of Life Wellness Institute here in California, and he does an incredible job talking about addiction, how it works, how people are addicted to different things, and really the practical ways of getting out of it. After his presentation, he's going to be moderated by our moderator, Dr. Mark Moyad, who is with the University of Michigan, and the Q&A is just fantastic. I hope you find this information helpful.
Thank you, Alex. It's a pleasure to be here. I'm happy to talk to you today about this very important topic of understanding addiction. I'm a family physician, and addiction is something that I have come across mainly when I was a team physician for the San Diego Chargers. And we had a fellow who's the NFL drug advisor come in and give us a talk at the NFL team physician meeting one year. And what he told us about addiction and how drugs affect the brain was mind-boggling for all of us. None of us had ever heard that information before. And to me, it was very exciting because it explained not only addiction and why addiction happens and how can we deal with it, it also explained the keys for wellness, and what everybody can do to be more well is the same things that people in recovery need to do to stay healthy at all. So this is great information for all of us. I hope you enjoy it. I, having learned about addiction, have dealt a lot with people in recovery. And I will tell you that doing interventions and helping people through the process of recovery is one of the most rewarding things that I do as a family physician. So I'm happy to be here and excited for you to help understand this. Today, what we're going to do is I'm going to give you kind of how I see it. I'm going to tell you what happens, what we see clinically with a patient who's using substances and how their life transforms itself during that process. We're going to talk about how many of us are affected by it. We're going to talk about how drugs affect the brain and why they affect the brain and why the behavior that they employ is so predictable. It's very, very predictable, and you'll understand that in a minute. So first we'll understand and talk about what happens. Then we'll talk about why it happens, and that has to do with brain neurochemistry. We're also going to talk a little bit about how it affects the family, because this is a family disease. We say that families get sick together and families get well together. They recover together. So it's important to understand how this affects the families, and in a work situation, it affects the entire workforce, the workplace, and a team situation that affects everybody on the team. And so this is something that doesn't affect just one individual. It affects everybody that individual is involved with. We'll talk about the solution. What do you do about it once you understand you have addiction and you need to get treatment? And we'll talk a little bit also, I'll share some information statistically about the recent opioid epidemic that's occurred in the last probably 4 or 5 years, and what that means and how we deal with that. And then at the end of the fact, after our talk, I'll be happy to answer any questions you have, and Dr. Moyad and I can talk together about that. Initially, what's really important to understand is that all drugs that alter brain substances are euphorics. So all drugs, whether they're an upper or a downer, whether it's a Quaalude or a Valium or an amphetamine, all these drugs that people take that make them feel differently that they like initially cause euphoria. And that's sort of a strange thing when you know that, for example, alcohol is a chemical depressant. But initially, when people drink alcohol, they get giddy and they have fun, and you see these kids playing around after using, and it's really clear that they're giddy and funny and having a good time and they're euphoric. So why does that happen? We'll explain that, and we'll explain what happens as you go through the course. So remember that initially, nobody wants to become a drug addict. There's nobody that started using drugs or drinking alcohol that says, you know, I'm going to screw up my life and I'm going to cause myself to be addicted and take away everything that I really value in my life, and that's where I'm going to go. That's not the way it starts. It starts by just wanting to have fun or experimenting. The age of experimentation is getting younger and younger for some drugs, older for other drugs. I'll explain that in a minute. But just remember that initially it's sort of a fun thing and helps people feel better oftentimes, and that's what they remember. Interestingly, the adolescent substance abuse data shows that it's America's #1 public health problem, especially in the teenage years. If you use the first drug, first substance before age 15, 28% of people do. This is basically the percentage of the population that are 12 and under with a substance use disorder. It's now called not drug addiction, it's called a substance use disorder, an SUD. So 28% of people in treatment have started before age 15. 18% started between 15 and 17, 7.4% started 18 to 20. The interesting fact here is that only 4.3% of people in treatment started using after the age of 21. So there's a lesson to be learned here. You know, if we can keep kids from abusing drugs early on while their brain is forming, and remember that brains don't mature for most people until the age of about 25. We kiddingly say women, it matures right around 25, a little bit before men. And for boys, it often never fully matures, but it probably does, but 2 or 3 years after males. So the longer we go before we start abusing the substances, and when I say substances or drugs, please understand in this presentation, I'm talking about anything that alters the way the brain thinks. So whether it's alcohol or cocaine or marijuana or prescription medications, I'm only talking about drugs in the generic term. So please don't think when I say drugs that I'm not talking about alcohol too. We're talking about everything. So if first use is over 21, only 4% of people in treatment are likely to be in that group. And that tells us that the more we can delay early onset, the better we're going to be in terms of preventing problems. The research regarding when people are actually starting is a little bit varied. You can see on the trick to the left here, this one says alcohol, average age of initiation is 16.5, but according to the American Academy of Child and Adolescent Psychiatry, the average age of starting alcohol is around 12, and the average age of starting cannabis or marijuana is 14. Cigars, 17, cocaine, 18, crack cocaine, about the same age, 18, ecstasy, 17, heroin, 17, and there's been an increase lately in the last 4 or 5 years of heroin usage because it's become so cheap. So before, 20 years ago, only really end-stage addicts used heroin, and nowadays it's one of the more common drugs in young people, something we need to be concerned about. And even snorting things, inhalants, the average age of starting that is around 15. So I want you to understand some things about teen substance abuse. This is important to understand because it really will put a highlight on the significance of this for our society and for how things are going to be as these teenagers get older. Alcohol kills 6.5 times more youth than all other illicit drugs combined. So alcohol, in terms of which has the biggest effect overall, certainly it's alcohol. By 8th grade, 52% of 8th graders have consumed alcohol, 41% have smoked cigarettes, 20% have used marijuana. 28% of teens know that a friend or classmate has used ecstasy. 17% know more than one person who's used ecstasy. Traffic crashes are the greatest single cause of death for all ages between 6 and 33. And most traffic deaths are related to alcohol-related crashes. In other words, 45%, not most, but close to most, 45% of fatalities are alcohol-related. Crystal meth is now the most dangerous drug of small-town America. And kids between 2 and 14 living in small towns are 104% more likely to use meth than those living in larger cities. So we have to be aware of that when we're addressing the macro problem. And youth who drink alcohol are 50 times more likely to use cocaine than those who never drink. So when they talk about alcohol being a gateway drug, it certainly is. Alcohol lowers inhibitions, makes people want to do other things that are causing them to be fun or socialize with people who also are using substances, 50 times more likely to use cocaine than those who never drink. Over 60% of teens said drugs were sold or used or kept at their school. I've done talks at a lot of high schools and grammar schools, and I can tell you that that's absolutely true. In 2006, over 2 million teens used prescription drugs. So you can imagine this is now 2024. It's a lot more than that now. 15+% of high school seniors reported non-medical use of at least one prescription drug within the last 12 months. And 64% of teens 12 to 17 who have abused pain relievers say they got them from friends or relatives, and often, actually most of the time, without their knowledge. Teens whose parents talk to them regularly about dangers of drugs are 42% less likely to use drugs than those whose parents don't. So many parents just are afraid to talk to their kids about drugs. They don't maybe know what to say. They're not sure how to approach the subject, and so they just avoid it altogether. Or they abuse drugs themselves, including alcohol, and they don't want to talk about it because of their own use. But if you really want to protect kids, encourage parents to talk to their children about the pros and cons and let it be a discussable topic among them. But although that's true, 40% less likely to use drugs than parents who don't. Less than 1/4 of teens report having these conversations with their parents. Marijuana use is the same as about 5 years ago, so that's not changing a lot. And teens don't generally this time see marijuana now as dangerous. So because it's been legalized in most states, many teens just think that because it's legal, it's just like alcohol, and they don't see it as a danger at all. Prescription drug use and inhalant use have been steadily increasing over the last 5 years. I'd like to say a word about marijuana because it has been legalized now, and because of that, many people think that it is safe. It actually is not safe. There are no health beneficial effects that have been documented by any evidence-based studies about marijuana. There are short-term effects of marijuana, which is why most people use it, because they like those effects. It relaxes them, but it has immediate impact on their thinking ability, their attention, their cognitive, executive functioning, their short-term memory especially, coordination and movement are impaired, and time perception becomes impaired. And with long-term use of cannabis, it can affect brain development, especially when you're using it as the brain is developing, again, before the age of 23 to 25. We see problems in older people that have started at those ages, the young ages, problems with attention, with memory, with problem-solving skills, and also just overall behavior, healthy behaviors using cannabis before age 18. And one of the biggest things that it really does with kids is when they use marijuana is it takes away their motivation and their drive. And I've seen lots of kids who come in with addiction, and their parents say they just become a totally different kid. You know, they used to be involved in sports or athletics, or they loved this or that, and now they just it doesn't matter much to them. They lost all their motivation. They're not studying. They just don't want to go to college anymore. All kinds of changes about how they perceive life to be, what their problem-solving skills are, how they analyze what's going on in their life. They lose those abilities. And we see similar findings actually in adults who continue to use marijuana over a long period of time. It's both physiologically and psychologically addictive. We thought for a long time maybe it was not addictive. We now know that it is. It's very difficult for people that are using marijuana regularly to get off of it. It's not easy to do. And there's a difference between two of the metabolites of marijuana. Marijuana is broken down into first hydroxy, THC, tetrahydrocannabinol, and then also carboxy, THC. And it turns out that hydroxy THC, that first metabolite, is the one that causes the symptoms that most people like. It causes increased in the munchies. They have, delusions, hallucinations, kind of things. They can get focused on something that's not very important otherwise, but they do. But those early on symptoms, when they smoke marijuana, what they like about it, besides the relaxation effects, are caused by the hydroxy THC. That is washed out from the brain in about 4 to 6 hours. And when that leaves, people think that they're just fine. Unfortunately, there's another part of the brain, another part of the marijuana, that's a metabolite that's called carboxy THC. Whereas hydroxy THC is hydrophilic. It's basically stored in the water cells. It's dissolved in water and it leaches out very quickly. So it's gone in 4 to 6 hours. But the carboxy THC is what we call lipophilic. It actually attaches to fat cells, and then it's much longer in terms of how long it stays in our system. We know that hydroxy washes out in 4 to 6 hours. Carboxy THC may take 4 to 6 days to go away. And for people that are using on a regular basis, especially people that have heavy fat content, overweight people, it can take up to 3 months to totally go away, so that you've got decreased concentrations in your bloodstream below the level of effects that affect your brain. So what does it matter? Well, here's a study they did on airline pilots. They took airline pilots that had not used marijuana. They put them in this study and they gave them a joint. They had them smoke one joint and they immediately felt all the effects. Before they started the study, they put them in plane simulators and they all had perfect scores on their plane simulation, perfect leg takeoffs, perfect landings. After they had the marijuana, they had all kinds of problems, as you can imagine, with coordination and hand-eye coordination and spatial appropriate development and so forth with their vision. After 24 hours, they said they were all fine. They scored them. Do you have any side effects now? Are you fine? Do you feel like you're sober? Yes, they all felt like they were fine. They put them back in the flight simulators. They did the same study. Every one of them, after 24 hours, feeling fine, had major errors in takeoffs and landings, and one of them missed the runway entirely. So the bottom line lesson to take home here is that even though we may feel you're fine after you've used marijuana, unless that THC, that is carboxy THC, has washed out of your brain, you still may have significant alterations in your brain functioning, and you don't even know it. So the problem that I see with kids who are just using drugs like marijuana on just Friday or Saturday night, they think they're just partying, but Monday they're fine. They're not fine. They're drug affected 24/7 all week long, and then they use again the next weekend. So it is a problem. It is addictive. It's tough to get off of it, and it's something we all need to be aware of. So here's what I want you to see. This is important, I think, to really understand what goes on, and I'll explain this graph. The red line that goes up and down, that's kind of normal mood for most people. Some days are better days than others. Some days are worse days. We have moods that are up and down, but they kind of vary about that normative curve there in the middle. When people take drugs, the first drug, remember I said all drugs are euphorics? Well, that big thing you see right here, this big highlight, that's euphoria from taking the drug. And after you take the drug, you get a less effect, but usually there's not much of a follow-up negative effect from initial use of drugs. What happens is then, especially kids who start using drugs, and it happens with adults too, but with kids, because the initiation phase is usually earlier on, they remember that high, and they remember the good feeling that high caused. And some of the big kids, they feel like, the addicts will say that first high was the first time my brain ever felt normal. It's the first time I really felt at peace with myself. The noise in my head went away, the committee in my head, they call it. And I never forgot that first feeling because it was so great. Most people, they feel high, but it's not that great. It's okay, but they remember it. And the next time they party, they remember it again. And it was kind of a fun thing. And there are progressions that go on here. And if you look at this one in the brown, you see the high becomes over time, it becomes less high and less high. And pretty soon it's not high at all anymore. And now it just gets low. I don't know why that happens, but that's what happens. And so when this progression happens, this is called tolerance. And what happens with repetitive use of a drug, it eventually takes more and more of drug to get the same effect. So people use more of it, they do it more often. The highs get less high, but they always remember how big this first high was. And certain people, everybody really, if you took statistically 7 people, out of 7 people in our country, probably 5 of them will abuse drugs or alcohol at one time. And all 5 who abuse substances at some point in their use history will have a problem. They sleep in too much, they fail a test, they get into a fight, they cheat, they steal, something goes on, they lose a job, they get with a drunk driving, something happens, and they have a negative outcome because of their use. And most all those people will say, I'm not going to do that anymore. I learned my lesson. I got hungover, I slept in, or I said something I shouldn't have said. I embarrassed myself, or I didn't do well on my test. Something happened, and I'm not going to let that happen anymore. And everybody promises themselves that they're going to change, and they all try to. But there are certain people who have a hard time changing. So out of those 7 people that abuse, 7 people that there are 5 people that abuse. And out of the 5 who abuse, all 5 will have negative consequences with repetitive overuse. And out of that group, they will all promise themselves they're going to change their behavior. But statistically, 4 out of the 5 can, and 1 doesn't. And the one who doesn't is the one who has a hard time, and usually that's the one who's genetically predisposed. So we say when genetics meets opportunity, we have addiction. And it's very unusual to see somebody who's in a recovery program that doesn't have some first-degree relative that also has a mood disorder or an addictive problem in the past. And so we now know that there is a genetic predisposition. We'll talk more about that a little bit later, but that's what happens. So what we see is tolerance, which is it takes more and more of the drug to get less and less effect. And then we see withdrawal coming in. The more you use over time, the downsides become deeper and deeper, and the end-stage addict is now no longer using because it causes fun and it's euphoric. They're now using because they feel so horrible when they're down here in this trough. They're just trying to get away from the feelings of withdrawal, and that's what's going on. And so even though they have negative consequences, they continue to use because their brain always remembers this high up here. They're always expecting to get that first high, but it's never coming again. Now they're just using to get out of the horrible feeling that they have in their brain when they're not using. And as this thing progresses, They become initially just interested in medication or drugs. They think it's fun. They like using it. And over time, they're not liking it anymore. At the end stage, they need it. So now these people aren't using because they like it. They're using because they crave it, and they don't know any other way to get away from the horrible feeling they have when they're not using. So that's the problem, and that's how tolerance can develop, and that's also how withdrawal can develop. So when genetics meets opportunity, we have addiction. Many people will have risky substance abuse. Some will have progression to substance abuse disorder where the substance is causing a problem in their life and they need some help to get over it. But remember, 4 out of the 5 people can just stop that, because once they see the light, once they recognize the problem it's causing, they're not going to do it anymore. But 1 out of those 5 users who are abusers has addiction. And that person is the one who, in spite of all good intentions, in spite of trying to do it, trying to do everything they can to stop, promising themselves that they will, trying all kinds of ways to stop, they just find themselves unable to do it. And you go, why is that? What is going on that that's the case? So this is the progression that we see. Initially, drugs are fun. They're experimentation type usage. It's social. A lot of people feel like their social inhibitions are less. I've heard guys say, well, they can talk to girls better, meet people better, a little more comfortable. They have less stress, a little less social awkwardness. They feel comfortable. They also cause decreased inhibitions. They often will do things that they wouldn't normally do, or say things they wouldn't normally say, or use other drugs that they normally wouldn't use just because they have that. But when those things are starting early on, they're still looking forward to their next use. They're thinking about it. And then as it progresses, they're planning, they're thinking about it, even when they're not using. So when it gets to be a little bit dependent and they're using drugs, then not knowing it, but they're actually using it as a medicine to cope with their feeling state, now they start to be thinking about it more and more and more. They're planning about it. They're I'll call perseveration. They're just thinking about it over and over and over. Can't wait till the next use. And they change their social situation. They find friends that are using too, so their use won't look abnormal. They kind of stay away from a little bit people that are sober who are not using, or at least who are not abusing, because that's not a comfortable situation for them, because they are finding that they need the drug and end up depending on the use to assist with those uncomfortable feelings. And then the negative side effects come. They promise themselves their change. It's harder to do it. Their behavior becomes more damaging to their self or to other people that they really care about. And what they find is their behavior is no longer consistent with their core values. So they say, I value my health. I value my studies. I value my job. I value my family. I value my relationships. I value sleep. I value being my best self. But they find that what they're doing with their substance abuse is taking away from every one of those core values. It's preventing them from being who they really could be. When that happens and they promise themselves their change and they don't, that 1 out of 7, well, they start to question their self-worth. There must be something wrong with me. I must not be smart enough or strong enough, or maybe I'm not morally good enough. And they start having significant self-doubt. And what you need to understand about substance abuse disorder, it's and especially dependence, it's a shame-based disease. Everybody who has addiction is very ashamed and feels guilty over what they're doing. They know it's not their best self. They know they shouldn't do it. They know they've got problems from it, but they just can't stop. And so they feel ashamed. They don't want anybody else to know what's going on. And because of that, they're more stressed. And when that stress increases, you see greater fear, you see greater anger, hostility, irritability, overreaction to things, the volcano eruption over little things that should be little things, but they're big things. And in order to continue what they're doing, they hide their use, they sneak things, they start lying, cheating, stealing, isolating, doing other risky behaviors. All those things are part and parcel of the person who's progressing down that addictive, slippery slope. They end up in a fear-based state. They have often panic attacks. In fact, I found clinically that if somebody comes in with a first complaint of panic attacks, there's a really good chance that those persons are abusing alcohol, because it's amazing to me how many people have panic attacks, but when they stop drinking, those panic attacks just go away. But they've often been prescribed benzodiazepines or Xanax or something, going to the doctor because they're panic attacks. They're treating the symptom of the addiction or the use, but they're not treating the root cause. Because when you stop the alcohol, then oftentimes the panic attacks just go away. And along with that, especially with other drugs like methamphetamine or cocaine, paranoia comes involved. All kinds of health complications from cardiac to sleep to weight to self-care, all those things are impacted. And in order to continue their use, addicts will always do three things, because if they don't do these three things, they're not really able to continue what they're doing and needing to do, which is use the drug to escape their feelings. They deny that their behavior is causing as big of a problem as it is for themselves or for anybody else. They rationalize why they're doing it, and they minimize how much of it they do. And as long as they can keep those three lies in the air, they got like a house of cards waiting to crash down. But as long as they can keep rationalizing, denying, and minimizing, they don't really have to admit the truth, and they can fool themselves into thinking that they're okay. They're not really having a problem. They don't need to change. And along with that, decreased self-care, they withdraw from usually pleasurable activities. They stop doing things they're normally doing a lot. They stop sports. They stop socializing. Normally with friends and family, things that they would do, they just back off, or they don't show up, or they show up late, or they leave early. More fear, more emotional pain, more anger, more blaming. They find themselves inability to have really meaningful, transparent relationships. What we see is what happens is that they just find they need to keep other people away from them because they know what they're doing and how they're feeling is not normal and it's not healthy. They know they're causing it by their choices of behavior, and they don't want anybody else to see inside the tent. So they create a wall around themselves to keep themselves safe. It's like a little brick wall around me, and you can't get inside that wall. You can talk to me about anything you want to talk to me about. We can talk about the football scores, the baseball scores, or other people, what they did last night. Talk about work. We can talk about jobs. We can talk about you, but we're not going to talk about what I'm feeling. We're not going to talk about where I'm at with my feelings. We're not going to talk about what I'm not comfortable with. And we're not going to talk about my pain, because that's dangerous. My fear is that if you got inside my wall and you really understood what I was feeling, that you'd judge me and you'd reject me. And unfortunately, I've already rejected and judged myself, and I can't take the thought of you rejecting me too. So it's a very isolated, lonely, painful place to be. And it's something that's very, very difficult, and they don't want to ever be disliked. And their biggest fear is if you take away their drug, if they admit what's going on, they're not going to be able to use their drug anymore. And then they don't know how to cope, because that's all they've learned in the last years to handle their problems. And if you take that away, they're afraid that they're not going to be in control anymore, and they're going to lose control. And that's a very, very scary thought. They've tried too many times to stop and not been able to do it. So they really feel like they can't stop, and there's no help to change. So it ends up feeling for that person, they have two thoughts: either I'm perfect or I'm worthless. And I know I'm not perfect, so I must be worthless. There's very little shades of gray in the addictive mind. And they're very much afraid for other people to see their imperfections, because again, they feel like if you see my imperfections, you're going to judge me and reject me. That's painful for me to consider. If I'm an addict, I can have a great deal, and I will have a great deal of empathy for others. Most addicts would give other people the shirt off their backs. They frequently, their families bring them in. They say they're the kindest person. They do anything for anybody, but they won't let anybody help them. That's because they know pain. They know what it feels like to be in trouble. They know what it feels like to be afraid, to be concerned, to be alone, to be doubting yourself. They recognize those feelings easily in other people, and they don't want other people to go through that just like they're going through it. So they would do anything to help other people, but they won't let anybody help them. That's the way it is. And this has nothing to do, you have to understand, with their intelligence. In fact, some studies show that the average addict is several IQ points higher than the normative person. So this isn't about intelligence. It's not about moral character. It's not about how good you are, how good your core is, what your core values are. This is about how the drug is affecting your brain. If you try to discuss these things with somebody, what happens in family dynamics, let's say a husband and wife, the husband comes home and he's drinking. The wife will say, you shouldn't have done that. You drank too much. You came home too late. I don't know where you were, you're driving while you're drinking, that wasn't good, or we were socially event and you fell asleep with face in the mashed potatoes and dinner. That's not good. And the husband says, you're right. That's not right. I won't do that anymore. I'm sorry. That was just a one-time thing. I'll take care of that. The next time they do it, the wife says a little bit stronger, and he says, I know I can do it. Don't worry, I can do this. And the third time, he gets upset. He doesn't want to be reminded anymore about it. And he responds overtly with anger and hostility and resentment and even violence, threats, whatever, because he knows he can't change. And so he's only got two options. One is to react by retaliating. Well, I'll blame you. It's your my if you weren't such a jerk, I wouldn't have to drink so much. Or by just isolating and staying away and escaping the discussion altogether. That's where it goes. And it ends up where it's been a problem for long enough. We've tried to solve it. We've not solved it. We can't talk about it because it just creates emotional distress. So we talk about other things. We talk about the fact that you didn't make your bed, or, you came home and, you didn't kiss me when you came home, or whatever it might be. We'll talk about everything else, but we're not going to mention anymore your drug use or your alcohol use, because we've tried that, and that just gets us nowhere. It just gets us into more problems. So that's where it gets to be the elephant in the room. It's the biggest problem of everything that's wrong with your life. It affects your job, your work, your mentation, your health, self-esteem, your mood, your sleep, your weight. It affects everything about your life. And we can talk about all those effects, but it's really hard to talk about what's causing those effects, because the emotional burden that creates for everybody. That's the elephant in the room. That's what makes it tough. And when people come in and they finally admit the truth, when they're finally at the point where, I just can't take it anymore, doc, I need some help, this is what they say. Every time I feel stressed or depressed or angry or whatever it is, I've learned to escape from those feelings by using my drug, right? But now it's not working anymore. Now I only use to escape how horrible I feel when I'm not using. And the highs are long gone, but every time I use, I just think it's going to happen. I'll be okay again, but it never turns out that way. And the truth is, doc, they say it's been so long since I've been in touch with my feeling state that I don't even know who I am anymore. I'm embarrassed. I'm ashamed. I feel guilty. I hate myself. And they'll say that. They'll say, the truth is, doctor, I hate myself. I'm unlovable, and I don't think anybody could love me, and nobody could even understand the way my brain is torturing me, and the way it's making me feel. And I don't know what to do, but I don't have any hope. And that's the way that the end result looks before people are often willing to get treatment. So now I want to tell you why that is. It seems crazy, right? You think, why? Well, why don't you just pull yourself up by your bootstraps and stop that stuff? You see what's going on. You see the problems it's causing. Why don't you just stop? Well, people can't. And the reason they can't is because of what I'm going to show you now. About 1 out of 7 people, 13 to 14% of the population, has addiction. And addiction is primarily genetic. And what we're finding now in the research, there's many genes, multiple, probably over 15 genes now are being studied with their effects in addictive behaviors. And it turns out that different genes can code for tendency to be addictive with different types of drugs. So some code for more response to alcohol, some to more response with amphetamines or stimulants, some for painkillers. So it's involved in the brain. We don't really understand all the whys, but we know the brain is very sophisticated and it's incredibly important. The brain is not simple. One of the founders of the double-stranded helix, DNA, the secret to the replication of life, said that the brain is the most complex entity ever discovered in the entire universe. I think that's probably right. Here is a picture of the brain. This is called the Glass Brain Project. It was done up at UC San Francisco, and it shows they've coded different neurons colored different colors. And you'll see this brain turn around, and while this person is turning around, they're blinking their eyes open and shut, and they're moving their hand and finger, just one finger like this. That's all the activity that's taking place. But look at the brain the activity that's going on with these nerves firing back and forth. I was talking one time with a brain scientist who actually won a Nobel Prize for a study with the brain. And I said, tell me about the brain. Tell me about these neurons in the brain. I said, I've learned that there's 50 billion neurons in our brains. And I've just read a recent article that said 100 billion neurons. How many are there really? And he kind of laughed at me. He kind of smiled. He says, well, nobody's ever actually counted, but it's probably on the order of magnitude of 100 billion neurons. But he said, that's not what's important. I said, okay, what's important? He said, what's important is how many synapses there are. That's the connection between the neurons, because that's where the action is. And I said, okay, how many of those are there? And he told me it was a big number, and I forgot. Now, what this is doing right now, it's focusing in on the brain and what we call the corpus callosum. You see these fibers going sideways here. That's the corpus callosum, is the part of the brain that connects the right hemisphere and the left hemisphere of the brain. But just with that little bit of activity that person was doing, the brain is firing back and forth all kinds of messages, signaling to keep the body safe. So what happens in the brain is we've got all these things going on all the time. We're not even aware of it. So in the brain, we have synapses, we have connections, we have neurons. The neurons are made up of dendrites and axons. The dendrite is the receiving end of the molecule. So if you look at this brain right here, on the right-hand side, you see this thing with all the tentacles sticking out. That's the neuron cell. That's the core of it. But you see all these different tentacles sticking out. It's not like one neuron connects to one other neuron. Neurons are plastic, and they've got all these tentacles that connect with all kinds of other neurons. And they all have a giving end and a receiving end. The receiving end is called the dendrite. The giving end, where it sends messages, that's called the axon. And between the two, you have a synapse. The synapse is the connection between one neuron and the other one. This is called the receptor site, and this is called the neurotransmitter. So the way that one neuron communicates with the other neuron is it has these neurotransmitters made up of amino acids that are sitting on the end of the neuron, the end of the axon. And when the cell becomes stimulated, a little bag of those neurons gets released, and then these neurotransmitters fly around. They find receptor sites on the next neuron ending at receptor sites, and they attach to the receptor site and stimulate the next nerve to fire. So the neurotransmitters communicate from one nerve to the next, and when they do, they cause proteins to be produced, hormones to be made, etc. This controls everything that's important in our body. Our brain signals everything to happen. Nothing happens without the brain doing it. So I said, how many synapses are there? If there's 100 billion nerve cells in the brain, tell me how many synapses there are. And basically what he said was, it's a big number. And he told me, and I actually forgot it. I called one of the, at that time she was the Howard Hughes Research Fellow at the Salk Institute. I said, how many synapses are there in the brain? Because I was giving a medical talk and I wanted to be accurate. She said, not known really, but there's a lot. And I laughed, and she said, probably on the order of magnitude. This was an email, and I will never forget it. She said, probably on the order of magnitude of 10 to the 12th to the 15th power. Well, 10 to the 15th power is 1,000 trillion connections. And then she said, many of which are in a position to be modified by the sequelae, the outcomes of fear, compassion, or loving kindness. I go, ooh. So here's a world-class scientist saying that the way the brain works is it can be modified as plastic, and the neuroplasticity of the brain can be actually changed. It can change the anatomic connections between our brain and the way the brain works based on how we think and how we feel, not just what we do. This was revolutionary, and now we know this is hard science. This is true. We know that we've got about 1,000 trillion connections, and that every time one nerve fires, up to 40,000 other nerves fire in sequence. And if you've read the book Outliers, it talks about what it takes to be world-class in anything, whether it's athletics or art, dance, whatever it might be. And the answer was it takes about 10,000 hours of practice before you can be world-class. What he said in that book was that, interestingly, we think world-class performers are genetically endowed. Well, he said, most of us have the ability genetically to be world-class, but we just don't have that training of 100,000 hours, especially early on in our life, or 10,000 hours, I should say. So what we do know is that neurons that fire together wire together. And every time we do something from 1 to 40,000, we're laying down hard wiring in our brains that stays that way. And then later on, we can go through that pathway without even thinking about it. That's how a concert pianist, when they start playing the piano when they're young, it's hut and peck, right? And it sounds awful. We look at them playing a concert and they're eating a sandwich and waving to the crowd and they're playing Tchaikovsky's whatever. And they're not even thinking about looking at the notes because they've got all those neuromuscular neurons hardwired once they start thinking about that. And that's the way our brains work. And that plays into addiction, which I'll explain to you. So what are these neurotransmitters? We've got a bunch of them that we know about. There's many that we don't even know exactly what they do, but there's some that we've heard of and we know do what they do. Acetylcholine affects motor neurons. So things that affect motor neurons, physical activity, contraction of muscles, those are regulated by motor neurons receiving acetylcholine receptor site stimulation. Dopamine, we know about that, right? Dopamine's the pleasure receptor, but it also not only gives us pleasure and satisfaction, but it activates motivation, it activates memory, it activates healthy sleep. GABA aminobutyric acid, known as GABA, that's now drugs are used. GABA, we use them initially for stopping seizures because they're reducing excitability in the neurons, but it also codes for improving sleep. We can use that as a sleep medication, prescription-wise. It's also an analgesic, so we use it now for nerve pain. So people that have herpetic neuralgia, we use gabapentin as something that helps the nerve pain resolve. Serotonin, we've heard about that. That regulates mood. It regulates happiness. It regulates appetite and cognition and reward. It's a reward system, and it also has a big play in memory for us. Epinephrine and norepinephrine are two stimulant neurotransmitters, and they hit receptor sites that cause us to be more activated. That's what we use for people that have ADHD and so forth. So they get them to focus, we use stimulants. Histamine, that's something that we have, if we have allergies, we have histamines that are more activated. That's what we use antihistamines for, to decrease the allergic reaction. Most of us have now heard about oxytocin. That's the love hormone. When we hug a newborn baby, when a mother and the baby snuggle right after the baby's born, both their oxytocin receptor sites become stimulated, which creates a feeling of trust, of love, of safety, relaxation. And endorphins, we've heard about the runner's high. When we're doing something in long running, for example, that's pain control. If we didn't have endorphins, the runner wouldn't feel very good. He'd have pain because of all the stuff he's doing to his joints. But endorphins increase analgesia. They actually elevate our mood and our overall sense of well-being. So all these neurotransmitters are part and parcel for a healthy, well-being life. What we have to understand is that every drug that affects the brain does so by fooling the brain into thinking that the drug is a natural neurotransmitter. So every drug of abuse, whether it's cocaine, for example, affecting acetylcholine neurons, or cocaine affecting norepinephrine receptor sites, all drugs fool the brain into thinking that they're the normal neurotransmitters, and they act as surrogate neurotransmitters. And that's what's going on. That's how drugs get past the blood-brain barrier, because they look very much like normal drugs. Most things shouldn't get past the blood-brain barrier to get into the brain. But all drugs, whether they're analgesics or sedatives or cocaine, marijuana, hallucinogenics, inhalants, all those things fool the brain because anatomically they look very much like, not exactly like, but very much like neurotransmitters that are supposed to be in our brain. They fool the brain. So what happens when we start using drugs over time? The receptor sites initially, they see something coming in that looks very much like neurotransmitter, but it's not exactly like that. So they actually, anatomical imaging studies from electron microscopes have shown that the receptor sites actually initially, they fit like a lock and key. So here's the neurotransmitter and here's the receptor site like a lock and key. The lock, it fits it exactly, but it didn't exactly fit the surrogate neurotransmitters of the drug. So actually the electron microscopic sections show that the receptor sites actually change their configuration anatomically to more precisely fit the drug to allow the drug to be used, because that's what we're feeding it. So the body tries to accommodate what we ask it to do. So it works nicely, right? Initially. And then with repeated use, we get overstimulation. The brain doesn't like to be overstimulated. We always like to be about the norm. When the brain becomes overstimulated, it wants to downregulate. It wants to not be overstimulated. So now it makes changes so that it won't be hypersensitive. It does that basically initially by decreasing how many neurotransmitters of its own it makes. So our brains stop making the normal amount of neurotransmitters that keep our brain working well, cohesively, like an orchestra. That decreases the stimulation. And when that doesn't work, because we're still using the drug and we still get overstimulated, it tries to downregulate more by actually atrophying receptor sites. So it has less receptor sites. So for example, on the end of a rat that's been addicted to cocaine, there's only 20% as many receptor sites as there are on a normal rat receptor site end of the neuron. They've lost 80% of the receptor sites in an attempt to decrease the ability to be overstimulated. And when that doesn't work, the toxic effects of some drugs is to actually destroy and kill receptor sites. So that explains why more and more causes less and less, because the brain now, we're not getting our own mechanisms working. We just have the outside drug. Before we had both. So we get hypostimulation. And now when we're not using, we feel awful. And that's called anhedonia. Anhedonia is the total loss of enjoyment in life. And that's what happens biochemically once we're in withdrawal. And when we're in withdrawal, we have an increased craving. There's a need to repeat the addictive behavior to get out of that horrible feeling that that creates. And we have a downward spiral of physical, emotional, spiritual, relational bankruptcy. It's just everything is working poorly. So here's what it looks like in a normal neurotransmitter. This is the axon on the top. And on the bottom of the top slide here, this is the receptor site. So the axon has these little amino acid neurotransmitters. The neuron gets stimulated. This bag breaks open. These neurotransmitters fly around and they fit into the receptor sites. When you've used drugs and you're getting tolerance, what happens is you've atrophied receptor sites. So now we don't have 6 anymore. Now we've only got 3, less places to stimulate. So there's down-regulation of the overstimulation. And some drugs cause toxicity to neurons and they actually get killed. So there's no receptor sites at all. So that's why we see tolerance. That's why we see tolerance. And then when we don't have the drug and we don't have our normal receptor sites and we don't have our normal neurons, now we've got tremendous dysphoria, lack of normal mood, and that's what causes the withdrawal. So that explains tolerance and it explains withdrawal, what's really going on. And here's the MRI studies of a control on the left side. All the red dots, this is a PET scan that shows stimulation of the brain. So every red dot here, in the intensity of the red dot, that shows you oxygen and glucose utilization in the brain. This is how much the brain is working. Every one of those red things is increased glucose utilization. Here's a cocaine-addicted brain. It just shuts down. It doesn't have the ability or the need or the desire to be stimulated anymore. It's lost its ability to become normally stimulated. That's the change that you can see. And so you can see what happens when you get down into this side here, what's causing this withdrawal and lack of stimulation. You can't get this big high anymore. This is a biophysical thing. You can't get it. It's just the way it happens with brains. I told you I'd mention a bit about opioid use. Opioid use has, in the last 10 years for sure, 5 years especially, increased. 70,000 people have died from drug use in 2019. 1.6 had an opioid use disorder in the past year. It's a big deal in our country now. You see all these statistics here. It's amazing now how opioids, doctors were convinced by pharmaceutical companies for a while that opioids were safe to use, that we should treat pain until it's gone, that it won't be a problem and long-term opioids are going to be okay. And it's just not the case. 2 billion people used methamphetamine last year. That's a big drug that's hauled across the border. There's 2 main cartels I found that are shipping methamphetamine. Most of it's made in Mexico into the US. And they know that there's going to be deaths from methamphetamine use. And they also know that there's other things. Fentanyl is now being put into the drugs. All these things, that fentanyl is a synthetic opioid. It's way, way more toxic than regular, even methadone and morphine. But they know that, this as an aside, they know there's going to be some deaths, but it doesn't matter to them because a number of people that'll get through and the amount of money they can make on those drugs is amazing. Rather than shipping in big tons of marijuana and things like that, big trucks, they can, in a backpack, they can put 20,000 pills, and their return on investment is very great. So it's a big problem. We're trying to face it now and figure out what to do about it. The problem is somebody's given a 10-day supply of opioid. These are people that do not have cancer. They don't have long-term chronic pain that's unbearable. These are normal people that just have a short-term problem. If you give them the 10-day supply of opioids, 1 in 5, 20% will become long-term users. If you give them a 30-day supply, the CDC shows that the chances of them being on it for a year is 45%, almost half. If you just give them one 30-day supply, you're starting that deal. It's very addictive. Long-acting opioids are even more problematic. So we're trying to be teaching doctors just to use short-term when they need it, and not more than for a couple of days if needed. If people get a second prescription, no matter how many pills were written in the first prescription, it could be just 10 pills. But if they get a second prescription, 1 in 7 were on the drug for at least a year. They'd figure out a way to do it. So the opioid epidemic is really a significant thing. One other thing you should understand is that we talk about drugs with addiction, but the brain has the ability to be addicted by any obsessive compulsive behavior. Remember what that neuroscientist said? Many of those synaptic connections are in a position to be modified by the biosequelae of fear, compassion, or loving kindness, but also by anything else that causes dopamine stimulation in our brain. So alcohol, drugs, sex, gambling, relationships, work addiction, exercise addiction, shopping addiction, food addiction, all these things can actually tap into the brain's neuroplasticity and create addictive lines of behavior, the 1 to 40,000, so that what happens is actually that when people have stress, whatever they do to manage their stress initially, when they're first trying to manage stress as young adults, that becomes remembered and hardwired in the brain. And the next time they have stress, they're going to try and do that very same thing again because they know it worked before. And if that's exercise, you could be an exercise addict. If it's sex, you can become a sex addict. If you found out that being the star athlete was what gave you all your pleasure, then you're going to be obsessive compulsive about being the star athlete. If it's a relationship addiction, you seek one relationship after the next and then they get tolerance to that. So brain changes can occur when the addicted gambler goes all in on the Vegas game table. The neurotransmitter changes and the receptor site stimulation changes are exactly the same as seen in the cocaine addict when they shoot up cocaine IV. And if you have blinders on the imaging radiologists that are looking at the brain scans, they can't tell the difference between the gambling addiction stimulation and the cocaine addict stimulation. It hits the same sites in the brain. Sugar, very addictive. Sugar hits the tongue, and within 2 seconds, it hits the brain receptor sites, gives us pleasure. So sugar is a very, very tough addiction to solve. So what do? We've got somebody who's addicted. They're using or abusing some substance. They're having a problem with it. Here's the model. This has been developed. And how do you have an intervention in that elephant in the room? How do we get past it without having a fight? You own your own feelings. And this is essentially what you say. Go through it. It's very complex, but I'll sort of dumb it down. The first thing you say is, and notice these are all I statements. None of these are you statements. We're not blaming. We're not judging. We're not criticizing. We're saying, I care about you. The reason we're having this discussion is because I care about you. I love you. The next thing we say is, here's what I see. And the subjective things that you've experienced yourself when you're in the presence of the other person. I've experienced you coming in late. I've experienced you falling asleep with your head in the mashed potatoes at dinner. I've experienced you getting into fights. I've experienced whatever it's been that you've seen and observed. I've seen you yell and scream at me when I didn't bring in the trash appropriately. It seems like an overreaction. Whatever it might be that you've seen that seems not right, you can mention that. It's my observations. I know the next thing you say is that you wouldn't intentionally affect me any other way than to be positive. Your intentions have never been negative, but this is what I've seen. And what I'd like you to do is I'd like you to get evaluated, or I'd like you to stop the behavior. I'd like you to get treatment for the behavior. I'd like you to get a consultation about the behavior, because I know that you wouldn't intentionally cause those things for yourself or for anybody else. And if you'll do that, I will be a best part of your team. You know, I've had athletes tell me we're doing intervention to another player, and the guy says, if you'll clean up and not use drugs, I'll be your best buddy. I'll sit on the plane with you. I'll be your best friend. I'll keep your bad druggy friends away. I'll do everything I can do to help you succeed in any way that I can. I will be your partner in recovery. But if you won't, here's where you have to have the boundaries. And this isn't about hurting the other person. This is not punitive. This is taking care of yourself, so you're not letting the other person's effects of behavior affect you adversely. And you're also teaching them to have the consequences of their natural behavior. So there isn't anybody that is an addict, pretty much, that doesn't have enablers along their life's way that allows them to not experience the natural consequences of their choices. So the parents will keep their kid from getting kicked out of school by calling him, tell the teacher he's got a sore throat today, when they know he's just sleeping in it because he's hungover. Or the wife will call in and tell the boss, my husband can't come in today because he's sick. He's not sick, he's hungover. So most people have basically enablers that enable them to continue their abuse. They're trying to be good. Their intentions are to not let the other person hurt. We don't want to see them in pain. So we coddle them and we protect them, and we don't want other people to know what's going on. But setting boundaries is one of the healthiest parts of recovery. This is what I want from you. This is what I'll do to help you. If you won't do that, here's the boundary that I'm going to set, so I'm not a part of the problem any longer. The next thing you say is, I know you can do this. You're worth it. You're better than this. And let's do this together. We can do it. We can succeed. And the reason is because I care about you. So the first thing and the last thing you say is how much you care. It's got to be really honest. It's got to be from the heart. If you trump it up and pretend like it's more than it is, they will see through that in a nanosecond. But a healthy intervention model is a way to own your own feelings, to state the truth, to ask for help, to be part of the offer, being a partner in that help. And then you see where it goes from there. But you can't control other people's choices. You can only choose and control your own behavior and try and be a healthy participant in help. But before asking somebody else to get help, just make sure you're prepared to do the same thing for yourself. Many people will say, well, me, what about you? And so you got to look in the mirror and make sure that we're honest here. And honesty is the key. And statistics show that addicted persons have a far greater chance of succeeding with their families if the families are educated and in recovery too. So families get sick together and families get well together. Joe Persh at Long Beach Naval Hospital, Captain Persh in the military, naval doctor, revolutionized the way we treat addiction. We thought that people had to reach absolute bottom before they were able to or willing to get help. He showed you could order people into treatment, and if you treated everybody the same, you got rid of this feeling of terminal uniqueness. I'm special because I'm an officer. No, you're just Bill. And you're right next to the private Bill over here. That if you surrounded people with a healthy milieu of unconditional love, acceptance, honesty, healthy boundaries, information, healing techniques, etc., the same percentage would be able to get recovery than people who asked for help. So people don't have to be at their absolute bottom. As we say, it's a one-way elevator. You get off any floor you want, but you don't have to go all the way to the bottom, but it's only going down. Addiction untreated only gets worse. It never stays the same. It only progresses, it gets worse. And in recovery, here's what people learn. It starts with surrendering to the truth, letting go of your self-image, getting your ego out of the way, your need to control. People think, I just got to try harder. I know I can do this if I'm just stronger. So I just got to be in more control and suck it up. And I know I can do this. No, that's the absolute last thing they need. What they need to do in recovery is let go of their illusion of control and trust somebody else can help them that knows more about this than they do. Their way hasn't worked. Otherwise, we wouldn't be here having this conversation. So it starts with understanding and being honest about your story. Here's my story. Here's what happened to me. Here's when it happened. Here's how that felt to me. Here's how I handled that. It tells human suffering, and it tells pain, and it tells honesty, and it tells connection or lack of it and need to understand it. But the story is where people can start to heal, when they really have the ability to look in the mirror and have what I call courageous honesty, talking about the truth about me. Here's how I really feel, and here's my fear, and here's where I'm stuck, and here's where I need help. Pascal has had a great quote. He said, in order to recognize the truth, you must first love it. And loving the truth, learning to have the courage to love the truth is a very courageous act. And Carl Rogers, the sort of the godfather of present day therapy, said only after we accept the truth, then can we change. So as long as we're kidding ourselves about what the truth is, we're never going to have a price or choice of changing. We're just going to stay and repeat the same bad habits over and over and over. Recovery involves getting in touch with our feelings. Those feelings, what we've done with addiction is every time we get uncomfortable feelings, we shove them down and we run away from those feelings by going into our addictive behavior. So healing starts with opening up those feelings, getting in touch with them, learning what those feelings are telling you about yourself, and then acting on their behalf. And Edie Eggers, a survivor of Auschwitz who gives talks to psychiatrists, amazing. She says what they've learned with survivors of Auschwitz, the ones who got in touch with feeling state and a purpose for their living are the ones who could survive. But she said there's no healing without feeling. So feeling and getting in touch with feelings, warts and all, is key part to the overall recovery process. Learning to accept help from others. Addicts don't want help from, they want to keep their wall up. They don't want anybody inside. But it starts with getting in touch with the fact that, I need help from others. None of us as smart as all of us, and I can't do this by myself. We say it's the only thing you've got to do. You've got to take the step by yourself of going where you've never gone before to trust other people. You have to do that step alone, but you don't have to do it by yourself, because if you have other people to be with you when you take the step, then you've got a surrounding, loving support system that can help you take that risk. Self-discovery, it's all about in recovery, learning who you are, why you're that person, what's uniquely special about you, and how miraculous you are, how worthy you are, how lovable you are in spite of your warts, and give that forgiveness and self-acceptance to yourself. And then having a disciplined plan for succeeding and being willing to pay the price for success. We say that, cancer has a much worse prognosis potentially, because many forms of cancer, if you're in the lucky group that responds to chemotherapy, maybe you can survive it, but 50% aren't that way. The interesting thing about addiction is you can have pretty much 100% success, even though the outcomes are worse. The outcomes are, nobody really has exact statistics, but well over 50% of people who go to recovery don't stay in recovery, they relapse. And most people who have addictive disease, that 1 in 7, die from the disease, many of them untreated, some complications of the disease. But if you're willing to pay the price, if you're willing just to show up and do what they ask you to do in the recovery programs, you can succeed. You can choose to be in that top 50% who make it. It's just a choice, but it's a courageous choice, and it takes a lot of work, and you have to be serious about it. So we teach people that the truth will set you free. It starts with learning your story, sharing your story, learning the truth, connecting mind, body, having courageous honesty, and then a whole group of things with education and understanding, insight therapy, self-love, learning to forgive other people and yourself, connecting with a community of people that are healthy people. We say you're the average of your 3 best friends. And if your 3 best friends are in recovery or sober or living a healthy life, then much more chances you're going to do that than if your 3 best friends are addicts as well. Having hope for change is critical. Learning the skills to prevent recidivism, relapses. 1 person goes into recovery. Out of the 10 that go into recovery, 3 or 4 or 5 will relapse at some point. Probably 60% of people relapse at some point overall in recovery, but a relapse doesn't mean you're going to fail. And having an action plan for whole body wellness. The bottom line is we look at sobriety as just one important part of wellness. Many people get overboard. They think, my recovery program is the whole deal. Well, it's not the whole deal. It's no more important than nutrition, than exercise, than sleep, than healthy, transparent, intimate relationships, than self-care, self-love, forgiveness, a whole wellness deal. That's why I said it early on in this talk. The keys we learned about what addicts have to do to be well and to stay healthy and stay in recovery, all of us can choose to do to be our optimized self. It's the very thing that addicts do to have really healthy recovery is what all of us could choose to do to optimize our well-being in life, our gratification in life, our meaning and purpose in life, and our satisfaction, as well as our longevity. So that's the key. So it starts with just accepting our humanness. It's okay to have pitfalls, we all do, but being willing to be accountable for my choices, to get help, to give myself love and acceptance, and knowing that it's a lifelong journey, just one step at a time. We're not here for perfection. It's progress, not perfection. And we're striving just to be giving up all hope of a better yesterday, but I know I can be better tomorrow. And that's what I want. Everybody wants hope and everybody wants to be all they can be. You can do that, but you can't do it alone. So help is it. And if you do all those things together, the freedom, the joy, the love, and the peace you have is more than you could ever imagine. It's one of the most wonderful things I've ever been involved in the medical practice of family medicine, just helping see this process happen, helping see people get their whole lives back, and they get their families back, they get their relationships back. And what they can do is amazing in recovery, but they've got to be willing to do that work and to give up trying to control. And oh, by the way, your brain can recover too. The healthy control is on the left. In the middle is this 1 month of abstinence where you see the lighting up of the brain starting again. And after 14 months of abstinence with a methamphetamine disorder, you see this 14-month sober person looks almost the same as this person. But if you're not willing to take that chance and do recovery, there's a whole hundreds of thousands of people in our country that have what's called post-drug impairment syndrome. They have continued their addiction for so long, their brains can never fully recover. They're never going to be normal again, no matter what they do. And oftentimes that's combined with mental illness of other types too, dual diagnosis, we call it. But with good recovery, people can recover and your brain can recover. And all those changes I talked about, they can all turn back to normal for most people. It's a family disease. And remember that families heal together and families get sick together. So unless the family, though, gets well, it's really hard to take somebody who's been treated and now they're talking and moving and discussing things and thinking normally. You put them back into a complex, dysfunctional environment of their family that didn't get treated. It's easier for them to go right back to their old behavior than it was to put up with this family that's totally dysfunctional. So everybody has to get well together. Everybody has to heal together. And if we do, then we can all do it. So it takes everybody being honest, everybody having respect for each other. Remember that honesty is the highest form of intimacy. And in a healthy family, there's no secrets. There's just help and honest. And I'm going to help you, you help me. Together, we're more than either one of us can be by alone. And all of us have tough love. We're not enabling each other. We're just giving each other information. We're promising to be a healthy partner for each other in our total success. So remember, enablers are addicted to the addict. The addict is addicted to their addiction. So we all have to recognize that, recognize what our parts are in, and improve. Different people in the family, these are the roles that people play in the dysfunctional addicted family. One person's the caretaker. That's the person that is preventing, this is the big enabler, the person that prevents them from, it's okay, you're going to be all right. We'll just put you to bed and we'll do better tomorrow. This is the person who's in bed. Then the hero is the one who, this is the kid who gets straight A's and he's the captain of the football team or the cheerleader or whatever it is, the A student. This is the one that's proving that they're worthy. They didn't get that self-esteem at home. They're going to prove it by showing everybody how good they are, how perfect they can be, so nobody thinks that they've got a problem. This is the person that's the scapegoat. This is the one that acts out, the other kid who gets on drugs. So if you're going to do that, I'm going to do this. And they try and distract the attention from the addict by drawing attention to themselves, mostly with dysfunctional behavior. This is the kid that just taps out. This is the one that they shut down all feelings themselves because it's too painful to be home. So they just repress all their feelings, don't talk to anybody. They keep it all inside, terribly alone, terribly afraid, nervous, totally dysfunctional, has no good relationships because they've never learned to have them, and they think it's all their fault. And this is the kid that just wants to keep everybody happy and smiling. They're the class clown. They just, if everybody just keep everybody laughing enough, then it won't be so serious around here and nobody will hate me as much. That's all the roles people play, all in adapting to this dysfunctional family addiction situation. So we can all get help. None of us is as smart as all of us. There's organizations in the country that are pretty much for every kind of addictive behavior. And the key is to take advantage of what you know, to spread the word, to have this be a discussable thing so people can talk about what they're going through, not something they have to hide, to get rid of the social stigma of addiction. We think of addicts typically socially as undesirable, as not very smart, as losers, etc. This is the disease process. We say when opportunity meets genetics, we have addiction. But once they're addicted, until they've got treatment and education about it and support for it, they can't make healthy choices. They don't even know what the healthy choices are. They're just trying to be happy like we all are. So I hope this gives you a broad stroke understanding of the nature of addiction, how effective it is in terms of how 1 out of 7, 13 to 14% of the population, it's everywhere. Once you start to recognize it, you see how many people it's affecting. And the ripple effect of recovery is huge. So please be part of the recovery system, not a part of the problem. Thanks very much. I'll look forward to answering questions.
How long have I known you? 50, 60 years? No, I mean, I've probably known you 20 years or so, right? I mean,
About right.
and I get to talk to you privately all the time. I always tell people that if I had to name doctors who are my top 3 to 5 friends that I talk to on a regular basis or I lean on, you're always in that top 5. But you know, the funny thing is I hear you on the phone and I see you, but I don't get to see what you do like that. So it's incredibly impressive. And there's so much there that when we talked yesterday, I thought we would just do a really short Q&A. Then we would take a break because just to absorb that is intense. And then in a couple months or who knows, a couple of weeks, we're going to do a part 2 where Alex and the team collects some of the most common questions on addiction, how, when, where, what to do. And then we'll come back and just ask you the questions so the audience will really take over the role as moderator, not me. So I want to tell you why I'm sort of at a loss of words and not many signs after doing this for 15 years or so. I'm at a loss of words because after 30 years of being a part of advocacy groups, all sorts of advocacy groups, I always found it interesting that we never really touched upon addiction. We don't really say the word. We just kind of let other people handle it. And you sort of broke the mold here, the ice, because you're the first person that I know in a long time that covers not only a men's health area, but we also have a lot of cancer patients who's actually talking about addiction. So I just want to thank you for that because it makes me think we probably should have done this 10 years ago, but at least we did it, right? That's better than nothing. I want to talk about I just want to talk about briefly the physiology of it, if you could just repeat it, because I've looked at a couple of books. You know, they call our generation the self-medication generation, even though I think that's every generation now, because like you said, it affects all ages, right?
Right.
Search and there's this philosophy from a lot of books. I read one from Stanford and other places. People get dopamine depleted. There's just a search for more and more dopamine. So can you re-explain that? Because I'm going to give you my personal quick story, and I've told you this probably 20 times. I'm so sick of putting you to sleep on this. In college, a bunch of us got addicted to smokeless tobacco to stay up late and study. And I thought, okay, I didn't like coffee. I didn't like caffeine. I'll be fine. I'll just quit it after I graduate. And I told you the story of it took me, can't even tell you how long, how many times I would throw it in the trash and then I'd go dig at the bottom of the trash to find it. And I began to realize that I don't even know what I'm doing here. Addiction is so strong. So again, can you repeat? Because what's happening is these chemicals are putting our foot down on the gas pedal all the way to the bottom, right? I mean, the desire is so great. Can you go back over the physiology in your mind of why it's just so hard to quit?
We're all dopamine seeking humans, right? It's just natural. Right. We want to feel good. And so when we do anything that stimulates dopamine receptor sites, remember, there's what I didn't say, and this is good information, I think, to think about. The brain has several parts that are very important to understand. You have 2 areas of the brain that store memory. One is the hippocampus. That stores factual memory, like what's your phone number when I want to call you or text you, that's your email address. The words to the Star-Spangled Banner, unless I'm singing in front of a crowd, then I'll forget them. But that's hippocampal memory. The amygdala is the area in our brain that stores emotional memory. And anything in our life, especially when we're young, that affects us emotionally in any significant way is hardwired memory in the amygdala. And that is associated then if it's either a good memory or a bad memory. That could be somebody abuses me, somebody shames me, somebody makes me feel badly about myself, or I win the contest. You know, I do something that just makes me feel great. Those extreme feelings are remembered in the amygdala. And everything associated with that act, that event, is also stored there along with it. That's that memory. And so in the future, once it's there, it's hardwired. Anything in the rest of my life that reminds me of that same feeling sucks me right back into that memory of what was going on when that first thing happened. So if I really felt like I told you that when you see that big euphoric state that goes up over the first use, addicts, turns out what we did say before is important to understand too. The difference between the addicted brain, the person who's going to become addicted, and the normal brain, the person who's not likely to be addicted, is that the addictive brain is genetically already a little bit dysphoric. There's something that's wrong in that brain. When I talk to people, I say, well, when did you first use? Well, I first started using when I was 11 years old, but I never felt good before that. And they have a hard time describing it exactly, but they talk about it like an angst. I felt this little angst in my brain. And when I used the drug, that angst went away. You know, those voices in my head, always the good bird, the bad bird, talking to me on both sides of my head. I felt at peace. And I'll never forget that first piece. That's that first cocaine addicts is the cocaine high. They never forget that first high. That's what normal people feel often, but addicts never felt that at all. So when they feel that from whatever it is they do, whether it's from sex or from drugs or rock and roll, whatever it is, they'll tend to repeat that behavior because they want to get that feeling again. And when you repeat that behavior over and over and over, especially with drugs, it supersaturates your receptor sites. See, normally not all of your receptor sites are stimulated. Some are in recovery mode. But when you take in a drug, you're not back. When you're just living life normally and your dopamine receptor sites are stimulated, they're stimulated because it's something you've done, something that needs it, it's an appropriate stimulation. And then the other thing that's important to understand is that when neurotransmitters are released, they hit the receptor site, they stimulate it, and then the receptor site lets them go. They go back to the nerve they came from, they get repurposed, and then they can come back again for another stimulation. So the percentage of receptor site stimulation and the degree of stimulation is very about a normal mean in the normal person. When you use a drug, you're not doing a dosed amount that's therapeutic that your own body would give you. You're giving a saturated amount. You're totally saturating all your receptor sites. And that's why you've got that tremendous euphoric stimulation way above what you normally would feel. And then if you repeat that, your brain doesn't want to be overstimulated. Our brains always in our bodies always want to return to normalcy. And we like about a median, up and down, up and down. And so if we're tremendously frequently overstimulating our brain changes its anatomy, it changes its own receptor site production, it changes the number of receptor sites available to always try and down-regulate that tremendous overstimulation to be normal again. But the trouble is then when you stop the drug, now you don't have the drug or your normal chemicals or normal anatomy, and now you're feeling awful. And that's when that rat study, that's when you're feeling that awful, that's when you'll do anything that your amygdala remembers that you did to get you out of that horrible feeling. And that's the cycle.
You know, withdrawal, they call it detox, right?
Yeah.
I used to, again, this is where I feel like an idiot when it comes to this topic because solutions apart from cold turkey, I used to think in the old days being, I feel like that was a couple of years ago, you'd say, oh, just go cold turkey. And then I just think about, can you explain that? I mean, physiologically, the withdrawal symptoms, people need to understand that if you've ever been really addicted, and how many times have you seen it? If you're not handled appropriately during withdrawal, you can go into things like seizures. You can actually be hospitalized. In some people, it can actually, the withdrawal effect can cause death. Can you talk about this idea? I still think we're a society where cold turkey seems to be, yay, good for you. You quit it. And I'm going, I don't know about that anymore. I think unless people are surrounded by help, even medicinally, behaviorally, I don't know how they overcome a serious addiction.
Well, that's very true. And it depends on the drug and it depends on the degree of addiction and what
Yeah.
you're trying to withdraw from. But statistically, smoking is a good example. The most successful means over and over in studies of quitting tobacco is quitting cold turkey. And the same with sugar addiction. It's easier. People will tell you all the time, they tell me they're trying to lose weight. It's easier for me, they say, to just stop eating all sweets than it is for me just to mitigate it. Just have a little bit, I'll cut down. I'll just have one here or there. Because the minute they have one, their brain kicks into that high gear again, the memory, and it wants more.
Yeah.
And so cold turkey, when you're going to be sober and in recovery, you have to be abstinent. And in abstinence, especially early abstinence, there is withdrawal. If it's heavy withdrawal, now most drugs, luckily, people don't need to be in the tank for withdrawal on heavy medication to allow them to physiologically survive it. Most people, if they're surrounded with a good enough milieu of people and support and caring and exercise and nutrition and sleep and so forth, maybe they need some medication to help them sleep, but they don't need to be medicated so they don't have seizures and things like that. But if somebody's into heroin or they're into really bad alcohol addiction where they're really drinking a lot of volume, then they do need to be medicated in withdrawal so that physiologically they're at least safe. But the key thing you said is support, friendship, connection, people around you that can help you succeed and know you can succeed. People don't want to be alone, and they've rarely reached out for help, and they really need help. That's why the AA programs and the sponsor programs, you've always got help, a connection, because connection is what helps you through it.
Do interventions still work? And so if people watching this want to do an intervention with somebody, I mean, do you give any sort of simplistic advice? Do they talk to their doctor who might be a specialist? Because an intervention, is played on TV all the time in comedies and drama. And I don't, how does someone even go about that if they want to intercede or intervene that way? Do you have any tips for conducting or an intervention?
I do. Interventions are hard. For some people, it's the only way you can do it. And everybody has tried the other methods. And we talk about interventions. It's not black and white. It's grayscale. You can go one-on-one, put your arm around them, have a little intervention just with a quiet conversation. And if that doesn't do it, sometimes it's a little bit more. And I do. Some people, at times they bring people in here saying, talk to the doctor, see if he's got a solution for you, because they don't want to take the heat for being the intervener.
Yeah.
So they let me do it. So if you're going to do an intervention, if somebody is really down that path where you've tried everything else and they really need to have a come to Jesus meeting, so to speak, in that kind of an intervention that's really serious, it needs to be professionally done. It needs to be thought out. It needs to be planned. It needs to be rehearsed. Everybody needs to be a part of it. The trouble with intervention that is not done well is it can blow up in your face and you'll be worse off than you ever were before. Because don't do it well. In a really well done intervention, I'll tell you the reason why they work. I told you that the addict is totally devoid of their feeling state, right? And their biggest assumption is that if you really knew what was going on in my head and how crazy my thoughts are and what I'm doing to handle those thoughts and how self-destructive I am, you would judge me, you'd reject me, and you'd get me out of your life. You'd think I was nuts. And I would never think that you would really understand me. And I really believe that I'm unlovable. I don't love myself. I don't believe you can love me. So when they're surrounded, and they think also it's the secret that nobody knows. And we say it's kiddingly, we say it's the secret that everybody knows. Everybody sees their behavior, but they think they're hiding it from everybody, right? They keep this person away from that person. They control everything in their life. So their addiction is secret, they think. They don't realize that everybody's watching their choices of behaviors and inconsistencies and all that. So their assumption is that if everybody knew or anybody knew that I care about and love what I'm doing and what I'm thinking, that they would judge me and I'd be out of their life. And an intervention surrounds them with everybody in their life that's meaningful. Every very close, intimate friend is there. And not only do they know, but they love me in spite of it. And the thought that you see what I'm doing, you know I've hurt you, and you know what I've done to this person and that person, you know my behavior has caused all these problems, and you still love me, that thought is emotionally overpowering for people. And they go, wow. And they just break down and they go, gosh, I'm so sorry. if you'll love me, if you'll be with me, maybe I'll be able to risk it. Okay, I will. My way hasn't helped. I'm in bad pain and I need your help. I just never thought I could have it. And if you know my truth and you still love me, that's overwhelming for me. And it breaks down my emotional barrier and lets you inside that tent. And now we can hug and maybe go together and try again. That's the
No, it's incredible. But so what do you tell? Because we always, it's like in medicine, it's what the person's going through personally, and then there's all the people affected by that behavior. Where do you when you talk to some of these families and couples, where do they go just to get help, regardless if you're successful or not in your intervention or helping the person? If I was helping a friend and I was constantly involved, and there's a certain exhaustion with it, where would I go for help?
Yeah, it's a good point. And the reality, in the best of cases, they have family weeks. And the families, the addict goes to the recovery program. The family goes to the family program. And in the family program, it's sometimes because of insurance, it's changed now, but typically in a family program, the family goes through a sort of a condensed version of everything the addict's going through. They go it through for themselves. I'll tell you the truth. I'll tell you my own secret. You were vulnerable. I'll tell you my wife is in recovery. She's my star. She's been in recovery now for I think almost 40 years now. So I went through, and she went through the Betty Ford Center. Joe Kirsch, who started the program at Long Beach Naval Hospital, he's the one who treated Betty Ford, and then she went ahead and started her center based on his teachings. So I went to the Betty Ford Center for my wife. And what I learned at the Betty Ford Center was, what about me? What was my part in it? And what can I do to be most healthy? And the thing that we have to learn is that the thing that the family members can do that most helps and encourages the person that we're pointing it to as the addict, the thing I can do to help you the most is if I take care of me the most helpful way that I can about me. If I become the best me and I let you become the best you, I'm not trying to control you anymore. I'm not blaming you or judging you or shaming you or whatever. I'm just trying to be all I can be in love of you and try to be helpful for you. Then I'm allowing you to be who you are in my presence. And so in healthy recovery, family members look in the mirror themselves and go, what's my part in this? How could I show up in the most healthy way? How can I model and demonstrate healthy behavior when I'm stressed? And how can I help you when you're stressed? And together, maybe we can be more than either of us can be alone. So it stops the judgment and the blame. And the forgiveness is huge, because the resentment and the pain caused by addictive behavior in a family system, and it can be family, this can be a company, it can be a team, it's the group. But the resentment and the history of pain and maladaptive stuff is huge. And it's really hard to forget that. Well, people want to be right. You can be right or you can be successful. And here you have to choose to give up all hope for a better yesterday. Yesterday is gone. We can't change that. What we can do is we can pick up today, go forward here hand in hand, and be the best we can today in service of each other.
That's powerful stuff. I mean, it's, they call it compassion fatigue sometimes, in cancer and other places, where I just think all the people that I had friends and other people who dealt with all sorts of issues. And I would watch the people taking care of them. And I would always kind of go, who's taking care of those people taking care of them? And so it's interesting that you say, so for people watching, when they're helping the person who needs help, they have to engage themselves to get help for themselves, right? I mean, that's basically what you're saying. If I'm probably not putting it adequately.
The second victim. The first victim is the one who has the problem. The second person. But remember, we're in this disease, we're all victims. Nobody's trying to screw anybody. Nobody wakes up and say, I'm going to screw your life up today. Nobody wants to be a bad actor. Everybody just wants to be loved. We all just want to be worthy. We want to feel good about ourselves. We want to be loved. We want to be useful. And nobody intends to have it progress to this thing. Based on your point, there's groups, there's Alcohol Anonymous groups for alcoholics. There's Family Anonymous groups for families. There's all kinds of support groups. There's Al-Anon for the person that's the family member of the person that has the narcotic problem. And here's what happens in addiction. People go into group therapy, and you see these TV things and they make jokes about it. But my thought is, if I'm the addict, that nobody could ever understand me, because my thoughts are crazy. My behavior is crazy. I'm in terrible pain. I'm very alone. Nobody's ever felt just like I feel. And if you knew, you'd judge me. They get into a room all of a sudden, and everybody in that room has felt exactly like they felt. And their eyes just go, holy cow, I thought I was alone. And to know that they're not alone and other people have the same thing, then they think, well, maybe it isn't my fault then. Because their theory is, their assumption is it's my fault. I'm a bad person. And the reality is it's got nothing to do with that. It has to do with when genetics meets opportunity, and then the rest is just going to go on autopilot. And when they realize that there's a whole group of people and a nation of people who have felt that way, who have accepted help, who've beat this thing, and they never get over it, it's never cured. It's just we control it. And knee-jerk reaction may always be when it was going to run away from my feelings, but the healthy person has the knee-jerk reaction, but stops a minute, takes a breath, has mindfulness, and decides, okay, I have that feeling, but now what am I going to do with that feeling that is healthy and productive instead of self-destructive behavior that I've done before? And when I don't feel like I can do it by myself, when I'm afraid, who's on my team? Who can I call to ask me to go through it with me?
Well, I think a lot of people watching this will think, okay, wow, he went through the physiology, he went through the impact on family, he went through treatment options. And then I just think of one more question to answer. I don't know how this is a loaded question. I think a lot of people will talk to someone who's gone to some of these centers that cost a lot of money. And I understand some of them cost a lot of money. So what do you tell people who are worried about just the expense of it in this day and age, just paying the basics? I mean, how do you even deal with that? I know it's a big question that probably takes an hour to answer, but how do you talk financial?
We have to do that conversation all the time, right? Because everybody has to deal with that. And it is expensive in those really nice recovery programs. And there's a difference, to be fair, between really good, healthy recovery programs and fly-by-night programs that promise you that you're special. Every addict would like to, we would call it terminal uniqueness. I'm special. I'm not like all those other addicts. I tell people when they go in there, I answer it in another way, but I tell them, don't look for the differences, because everybody wants to see that I'm not like that person. I didn't do that. I didn't lose that. I didn't kill anybody. I didn't hurt. I didn't have a 502, whatever. Don't look for the differences. Look for the sameness. Everybody in that room that's been through this has something of value to give to you if you're humble enough to receive it. Everybody has a message for you. Everybody can be the Buddha in the room. Everybody can be your Buddha or your teacher if you're humble enough to put your ego on the shelf and say, what can I learn from this person? Because our feeling state, the names, the places, the details change, but the feelings and the need of feelings all the same. Great programs are wonderful programs that give great support, great education, great family programs, but there's lots of roads to Rome. The majority, take alcoholism, the great majority of people who got sober and are healthy in recovery did it through AA, not through a program. So you don't have to go to a fancy program. You just have to want to show up. It's nice to be able to go to a program. That's I think the most comprehensive way to do it. But there are outpatient programs. There's intensive outpatient programs, IOPs they call them, that are very helpful. There are AA groups. A lot of people get sober just by going to the group. They go to a group meeting every day. They go to AA meetings every day, sometimes twice a day. People will volunteer to help them. They'll come over to their house. They'll take them to meetings. They'll offer them something to do, food, clothing, and shelter. It's amazing what groups of people who are all suffering want to offer somebody else who's a fellow traveler. And so you have to have the money to go to a big program. If you do, hooray for you. But if you don't let that be the reason why you're still self-defeating your behavior. You can get help if you want it, just by showing up and doing what you can do and asking for help.
So that's interesting. Sometimes cost is not the issue. I mean, sometimes it's just a matter of figuring out the resources. I mean, not financial resources, but
sometimes cost is in the way. If a lot of people with a lot of money, I'm Gucci. I'll go to Malibu and I'll have a really Gucci program there, and they'll give me massages and treat me special. What they need to do is stop thinking they're special. They need to learn that they're not unique. They're not terminally unique. They're not better than anybody else. Their feelings and their need and their pain is the same as yours. And what they need is to learn to take that. That's what Joe Persh found out. You could take your officer label off, Captain John's, and you can be Bill and just be who you are. And that's where healing starts. Just taking your ego aside and just the truth about who you are as a human being, not as some role you play or how you want to be treated by other people or how you want other people to see you.
This was going to be my last slide, so to speak, my last sign, but this is for when the next time we meet, because I like to go through at least some of these individually in terms of their impact and in terms of some treatments, and we can cover some of these. So for example, notice which one I put at the top. Whether it's in cancer, whether it's, these are very traumatic situations, and the problems with alcohol are just stunning. And then there's subtle addiction and there's overt addiction, right? So I want to make sure that I'm not going to just let people know to stay tuned next time. We're going to go through some of these because, for example, some of these are used as medications. For example, some people with cancer will use marijuana for a variety of reasons. But, so doctors aren't as concerned depending on the situation. But then there's the person who gets overexposed and then it runs into havoc. So there's so much subtleties with some of these different compounds that I want to make sure we cover that next time. But I was so excited to talk to you about alcohol to start with today, but I don't think we're going to have the time just because it's just unbelievable the awareness in my life over the past 10 years, how easy it is to get exposed to these. What I've noticed, and this is set up for the next time, I don't know if you've noticed, is that there's just sort of this game going on where the concentration of the component is increased. I don't care if it's caffeine, I don't care if it's tobacco and vaping, some of these alcohols, the concentration gets more and more. And I think about, for example, marijuana. When I was a kid, you're looking at THC levels, a couple percentile. Now, 20, 30, 40%. That has completely changed the addiction game, hasn't it? Because they've concentrated these addictive compounds. That's like ultra processed foods.
Well,
You're concentrating the idea of going after the dopamine quickly. Is that a way to tease it out?
Yeah. I mean, if you look at the good example is marijuana. In the 60s, when marijuana was really introduced with the military veterans coming back from Vietnam, many of them smoking marijuana, the THC content of marijuana was 1%, the average. And when people started to use it, usually by joint, by smoking, sometimes they used pipes, but usually it was smoking. And they would have to smoke several cigarettes, several tokes to get high, to feel anything. Are you feeling it yet? Are you feeling it yet? And it wouldn't. Now, the average concentration is not 1%. It's like 14 to 15%. It's been found as high as 25%.
Okay.
And that's like 1,000 times more concentrated. And now just one puff will get you high. The concentration is way more strong, way more serious. And like you're saying, with vaping and everything else, if a little is good, everybody's thought a lot is better. And so everything has gotten more and more and more and more. We want that quick hit.
We do want that quick hit, and that concentration.
On this. It's all about balance. I have a friend who said, he wrote a book called Health is a Question of Balance. And he told me, he was studying wellness around the world. I said, what do you think true wellness is really about? He said, I think true wellness is nothing more than balance, perspective, and appreciation of life. I think that's everything we're talking about. It all comes back to balance and attitude, kind of. You can do anything, a good thing you can take to extreme. A lot of people who are addicts for alcohol or cocaine, they become exercise addicts when they get out. And unless they run their 6 miles today, their life is ruined. So anything, even a good thing, taken to the extreme can become out of balance and dysfunctional. So I think in sum, this all ought to be really about balance and perspective and understanding yourself as it is, and appreciation for who you are, and having ability to forgive yourself for not being perfect, and joining the communion of saints who all want to be better with each other.
Oh, it's a perfect way to end it. I really appreciate this time. I mean, I just was staring at each slide and reading it and listening. And so, I mean, like I said, I apologize. We're probably 10 years overdue, but at least we did it. And I'll see you for the part 2. But before you go, I wanted to make sure to say thank you sincerely. It makes me think of all the people that I, in friends and my inner circle. So anyway, to shake that off for a second, because it gets very deep. I thought I would give you, at least the PCRI would give you a gift that no one's ever given you before. And you can choose between one of the two or both. So can we bring up the gift that Dr. Rice will be sent in the next week to his office? But there it is. He used to be the team doctor of the San Diego Chargers. So I thought you'd want this cup now to support the Los Angeles Chargers. But if you don't want that cup, I have a better cup for you. Can we bring up the second cup that he can keep if he wants to? There you go. How about that? That's the Jim Harbaugh Los Angeles Chargers cup.
I think you keep both those cups.
Yeah, you got wrong answer, Dr. Rice. Wrong answer. The right answer is you keep them both.
I don't know if you saw the draft. I probably shouldn't say this. Rolf Benirschke was asked. He was a kicker for the Chargers in the San Diego days, and he was asked to announce the draft pick this year's draft for the San Diego Chargers. And he's supposed to say, and this year's pick for the Los Angeles Chargers is, he wouldn't do that. He said, this year's pick for the Chargers is.
Oh, so it still runs deep.
The people that were from San Diego and in San Diego, it still runs deep. Sorry,
man. And Harbaugh had nothing to do with that. He just went where the team was, but so you can't blame him.
Okay, I grew up in LA. I'm a Rams fan.
All right, I'm going to let you go. I know you have to see patients. You're probably running over. I will see you for part 2 when we'll collect. We're going to go over this. We're going to go individually over some of these different things, and then we'll collect the top questions in general that deal with addiction, from how, when, where, what to do, that come from the audience all around the world. And then we'll meet up again just for that Q&A. Thank you. Namaste. Thank you, my good sir.
Thank you. Okay. Pleasure. A pleasure.
Pleasure.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing. And that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
The key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up-to-date all the physicians are.
And they are very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging. I mean, this is not a dull conference. This is, I don't want to use the word entertaining. I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
Thank you, Dr. Rice, and thank you, Dr. Moyad. Now, Dr. Rice shared some resources on the last slide of his talk, and so we're going to link those in the description below to those websites that he mentioned and put them in the comment section, just so you guys have easy access in case you need to reach out to any of the organizations that he mentioned. Now, our next speaker is Dr. Brian Helfand, and he's the chief of the Division of Urology for the North Shore University Health Systems. He's going to be doing a deep dive into BPH and showing really how does BPH work, what are the treatments that are available, and he's going to share about aquablation. He's had a lot of experience in this field. And Dr. Mark Moyad, who is our moderator, is going to have an extended Q&A session with him after his presentation. I hope you find this educational.
Thank you for joining us today. Today I'm going to be talking about advances in surgical therapies for benign prostatic hyperplasia, or BPH. I'm going to go through really what are we talking about when we talk about BPH, or an enlarged prostate, how we commonly evaluate it, and things to think about during that evaluation. What is the national and global burden of BPH? And then how do we actually address this surgically? And what are some of the newer therapies that are out there to address this common disease that impacts most men? And finally, I'm going to focus in on one of the newer therapies and highlight it, a therapy that is called aquablation. As a disclosure, I am on the board and a speaker for ProCept Biorobotics, who is the manufacturer of aquablation. And so to really start this talk, I want to make sure that everyone understands what we're really kind of referring to is that, you know, as men age in particular, there's an increased frequency of lower urinary tract symptoms, meaning that men typically go to the bathroom a lot more frequently, they go urgently, they wake up in the middle of the night, their stream is often slower. And we always blame that, at least historically, on the prostate. But it turns out, just like everything else in this world, that urinary tract symptoms are not just a cause related to an enlarged prostate, or what we call benign prostatic hyperplasia, BPH, is all that same thing. In fact, there are many other causes that contribute to urinary symptoms, meaning you could have a scar tissue within the tube that a man pees out of. His bladder, which is kind of like a big motor, may just be underactive, or sometimes it's overactive. And sometimes many other disease states contribute to the development and overall severity of urinary tract symptoms, specifically diabetes, inflammatory bowel disease, arthritis, inflammation of the prostate, anxiety or depression, fluid intake, the amount of food types that men have, alcohol or caffeine, which are known irritants of the bladder, and other even more novel things like obstructive sleep apnea or sleep disturbance, and neurologic conditions, including Parkinson's disease and multiple sclerosis. So there are so many things that ultimately contribute, and it's our job as physicians to really figure out what is causing or contributing to urinary symptoms, and if it indeed is truly related to an enlarged prostate, or BPH. And just to support some of this, we as a research group and many others, for that matter, have really looked into this kind of question of what are the causes of urinary tract symptoms. And we've looked at large databases. Specifically, there's a data set known as the UK Biobank. So this is a data set that was derived from Britain, and it tracks over 500,000 patients over time for about 15 years. And in that, some men develop BPH symptoms and others don't. And you can have the ability, because we have all of their medical histories for 15 years, to look at if there's associated, kind of diseases. And again, it's not surprising here that many other things contribute to the presence of urinary tract symptoms. That includes diabetes, sleep apnea, anxiety, depression, high blood pressure, coronary artery disease, increased body weight. There's so many things that are ultimately associated with the presence of urinary tract symptoms. And in past years, a lot of these urinary symptoms, we know that there are certain things that are even stronger predictors. So sleep disturbance, right? So we all make the association that, as we sleep, if we aren't good sleepers, we get up and then we have to go to the bathroom. But it turns out that association is even greater, and there are neurologic changes that happen when you're not a good sleeper. So we and others looked many years ago at different data sets, and we found that the degree of urinary symptoms, as measured by what we call a urinary symptom questionnaire, in this case it's the American Urologic Association Symptom Questionnaire, that the changes in sleep abilities, meaning that the worse sleep you have, the more likely you are going to get up overnight. We know that. But interestingly, the more trouble you have sleeping at night, it also impacts a man's daytime symptoms. So it actually tracks quite nicely in saying if you get up in the middle of the night, you're actually during the day more likely to go to the bathroom more frequently, more urgently, with a slower stream, etc. And so again, that's just an example of an associated disease process that we can address to help you control your urinary symptoms better. Of course, urinary symptoms are also associated with many other disease states, and certainly some of my collaborators who I work with at this institution are also interested in this subject. And we found that there is a strong association between the presence of inflammatory diseases and urinary symptoms. And when I'm talking about inflammatory diseases, I'm talking about things like Crohn's disease or ulcerative colitis or rheumatoid arthritis or psoriatic arthritis. These are very kind of common in the population. And the thought being that if you have an inflammatory disease, your immune response is kind of revved up, and that increased inflammation or revved up cycle in your system is also potentially associated with urinary symptoms. So again, we know we can look at large data sets and we can improve and show that yes, if you do have an inflammatory bowel disease or inflammatory process, you are significantly more likely to be diagnosed with urinary symptoms or an enlarged prostate over time. But interestingly, if you are treated with a certain medication, such as TNF-alpha inhibitors, so the most common type that I think most people are familiar with are your Enbrel. So this is, again, a very common drug that is used for a lot of those diseases. And if you're treated with some of these drugs prior to, then you're actually less likely to be diagnosed with BPH or urinary symptoms. So it is one of those where we're studying this over time, and there are, kind of targets here and that we can prevent. And this is, kind of a follow-up study to this, showing that if you are treated with, Enbrel, a TNF-alpha inhibitor, again, a very common medication that's used, if you're given mice these same type of drugs, they're less likely to have an enlarged prostate, and they don't, from a mice perspective, have the same kind of urinary symptoms. Based on this data, we do have an ongoing clinical trial that is now available, that we're actually giving a lot of these drugs prior to any type of intervention to see if this can ultimately improve prospectively urinary symptoms among men. So again, now that we know that there are a lot of other things that are associated with urinary symptoms, including a big prostate, how do we sort through this? Like, what should we do? And there's a lot of potential noise here, right? Everyone walks in the door. Most men have an enlarged prostate. Is that really the cause of their urinary symptoms? Or are there other things that we should be addressing? And that's really when we talk about now the evaluation and testing for patients, the current guidelines really show that you should gather the type of urinary symptoms that they have. You should use, standard questionnaires. The most common standard questionnaire that we use is the International Prostate Symptom Score, or IPSS. Again, this is used all of the time. It's the same as I just mentioned previously as the AUA symptom score. Very, very similar. You can get other tests. You can have men come in the clinic and they can void or pee into a funnel to see how fast their urine goes. You can measure with an ultrasound how well men empty their bladder with what we call a post-void residual. You can look at, the contents of the urine. But again, with this, we always recommend that you should gather the other information. Do they have diabetes? Do they have sleep apnea or sleep disturbance? Do they have inflammatory bowel disease or inflammatory diseases? Because understanding that will help us address these other contributors to urinary symptoms, but that will also help treat men and their urinary symptoms and help identify really their predominant cause of their urinary symptoms. So again, this is now being included in a lot of the guidelines, but it's just highlighting an awareness that there are other things other than an enlarged prostate that contribute to the urinary symptoms. Again, one of the main things or questionnaires that we suggest, meaning the American Urologic Association or the main governing board of urology, is that when you evaluate patients who have urinary symptoms, use a questionnaire. Now, the questionnaire that I just recently highlighted is something known as the IPSS. IPIS would be the kind of funnier name of that, but it is really the International Prostate Symptom Score. No pun intended, that we're really trying to quantify the severity of urinary symptoms among men. Now, this is a historic questionnaire, and I say historic, it hasn't been around forever, but certainly in 1992 is when it was developed and then subsequently validated in large cohorts, and it is a very good questionnaire. It asks all of the questions about how men empty their bladder, how they perceive the frequency of their urination is, or if they start and go or start and stop, if they have urgency, like the sensation that they have to go and they got to go now. If they have a weaker stream, or if they have to strain to void, or how many times a night do they actually get up to go to the washroom. And then in addition, it assesses how bothersome it is, meaning there's a quality of life question. If you had to live the rest of your life the way that your urination is today, how does that ultimately go on to impact you? And that helps us decide, if we really should be intervening, because again, this is not cancer. These type of urinary symptoms are quality of life. So if it's impacting a man's quality of life, then we have potential to intervene. And so this has been the standard questionnaire that has been used, basically what I would say forever. But even though it has been the standard and it is in every single guideline, there are major holes in it. There's no question about incontinence, meaning, hey, sometimes I go to the bathroom and I leak urine. That seems to be actually the most bothersome. That's not captured on this questionnaire. It doesn't say like, hey, after I pee that I have some dribbling, and there's some urine that leaks after I void. And there's certainly no questions about urinary pain, meaning, hey, there are some, conditions that are, kind of painful because I have inflammation of the prostate or something like that. That would be missed on these type of questionnaires. So there's been like a whole void, if you will, of space that we can better help patients if we could characterize them better. Meaning if our questionnaires were better and they really got to the main point and said, hey, you have sleep apnea, so you have a lot of urgency sensation and you leak because of it, that would help us potentially treat you better. And so with that, there has been an effort with a group that I'm also part of, known as the Learn Research Network. And this is a NIH, so a government-sponsored network. It's multi-institutional, so it includes North Shore, but there are many other institutions, including Michigan, including Iowa, including the NIH, including many of the other, kind of large institutions across our country. And we have over time worked together to develop a new and potentially better questionnaire that addresses a lot of the holes that the IPSS questionnaire doesn't currently take into consideration. And so with that, we developed a very patient, user-friendly questionnaire known as the LEARN, because that's the name of our group, Symptom Index 10, and the 10 meaning there are 10 questions that are asked. Again, this asks many of the same questions that the IPSS question asks, but it also includes urge incontinence, meaning I got that urgency and now I leak urine. It asks about stress incontinence. It asks about, dribbling urine, and it certainly asks about pain. And again, we've done a lot of work here and now have published with this and saying that when we've given this to patients, we actually believe that it's a little better. And again, the reason is that we're more completely able to understand what is most bothersome to patients, as well as what are the exact type of symptoms that are there. And as you can see here is that if we plot out the values, so if a man comes in and they fill out both the Learn SI10 questionnaire as well as the IPSS questionnaire, they track pretty well together, meaning that the general shape of this curve goes up at the same rate, meaning the values on one questionnaire are very similar. However, it's not a surprise that those men who typically have the worst urinary symptom scores, as measured by the IPSS, are also the ones that leak the most urine. So again, that also tells us that the questionnaire has a lot more value is because the reason why men are coming into clinic is they start leaking urine, and the old questionnaire didn't even ask about that. And now we have a better clue as to, kind of the reason why they come in. And again, when you look at bother, why guys actually came into the clinic, that bother is also captured by the Learn SI10 and also correlates with the IPSS. And it's no surprise here also that if you look at those kind of pink red dots here, that those are the men who have the worst urinary symptom bother because they are leaking urine. So again, just a novel tool that we have, a questionnaire that better helps us characterize why you're walking in the door and better helping with us. So now that we've gone through all this and we said, yes, we can identify factors that also, just like BPH, contribute to the presence of urinary symptoms, and we have better tools to better help us characterize or understand why men are having these problems and help us, kind of distinguish those men who have urinary symptoms from diabetes versus those men who have an enlarged prostate. What do we do about it? How can we better help treat men? And this is really kind of moving on to the next part of the talk, is to say, what is the real problem with an enlarged prostate or the presence of urinary symptoms related to BPH? Again, it's not cancer. But on the other hand, it is the most common reason why men present to seek urologic care. And when we look at the presence of an enlarged prostate and bothersome urinary symptoms related to that, we know that the presence of BPH increases with increasing age. Meaning that we do know that over 85% of men who are 80 or greater in age years will have, moderate to severe urinary symptoms, bothersome symptoms there. Not all of them are treated, but certainly if you query them and you ask them, a lot of them have those urinary symptoms and potentially should be treated. And so again, we know that the global population, so the population of men around the world is increasing. And certainly in men greater than 9% of men over 65 in 2018 would present with urinary symptoms. And now over 17% of men greater than 65 are going to be seeking care in 2050. And again, when you look at the millions and millions of patients across the world, that burden of urinary symptoms, as shown by this, kind of blue line, is increasing over time, meaning that the burden of urinary symptoms or disease related to BPH is increasing. The problem with that is that that rate is actually increasing faster than any other urologic disease that we know of. Again, that strictly relates to the fact that we're living longer, throughout the world, and we're seeing, because of that longevity, an increased amount of urinary symptoms. And so, with that, if you compare the burden related to an enlarged prostate, that is over 3-fold higher than those with prostate cancer or bladder cancer or kidney stones. So again, do we have the ability to really address it? And that's some of the problem here, is that we really don't. The world estimates that, with this increasing demand, that, we just can't really keep up. And specifically, if you look at the yellow line here, that is a number of urologists. Those are the physician types that are treating men who have an enlarged prostate. And when you look at that, we can really cover about 1% of those men who come in this country with urinary symptoms. The demand of urinary symptoms is far greater than the actual workforce, the urologist number, who are available to treat it. So it is truly an inequity there. And because of that, we have to be smart the way that we treat it. We have to be able to identify this quickly and be able to treat men very efficaciously, so that it's not hey, maybe I'm going to get it right the first time, maybe I'll try a few times to get it right. No, we don't simply have the number of physicians to get it wrong. So we really have to be able to meet that face of the increasing population, because we know that the number of MDs isn't currently suffice. So, as I just said, I don't know if the solution to the treatment is more clinicians. I don't think it's possible to so quickly train more urologists. Certainly, we can talk about more prevention, risk stratification, education. We know, as an example, if you can control the amount of obesity, or you can better control sugar control in diabetics, or you can help or prevent sleep apnea, then potentially you can help with some of that problem overall. I don't know how many new drugs are coming into play. We haven't seen a lot of new drugs recently, but are there more cost-effective treatments? And that's really kind of some of what I'm going to get into with this talk, is to say, if we can do a treatment and we can get it right the first time, and so therefore I don't have to follow you or expect that you're going to have a recurrence of those urinary symptoms or a recurrence of an enlarged prostate, then potentially we can start addressing some of this. And so this gets into what is the efficacy and durability of a lot of the things out there right now. So I didn't yet talk about it, but a lot of the current guidelines always tell men that we should start off when a man comes in with urinary symptoms. Some of our first line treatments, we should consider as physicians offering those patients medications, pharmaceutical drugs that can impact their urinary symptoms in positive ways. And there are several classes of drugs, and we'll talk about some of them. These are alpha adrenergic antagonists. These are drugs like tamsulosin, formerly known as Flomax, or Rapaflo, Silodosin, etc. And so these are good drugs, but in general, if you started off with an IPSS, that score of 25, a higher score indicates that it's more severe urinary symptoms, and you provide someone a drug, you're only going to see about a 7 to 10 point improvement in their urinary symptoms, saying, hey, you're going to feel better. We can give you this drug. You're going to have to take that drug every single day, and you're going to get, some moderate relief of your urinary symptoms. That sounds great, but we can do better. We can definitely do better. And so within the past 5 to 10 years, we've come up with some other type of therapies. These are generally less invasive type therapies that use a clip, or they use they burn a little of the prostate. These are non-resective type of procedures, and they give you a little bit more relief, meaning that you'll get a 10 to 12 point improvement in your urinary symptoms. So, hey, the cool part about a lot of those is that you don't need to be on a medication for the rest of your life. and they do better than a lot of the drug therapies, but they don't totally get you there. And there is some question. What we'll talk about is for non-resective type procedures, these are generally, again, the more minimally invasive type, the durability, their ability to act over time may be in some question. Now, again, if you're treating urinary symptoms and you say, hey, I know these urinary symptoms are because of an enlarged prostate or BPH, then I can also go in and shave part of your prostate down, something we call a resective procedure. These have been the most historic type of procedures used. We know that they are very, very durable. And when we do resective procedures, they have the largest improvement in urinary symptoms. So you can expect that, again, you can expect about a 15 to 20 point improvement if you do a resective procedure. And again, the advantage there is that they tend to be very durable. So again, I think understanding where we are in the current type of therapies we can offer patients and manage patients' expectations and say, hey, I can get you through a little bit with a drug, knowing that there's more that we can do. I can do a little bit more, a non-resective kind of minimally invasive therapy and get you a slightly better type of improvement. Or alternatively, I can go for the roto-rooter, shave your prostate down from the inside, those type of procedures, and get the maximal improvement there. And so to go through those a little bit more individually is, what about medications? Medications, again, are always considered the start of where we begin. Someone comes into your office, they say, hey, I'm bothered by urinary symptoms. I have a weaker stream. I'm getting up in the middle of the night. The kind of gut reaction is, I'm going to give you a drug called tamsulosin. The other name that I historically said was Flomax. And we're going to see, how you do. There are other, kind of forms of therapy there that you can give a 5-alpha reductase inhibitor. These are another class of medication that helps shrink your prostate down. Or you can give them together and get more maximal therapy. The problem with it is if you look at the overall adherence, meaning if you give any patient a medication, whether it's an alpha adrenergic antagonist like Flomax, or whether it's a 5-alpha reductase inhibitor, their overall compliance, the adherence to taking those medications is low. And this, study of, over 200,000 men that were given medications for their enlarged prostate, only 30% of them remained on those medications at 1 year, meaning 70% said, hey, I don't like the way that this is making me feel because of side effects. I don't like that I have to take a medicine every day. Or maybe they said, you know what, I just am not really getting any different relief or benefit from this drug. I'm going to stop it. And again, when you look at this and you look at the long-term use of this, it's just very, very low. And so again, that tells us that maybe medicines are not the answer. And as I just said, is if you're going to treat a man with a therapy, you want to see its efficacy. And again, compared to any surgical therapy, medications do improve your urinary symptoms. That's not in question and has been shown. It's just in general not to the same degree. We're not going to relieve your symptoms to the same degree that we can if we would do surgery. And again, what have a lot of the studies shown us is that no medication is totally benign, and there are side effects there. Kind of a lot of these medicines, whether it's an alpha adrenergic antagonist, so in this case it's doxazosin, or a 5-alpha reductase inhibitor known as finasteride, is the kind of new onset of erectile dysfunction or retrograde ejaculation, meaning that when you orgasm, that you may still have no problem having an erection, but the amount of fluid that comes out is significantly decreased or absent, that's high. It is present in at least 2/3 or more of patients that they will have, these kind of side effects. And again, a lot of these type of side effects are so bothersome that lead to men stopping these medications. And when you really look at this, is that, you know, their overall sexual drive, their ejaculatory function, and their, you know, kind of sexual function is really compromised when you're taking these medicines. So it's one of those where we used to, as urologists, say, you know what, it's fine. We don't have to pay so much attention. It's more important that we focus in on your urinary symptoms. But again, it's no surprise that it has really become called to our attention to say men aren't taking these medicines because they're so concerned over their sexual and erectile function. And they should not be having to choose between, hey, I want to pee, so I should, you know, I should have compromise on my overall satisfaction with my sexual activity. So again, we have all of these different things, right? Is that when we look at this, we have a spectrum here. We can give men medications, and that, well, again, may not be as efficacious in terms of urinary symptoms. You got to take something the rest of your life. They may compromise your sexual function, or they could, you know, have other side effects. On the other hand, there's slightly minimally invasive type therapies that are either baskets or clips or, you know, kind of burns of the prostate that we can do even in the office, that again increase the ability to urinate better, but they may not be as durable. And then on the other hand is you start getting, once we get to the right side here, we get more aggressive in terms of how we're getting rid or shaving down your prostate. And so we can do things like a TURP or transurethral resection of the prostate. And that's where we literally go in with small cameras and we use a cautery device and shave the prostate down. This is one of those that historically was really referred to as the Roto-Rooter, because it went in and shaved that down in the same kind of fashion. It is still considered in today's modern era the gold standard by which things should be compared against, because it has been done for so long and we have so much data that supports its efficacy. But there have been modern versions of this. So you can do a laser procedure to shave your prostate down. You can use a green light laser, which we call photovaporization, or we can use a holmium laser to either ablate that tissue or actually enucleate, carve out that tissue, things that we call HOLEP. There are different things that we'll call aquablation, and on the other hand is that there's even more aggressive surgeries where we can, you know, carve up the entire inside of that prostate using a robot these days, or or using our finger still, and so these are really on the more invasive side, because on the right hand side here is that we got to make incisions into the belly and see the prostate on the inside. So again, there's a whole spectrum of things that we can do. And the more aggressive you are, meaning the more invasive you are, historically, the more likely you were going to have side effects, meaning that you were going to have sexual dysfunction. You could leak urine, but they were in general considered more durable. And on the other hand is if you do kind of a less invasive type procedure, you may not have the same degree of improvement in urinary symptoms, but you don't have that to worry that you're going to have the sexual dysfunction or leak urine, et cetera. So there's a kind of a balance here. And the question is that, you know, is it fair to make patients make this choice, right? Like if you want the ability to urinate better, that you should have to compromise or give up your sexual function? Or we have to say, do you want a durable procedure or not a durable? Do you want to do this many times? And again, understanding the global burden of disease, like, should we offer patients that choice to say, well, we should give you something that only gets you 1 or 2 years of benefit, but in 2 or 3 years, you're going to need another treatment. So there's all these type of questions, and a lot of them are, you know, kind of ethical, but really should be in the hands of the patient in a shared decision making to say, well, do you want a medication? Do you want a minimally invasive procedure? Or do you want a more maximally invasive procedure? Are we the ones choosing, or should it be the patient? So yeah, I'm going to kind of switch gears a little bit here and now talk about, you know, kind of how we are evolving and what is the current landscape of surgical interventions for the treatment of an enlarged prostate. again, as I brought up, is that the Roto-Rooter, what we call the TURP, or the transurethral resection of the prostate, has really always been considered to be the gold standard. That is, again, we do it in the operating room. The patient is asleep, and while they're asleep, we take a camera, go in through the penis into the prostate. We can see the prostate on the inside, and then we use a cautery device and we shave the prostate down, which basically opens up that prostate channel, relieves that blockage, right? Because normal anatomy is that you have a bladder. The bladder then sends urine through the prostate and then out through the tube through the penis. And by shaving that prostate down, it basically gets rid of that obstruction, that tissue growth because of that enlarged prostate. And when you look at the current frequency by which various procedures are being done in this country, you can see that TURP, which is shown in blue here, is the major procedure that continues to be done throughout this country. Certainly, laser surgeries with that green light, which is ironically shown in yellow here. Urolift, which are clips that kind of pin open the prostate. Those are shown in green here. The microwave technology, which historically was used, it's actually shown that it wasn't efficacious. But again, a more minimally invasive procedure has really kind of dropped off the map there. And then there are other players like Resume and HoLEP, which I'll talk about, which are kind of have become more into the scene here. But again, looking at and understanding what are the current available techniques to surgically shave or open up that prostate channel, we have a lot of choices here. But the gold standard TURP continues to be the most utilized here. And so how do things, kind of compare, and what are some of the technologies out there? Let's just talk about stuff. So the prostatic urolift, or the urolift as it's kind of known as short, are technologies more minimally invasive. They don't resect tissue, right? So what they do is that they are placed, these are clips that go in into the patient's prostate, which basically pin it open. So the urolift is done. It can be done in an office setting. It can be done in an operating room or a surgical center. The overall time it takes is about 5 to 10 minutes to do. If a patient is done in the office and the patient is awake, ultimately the urologist will give a numbing or nerve block so that it's not as stimulating or painful of a procedure. They then take a camera, they go through the penis, see the prostate tissue on the inside, they identify where it's kind of pooching out or blocking the prostate channel. And then they take these clips, which are shown in the diagram here, and they pin them into the prostate. They clip it open to enlarge that channel. So at the end of this, again, that there's an opening there that the bladder can squeeze the urine easier through. And again, I give this a lot of props because it is something that really, I think, caused our attention to the importance not only of urinary symptoms, but also the importance of preservation of sexual function. And as you can see here, is that, these are a 5-year data set. So these are men who underwent the urolift, and then they followed them over time here. And as you can see here is that that there was a significant improvement. So the IPSS score dropped from 25 down to about 12 here, about halved it, and followed men over time. And in general, men did very well. And if you look here, the quality of life, patients were bothered, they underwent a urolift, and they stopped having the same degree of bother from their urinary symptoms. This sounds excellent. But over time, there was about a 14% of men in this 5-year trial that needed a retreatment, saying, hey, we got you some initial improvement, but within a short time period, whether it's 12 months, 24 months, there are, men who needed retreatment, and 14% of those men required an additional surgery. So 4% needed, wanted another clip, another UroLift placed. And 9% said, you know what, I'm done with this. I want a more traditional proven procedure. So they went back to the TURP or the green light. And when you look at this in the real world, is that every year that a patient has, after they underwent a UroLift, about 6% of men are treated again, meaning saying, hey, the UroLift was great for a little bit, but or maybe it didn't work at all. So I need some other type of treatment to really improve my urinary symptoms. And again, that somewhat is a problem of saying, hey, we can get you there. We're going to do better than medications, but it may not be that durable. Again, that's really important to understand here, is saying, hey, with the large burden, that we may intentionally use something like the UroLift is a short solution. On the other hand, it may not get men to exactly where we need to be. So again, counseling patients to say that UroLift is a viable option these days, but it just may not take us across that urinary symptom goal that individual patients may have. The other thing that I didn't present here is that UroLift does preserve all aspects of sexual function, meaning that there is no retrograde ejaculation that occurs after UroLift. So again, from a side effect profile, because it's just clips and it's not resecting any tissue, these men do great from sexually. There is another therapy called Resume. Resume is again, a more minimally invasive type procedure. What it does is it, again, uses a camera, evaluates where the prostate tissue is, and then injects. So there's kind of fang-like prongs that come out, and then will inject steam into the prostate. That steam energy, it heats up that tissue and causes that tissue to die or slough. And then those patients, that prostate sloughing tissue, which is now dead after the Resume, will eventually open up, become remodeled, and then the patients will not have those urinary symptoms over time. And again, here is a 5-year trial outcome. So looking at men who have undergone Resume and then been followed up to 5 years. And again, we see the same significant improvement in urinary symptoms. So these men had significant improvements in their bothersome urinary symptoms. Their overall flow rates, how fast they could pee or void, also significantly improved. In their 5-year trial data, about 4% of them were surgically retreated with other therapies, including a TURP or a green light, really within the first 2 years. So again, it's one of those where it is minimally invasive. It's easy to do. And again, it takes about 5 minutes to do in the office. It's just one of those that the durability and effectiveness may not be what a lot of men are choosing to do. Meaning if you try to do, hey, my goal is that I want a one and done procedure. I want to reset the clock to a time when I was 20 where I could really pee with strength and not think about it. This may not be the type of therapy that you're really going for. And again, when you look at the real world, which is separate than any type of study, is these rates of retreatment are often higher. And about 5% of men are retreated on an annual basis after they undergo Resume. So again, it's not that it's wrong to do. It's certainly a viable surgical, minimally invasive therapy. Again, very easy to do, but again, understanding that it may not get you the same type of improving results as a TURP, the gold standard would get you, and it may not be as durable as some of the other procedures. So moving on, as I said, there are other cool things that you can do with lasers. So there is a technology called HOLEP, or holmium laser enucleation of the prostate. This is where a patient is done. Again, it's in an operating room setting, so you cannot do this in the office. You either have to do it in the hospital operating room or in a surgery center where you would be asleep. While you're asleep, the urologist will take a camera, go in, see the prostate, and then use a laser and in big chunks, if you will, of that prostate, carve out all of the inside of that prostate. So I always say that if a prostate is like an orange, this ability is you're going to get rid of all of the juicy part of the orange and leave the peel. Now that juicy part of the orange is then pushed into the bladder, and there's a separate device known as a morcellator that will take the juicy part of the orange and chop it up into little bits, which are then sucked out at the end of the case. This in itself is a very effective procedure because you're getting rid of all of the adenoma, all of the juicy part of the orange, so you're maximally opened up. And again, that should be, you know, kind of a cool way. There's no incisions, and patients do really well. However, we have to understand that this HOLEP technology utilizes a laser, and lasers can be problematic because they impart some of that energy to the residual, the peel of that orange. So remember, because we're only taking out the juicy part, we leave that peel, and that peel stays in the patient. And the problem with that is that because it absorbs that energy, it is associated with a lot, or at least temporarily, a lot of urinary symptoms, meaning, hey, afterwards for several months, if not a year afterwards, that men can have that experience that they have a lot of urgency. I got to go to the bathroom. I got to go now. And many of those men may leak urine. And about 30% of men after this procedure will temporarily have what we call stress incontinence, meaning if they cough or they sneeze, they may have some degree of urinary leakage. Again, most of those patients, about 98% of them, will recover their stress incontinence. But again, it's important to be aware that these may be temporary or in very rare circumstances, permanent side effects that you can have from this procedure. But from an overall urinary symptom standpoint, it is certainly a significant improvement over a lot of the medications and a lot, certainly over most of the more minimally invasive procedures like the Resume or the UroLift, which we just talked previously about. The interesting thing is if you compare HOLEP to the gold standard of TURP, where we use a cautery device versus a laser to shave your prostate down, that, you know, certainly the quality of life is actually in favor of TURP. And again, the reason why is that the cautery device doesn't usually impart a lot of those irritative urinary symptoms, the urgency or the incontinence following the TURP that you do see for the HOLEP. So again, in general, TURP is a little bit easier of a recovery for many men. But on the other hand, there are many advantages that it can be done on anticoagulation, meaning on blood thinners. It's done in truly a minimally invasive fashion. And the durability of HOLEP, I don't think can be argued with, because if you're looking at 5-10-year studies, because you are getting rid of such a large portion of the prostate that you really don't have those type of retreatment rates that I previously just showed you for UroLift or Resume. But if you look at the actual growth or use of HOLEP across this country, it really hasn't increased in the numbers over the past decade. And the reason being is that it's a long procedure to do. It's not easy to do. There are, you know, only a certain number of us urologists who are really trained to do it and do it well. And as such, it's not really meant for the average urologist across this country, in my opinion, because of that there is a steep learning curve. I mean, it's been estimated that urologists will require about 250 cases or more to become competent in it. And so the question is that really a practical procedure to do across this country when we understand the global burden of our population that continues to increase on an everyday basis? I would argue that it's not necessarily going to solve our problem here. And so again, when we look here and things are changing, that we are seeing a increase in the number of minimally invasive procedures over time, including the prostatic urethral lift shown in blue. We are seeing an increase in water vapor therapy, the Resume. We are overall seeing a decrease in TURP. And so what is this ultimately being replaced by? Where are we going to this? What is going to be kind of next on slate here? And so I'm going to kind of really quickly brush over some of the newer concepts here before I really focus in on aquablation here. But there is a technology called Optilume BPH, which is a balloon that basically is blown up intentionally in the prostate, again, done in the operating room. So while it's blown up, the patient doesn't really feel this. And it's blown up, so it actually stretches out the prostate so much that it also causes a tear on the top part of the prostate. And by doing that, after it stretches it out and causes that tear, it releases a chemotherapy, a drug called paclitaxel, which inhibits the kind of normal healing. So as you stretch it out, you don't want it to reform. So this drug is believed that it helps reform that. And when you do this type of stretching, the Optilume, that there is a significant improvement in urinary symptoms, and flow rates, and the amount of men that hold. So it appears to be an effective treatment. I think the long-term outcomes will show, but when we look at, kind of a double-blinded study where guys were either randomized to a sham, so nothing really happened, or an Optilume, is that there is a significant and sustained, at least to 1 year, if not, kind of 2-year data that is showing that the improvement in urinary symptoms is there. And again, with all of these type of more minimally invasive treatments, there really is no change in sexual or erectile dysfunction. So again, that after the procedure is done, when men orgasm, the amount of fluid that comes out is preserved after these more minimally invasive. I did not mention that for HoLEP, it's about 100% of the time, that laser enucleation procedure, that when men orgasm afterwards, they have retrograde ejaculation, meaning that there is no fluid that comes out. There is another therapy that patients may hear about called prostate artery embolization. So this is, again, under the class of more minimally invasive. It's based on the concept that the prostate is fed by, arteries, blood supply, and that if you go and occlude that blood supply specifically to just the patient, that prostate tissue will die because there's no blood supply to it, and that men will ultimately do better. This is considered one of the more controversial types of therapies that's currently out there because it's been tested in somewhat controversial ways. On the other hand, there has been crossover or randomization studies which may show its effectiveness. Again, that we don't have the long-term data on this, but men who do undergo prostate artery embolization do have an improvement in urinary symptoms and quality of life. But we do have to understand and recognize that the results may be variable, meaning that if you have a very large prostate, that you may not be amenable to this. If the blood supply to the prostate isn't ideal, meaning that there are many, many different branches that you would have to occlude to get this, you may not be ideal. And it is also user dependent, meaning that the radiologist, so it's not the urologist who generally do it, it's what we call interventional radiologists, who do this with machines and under X-ray vision, that they, if they have a lot of experience, that it could be better. But again, these are all different factors that may be difficult to control and may influence the outcome. I bring this up because, again, it is one of those that is included in our urology guidelines, but I currently say that it shouldn't be considered the standard or for most patients based on that. But again, when you look at the data, that there is an improvement in urinary symptoms, we still don't know the longevity, how durable this will be over time. There's also a therapy called iTind. And iTind is a newer therapy. It, again, can be done in the office. It can be done in the operating room. It literally takes about, 5 minutes to do the whole thing. You take a camera, you go in, you see the obstruction from the prostate, and instead of blowing up a balloon, you actually leave a nitinol basket, a wire basket in the prostate, which over time kind of stretches out that prostate, makes some incisions over time into that prostate, so that it basically springs it open. And again, this is a very a device that has been studied in the same regard. We don't know its overall durability. We do know that it's more ideal in certain size or shape prostates. If you have a part of your prostate that grows into your bladder, something we call a median lobe, you are not a good candidate for something like iTind. The actual nitinol basket stays in for a total of 5 days before it's removed in the office. Again, it's nice because you can easily place it, but again, we just don't know the durability because it's not removing or resecting any tissue. And again, when you look at the overall improvement, it does improve urinary symptoms. It does improve quality of life. It is, considered an option for many men with BPH. But it is one of those where it may answer some questions because of the fact that that we can do it, and it's so quick to do that we can treat a large number of patients very quickly. I don't know if it's ultimately going to have the same durability, but that may not be the goal of this type of procedure. There are other forms of treatment that are now coming into the space. There are different types of nitinol baskets. One of them is ZenFlow. ZenFlow has just seen its several year outcomes data. Again, this is a more permanent type of basket that sits in the prostate. You can take it out at any time, but it basically serves as a opening, a little pipe, if you will, that keeps that prostate open, that allows that channel to be unblocked. Again, not for very large prostates, but certainly for certain size and shape prostates, this may offer patients a more permanent type of solution to help with their urinary symptoms. Again, just like every other technology I've shown, does improve urinary symptoms as well as quality of life. And there are so many new players in this kind of nitinol basket space. I don't have time to go through all of these, but all of these have the same type of potential to quickly improve urinary symptoms. They can be easily placed in the office or in the operating room, depending on patient preference. And again, their overall use may be limited to certain sizes and shapes, but they are certainly being investigated as patients there. So with this, I really wanted to focus in on one of my, kind of new favorite technologies. This is really highlighting aquablation. Aquablation has now been around for over 7 years when it first received its FDA clearance and approval. And again, the beauty of this is that it really, compared to almost every other technology out there, has the ability to address any size or shape prostate. I really didn't get into this, but a lot of the technologies out there, whether if you have too big of a prostate, or if you have a median lobe or a certain funny shaped prostate, you can't do those technologies because they are just not designed specifically to address it, or they're going to fail because you're leaving that tissue behind. And when you look at this, Aquablation really said, hey, we can have that ability to get rid of a lot of the tissue there. So it is a resective technology. It uses a water jet, a water pick, a high pressure power washer to resect that tissue. And in that way, the results should be very durable. It is done, and I'll explain it on the next slide, under ultrasound imaging in real time. So you can actually watch the technology in action. You can watch that water pick get rid of that tissue. But that real-time visualization allows you to avoid critical structures. Those are the ejaculatory ducts. Those are the things that we value for anterograde sexual function, for normal sexual function, so that after an aquablation procedure, most men, 90% or more, will actually retain their fluid when they orgasm. And again, that's very different than historic, kind of procedures, right? Because you have, on one hand, you have these non-resective procedures. They may not be very durable. They certainly can handle large prostates, but they always preserve their sexual function. On the other hand, historically, when we had TERP or when we did a HOLEP, we got rid of their sexual function. We had maximal durable symptom relief. So was it really fair to make men choose? And Aquablation came into this space and said, hey, we have the ability, we can offer the benefits of a resective procedure, maximum urinary symptom improvement, but we can also preserve your sexual function. So this is really how it works. Again, the aquablation is done in the operating room. So men are asleep, they're not in any pain, they do not feel this procedure. While men are asleep, what we do is that we insert a ultrasound imaging probe. So we can in real time image that prostate tissue, see it on an ultrasound, and then we can make a plan based on that ultrasound. That is why you can do any size or shape prostate, because it can really handle anything. And you're designing that plan, you're personalizing that plan for any size or shape. Afterwards, you take a camera, you go through the penis, you see again the prostate on the inside. And then based on that, there's a water jet that then talks to the plan that you just created based on the ultrasound images. And that the water jet then precisely gets rid of all of that tissue. And then you're done. The procedure itself takes about 35 minutes in total, meaning that by the time you go into the operating room to the time you leave the operating room, that's about 35 minutes. Your plan includes those critical structures. So again, I said is that if you look at the yellow diagram here, it preserves your ejaculatory ducts. It preserves those things that we value the most. It preserves the bladder neck shown in blue, that entrance to the prostate there. So it is really designed in a very fancy way. And if my prostate looks one way and someone else's look another way, we cater that program to every man's prostate size and shape. So it's truly personalized. And again, I said is that it has that ability to identify that critical anatomy. So it gets rid of the obstructing, what we call lateral lobes of the prostate that are pushing in. It preserves that bladder neck, which helps contribute to the preservation of that sexual function. If you have a median lobe, which is shown in number 1 here, and it's protruding into the prostate, it will take care of that water jet, will design it and get rid of that median lobe tissue. Again, it also preserves the veru. That's where the ejaculatory ducts come in. That means that you aren't leaking urine after the procedure. If you cough or you sneeze, we don't have to worry about that. In addition, because it's using a water jet, we're also not only precise in how it goes, but we don't irritate that residual rind of the orange, so to say, because water is not irritating like laser energy. And again, it doesn't make a difference the size or shape, meaning if we did a TERP, that classic procedure that we do, or the HOLEP, that holmium laser enucleation, we do know that the larger your prostate, the longer the surgeon is going to have to be in the operating room and work on you. Because again, the more prostate tissue is there, the more work that was going to have to be done there. Aquablation is virtually agnostic to prostate size, because if you have a small prostate or you have a large prostate, the difference that you're talking is just several minutes that a patient would have to do. So this is data that was captured by the randomized trial. So Aquablation in their Water 1 study, so that involves water, so they cleverly came up with a name, the Water 1 trial, that compared Aquablation to the gold standard. There is no, which is TURP. There is no other technology that right out of the gate went against the gold standard. And they did this, and what they showed is that the TURP, which is shown in orange here, the larger your prostate, the longer that surgeon was going to be in the operating room. But if you look at the blue line, it doesn't make a difference which is the Aquablation line. It didn't make a difference if you had a small 30-gram prostate or you had a large 150-gram prostate. You were essentially in the operating room for around the same amount of time. So again, that makes it kind of agnostic. But when you start thinking about the global burden, you start questioning and say, hey, I can be in and out of the operating room. I can do many of these procedures and around the same time. That may help us treat patients. And again, when you look at the results that are created, it's so impressive. There's a huge defect here. So if you look at the top bar here, you can see here that the white prostate tissue, the lateral lobes are kissing, or they're pressing in. The aquablation is then performed, and you can see that there's a large, big defect that's created here. This defect is sustained for many, many years. Again, we've looked back, and now many have had this over 7 years ago, and this concentric round hole that we intentionally created with the water jet is maintained for many, many years afterwards. And again, just so you don't think, hey, Brian Helfand is just making this all up. This is actually, all of this is based on data that has been accumulated in the literature. Meaning that, again, we talked about the Water 1 study. We talked about the Water 2 study that was larger prostates. There has been real world data. This has now been utilized in over 50,000 patients across the world. And when you look at that, it has significant improvements in urinary symptoms. Again, the Water 1 went against TURP out of the gate. And in that study, in a subset of men, there was significantly improved urinary symptoms compared to the gold standard of TURP. There was a lower risk of complications. Again, 90% of men maintain their ejaculatory function, their sexual function after this treatment. And very few retreatments are performed. When you look now, we generally quote that the retreatment rate is about 0.2 to 0.7% of patients a year. Again, compared to 4 to 7% of men who've undergone either a Resume or a Urolift. So again, we're talking about a very durable, effective type of procedure. Again, I am not going to go through all of the data here, but again, just supporting the fact that it is really an efficacious procedure. It has, because of its efficacy, been included in the American Urologic Association, our Urologic Association guidelines, the European guidelines, the Canadian guidelines, the British guidelines, again, considered to be a very effective treatment strategy. Again, when you look at the results, now just focus in on the blue bars here. After 5 years, it's associated with a 15-point improvement. That's a 69% change from their baseline to improvement. Huge improvement in their urinary symptoms. Huge improvement in quality of life. Huge improvement in uroflow, how fast that urine is flowing through. Almost no ejaculatory dysfunction, 7%. Again, TURP, can be up to 80% of men who have sexual or ejaculatory dysfunction. No risk of erectile dysfunction, and really no risk of leaking urine. Again, going through this, if you look at their overall urinary symptoms, huge and significantly sustained improvement in urinary symptoms in any of the studies that were performed. Huge improvement in the flow, how fast that urine is going. They're not obstructed. And again, if you look at even the large studies of studies in aquablation in large prostates, 150 grams or more, you see a similar improvement there. When I've looked at my experience with aquablation, it equally is reflective of that literature. So I've now done many hundreds of these cases. I have analyzed the first 300 of these cases done. Again, I've treated prostate volumes as low as 20 grams and as big as 535 grams. So huge monster prostates here. The average size that I treat is about 108 grams. Again, that's a very large prostate. About half of them have part of their prostate that it grows into the bladder, that median lobe. And about a third of the patients that I treat present with an inability to pee before the procedure. And almost every single one of them, 99+%, are able to pee after that procedure with extreme ease and an improvement in quality of life. Again, when you look at the overall improvement in urinary symptoms, again, all of these men significantly improve their urinary symptoms, their post-void residual. I'm not showing here, but they have an increase and significant sustained increase in urine flow. About 90 to 92% of them have anterograde, ejaculatory function. But the interesting thing is that, yes, I do see that I am in the operating room when I start getting into monster prostate sizes, slightly longer. But the longest that I typically am in the operating room for any of these procedures is an hour or less. And the average amount of time is about 37 minutes. So it is one of those where this is very efficacious. No one would dream that we can take care of such large prostates, 150 grams or more, in under an hour. There is no other technology that is equipped to handle such size. So again, very efficacious. And none of these men really need retreatment. And certainly their follow-up period. Again, when we look at even case number, this also shows that how easy it is to use for urologists is, if I look at the first 50 cases that I did, shown here, or if I look at, kind of my 250th to 300th case, the average amount of time I'm in the operating room has improved a little bit. We went from 47 minutes down to 42 minutes. So it is one of those where there's not much of a learning curve here. And again, that's really important when we start talking about offering a technology across this country, because you want many patients to get it. You don't want a barrier to say, hey, that urologist needs to learn so many cases before they can actually offer it. So very advantageous there. And again, when you look at the overall size of the prostate, it doesn't really make a difference of how big your prostate is. We're kind of in and out of the room in a very similar amount of time. And so is aquablation the answer? If we look at the largest prostate in Chicago, which I would argue is the Bean structure, which is in downtown Chicago, it may be the answer for many patients. There are very few contraindications that I can come up with, and a very successful procedure. But again, a lot of this decision comes down to shared decision making. So if you're a patient and you're sitting and you're saying, hey, what would be the best therapy for me based on the bother my urinary symptoms, based on the cause of my urinary symptoms, based on the fact that I want to have no pain and I want a one and done procedure, etc. These are the type of conversations that you can have with your patients. And there are actually now, and this is not surprising, there are applications that you can do on the computer to help you even prepare for this. Canada, with some of those urologists up there, came up with a shared decision-making tool to best help understand which may be that most appropriate surgical therapy for you. Again, I think that this initial application is primitive. On the other hand, I think I applaud them because they came up with this, and I think that we'll only start seeing that this type of application and shared decision making will only become more and more. So really kind of here is that in summary is that BPH is an increasingly expensive and it's a common problem. We don't really have any new medication that's been offered in the past 30 years. And as I showed you, is the compliance is overall poor. But there are many alternatives if you would ultimately say, hey, I'm bothered enough that I want to undergo surgery from this. The surgeries are effective. They are way more effective than medications. On the other hand is that you have to need to help choose if you want a durable procedure or if you want something less durable. And so understanding that there are these new technologies out there, but we need to understand their long-term results and what our goals of treatment are. There is a procedure, aquablation, that may ultimately be a one-size-fits-all approach to patients because it can handle any size or shape. It isn't associated with a lot of the historic problems that we saw with sexual dysfunction. But I think the key here will ultimately be shared decision-making. And with that, thank you so much for your time, and certainly always excited to talk about treatments for the prostate.
I mean, I should stand for you. Maybe I will, just a second. It was that good. You know, I know you and I have been friends, but that was even better than your genetics talk that you did not that long ago. I know you can't compare them. It's like comparing an apple to orange, but it was really comprehensive. It was really awesome. And I appreciate that. Thank you very much.
It was my pleasure. It was fun. There's a lot out there. That's a problem.
Well, you did something that not a lot of people often do, because when you and I talked earlier, we said, I want a comprehensive talk. This is a massive subject, but then also talk about what you do at the end. And you talked mostly about the rest of the competition, which is unheard of. So kudos to you, my man. Not only are you looking sharp and your skin right now is smooth and sublime, but overall, this is like, it's a dream comprehensive talk. So thank you. I just want to remind the audience that last time he was here, he talked about genetics. I did ask him the key question: if Michigan played Northwestern in football 100 times, how many times would Michigan win? And he correctly answered that Michigan would win every single time. So we got that out of the way. And for those of you who weren't there last time I talked to him, I thought the name of North Shore Urology was the name of a urology group in Hawaii, and you cleared up that you're not. You're in the Chicago area. So that was another one of my favorite jokes. I don't know how much you enjoyed that. And then I had a couple more, but instead I'm going to ask you one genetics question in prostate cancer, if you don't mind, because let me remind the audience, if you haven't seen Dr. Helfand's talk on genetics that he did essentially not that long ago, it was comprehensive. It was unbelievable. And I thought at the end of the talk, I kind of wish I would have asked him the most obvious question of all. And I wonder if he had a comment on that. And I don't think a lot of people realize this, but this is what comes up a lot. And I've seen it in some of your publications. You know, prostate cancer is one of the most heritable cancers of all the common cancers. So people don't realize how strong the genetic component is to prostate cancer. And I think you helped get that across in your first talk. I don't know if you have anything else to add to that, but you know, it really kind of, every time I read that, Brian, it kind of blows me away that it's so heritable.
It's really kind of the prototype, the example of cancers and understanding how it can be passed from generation to generation. But what's even cooler is that I'm not just so limited to the cancer, the genetics of prostate cancer, but we also look at the genetics of BPH, and BPH is even more heritable than prostate cancer.
What?
That's right.
First comment on your talk, like genetics and family history with BPH. You're saying it's more heritable. So if you've got a history of BPH in the family, you best tell your doctor, your urologist, and your primary care doctor, right?
Because the chances of you having urinary symptoms is also extremely, extremely high. Some of that can be explained by the anatomy of the prostate, meaning that we do find that men who have a median lobe that part that grows into the bladder, that their offspring are also more likely to have a similar shaped prostate. That always doesn't go hand in hand, but similar. It doesn't get as much attention for BPH that it does for prostate cancer because in general, no one's really going to die from their BPH these days, or shouldn't die, because if you can't pee, most men will seek out help. But it is one of those where we do study it because understanding the genetics of BPH helps us distinguish some of the noise of prostate cancer screening, because we do know that if you are at risk of BPH, those men, for the most part, have a different risk for prostate cancer. So only about 30% or less of men will have a risk of both prostate cancer and BPH. And we can quantify that by genetic testing, and we can actually help counsel patients to say, hey, you're more likely to have urinary symptoms, you're more likely to have prostate cancer. This will help better understand our screening and interpretation of our screening tests, such as PSA.
So wait a second. Are you telling me there's a BPH genetics test available?
There is.
And where is the guy? I've gone to the pharmacies. I haven't seen any BPH genetics test. I would like to know where this is, because I'll tell you why I thought of this as I was coming up with questions for you. All the guys that I went to college with, that I was close friends of mine, all the ones whose fathers knew that they had very severe BPH, my friends ended up with it. And I remember that was the first time I thought, what is going on here, right? So anyway, I didn't mean to distract you, but let's go back to this test. Where's this test at?
So it's not widely available, but there are several companies out there, GoPath Genetics, as well as Genomic MD or GMD, that you can get that test that will actually tell you both of those. What is your risk of BPH, those of prostate cancer? And so that's kind of cool these days, is that it's really helping us counsel patients when they walk in from day one.
The reason I said this is like Bigfoot and UFOs is because I have these Moyad BPH questions and nobody can ever solve them. So can I take you through my list?
You can.
Okay, so the genetics you answered. So nobody's solved that. So there's clearly a genetic family history relationship going on with BPH. The second one I have is that it doesn't matter what book you read, everyone has a different opinion. They say that severe BPH has no relation to prostate cancer risk, has some relation. And then there are many schools of thought lately that say you have a lower risk of actually getting severe disease because the prostate's big and there's a migration issue. There's so many theories. What say you about the relationship between having BPH and prostate cancer risk?
Again, this is where it gets a little bit more complex, is that many studies historically have noted that if you had BPH, there was a slight higher increased risk of prostate cancer. But we attributed that to a screening bias, right? So if you go to the urologist, then you say, hey, I have urinary symptoms. He also worked you up for prostate cancer. And ta-da, you magically had both BPH and prostate cancer. We did a lot of, again, the genetic studies there. And yes, we have separate genetic tests that predict BPH and those that predict prostate cancer. But we can also do these kind of cool analyses showing what is the interconnectivity of these different tests. And based on this fancy stuff, which no one really cares about unless you're in front of a computer, there is actually a genetic basis that explains both. So it is one of those where they are actually genetically related, and there is a defined association between them. Doesn't mean we can't use their tests, but understanding that if you do have increased risk of one, you are at slight increased risk of the other.
Interesting.
Depending on whether you see a urologist or not.
And how do you feel about, you talked about this, which I thought was awesome. How do you feel about someone that's dealing with chronic inflammation of the prostate, prostatitis? How do you feel about that relationship with BPH and or prostate cancer? Because a lot of people don't realize, what you study in school is you study that an infection can cause prostatitis, and then that could raise your PSA. And then you look at the data, and the vast majority of people that have prostatitis are these chronic prostatitis, non-bacterial. So all these men are walking around with chronic prostatitis. How do you relate that to your talk and BPH and prostate cancer?
I usually simply say there is a relationship. It is complex, and certainly just because you have inflammation on a slide doesn't mean you're ever going to be symptomatic from it. And certainly it doesn't mean that you're going to get prostate cancer, period. However, my general thought is that the more prostate tissue you have, the more likely, so in BPH, and the bigger your prostate volume is, the more likely you will see evidence of inflammation there. And we know that whether that inflammation is derived because there are, normal bacteria that live there that are causing that, and certainly a lot of the microbiome studies these days are suggesting that maybe that's some of the cause there. Maybe this is from other disease-associated causes, meaning that you have psoriatic arthritis, which you're like, how can that present? But it may mean that your body is just revved up so that you have sites of inflammation that can influence it, or Crohn's disease. So I think we have to pay attention to that. I think controlling or limiting the amount of inflammation in the body when it seems to be out of control or super normal is probably the prudent thing to do.
Yeah.
Not just as a sole isolate, like I have a biopsy of a prostate tissue and there's something. No, but if someone is symptomatic or have those other causes, I think it's a good idea to get that under control.
Love that. Now, here's what I've always found interesting. This is the third Moyad UFO Bigfoot scenario in BPH. I don't understand it. You have to explain this to me. I was telling Mark Scholz on a phone call, I said, it's really striking to me, and I've never talked to you about this. It's striking to me how when we talk about prostate cancer, the words active surveillance, okay, it's accepted, watchful waiting. But when you look at the history of BPH, prostate enlargement, there's clearly a spectrum of men. There's men that have mild symptoms. There's men that have moderate, severe symptoms. And then there's this group of men that have whatever type of symptoms, let's just call them mild or minimal, and they never move. They can be on active surveillance for BPH, which may explain, the natural history is. So where are you with active surveillance for BPH? Is that such a thing, or I've been drinking too much moonshine?
No, I mean, in general, we call it watchful waiting, whatever that means. It means that we are just content with not doing any type of intervention. These men come in, and some of them have more severe symptoms, but they're not bothered by it. Some of them have minimal symptoms, they're not bothered. Some of them, as you said, they never seemingly get worse. I think some of it is defining the phenotype, because urinary symptoms, the way we report that out, whether that's with the IPSS questionnaire, whether it's with a learn symptom questionnaire, doesn't make a difference. It's subjective. And as men or as a gender, we are not always the best at being proactive with our health or reacting to our urinary symptoms. And the interesting thing, or the difficult thing about urinary symptoms, is for the most part, it's not a on-off type experience, meaning that it's a slow, if I will, strangulation of the bladder. So it's, hey, I'm slowly noticing over time I don't urinate like I was 20. And I feel that, again, as a stereotype and not using really gender in any specific way, but that a lot of female gender tends to be a lot more proactive in that way. They notice a slight change and they're at the doctor and they are ready to do something about it. As a stereotype, we're just a little bit more sluggish. Hey, I can live this way. I've been living, you know what? I'm doing okay. I'm playing golf. I'm doing all the things I want to do. But yeah, I may go to the tree a little bit more to urinate on the hole. It's something that we just generally try to live with, and that's not right, but it makes characterizing our treatment a little bit more challenging, because it's not until men are truly bothered that they typically seek help. And that is very different. So this concept of watchful waiting, a lot of men kind of put themselves on because hey, I'm just living life this way. I'm fine. I may be getting worse. I may not be. We don't really know, but I'm not going to come and bother the urologist yet.
What do you see in your practice and in general in the literature about little and big prostates in a relationship to symptoms? There's always that adage that just because you got a big prostate doesn't mean you have big symptoms, and just because you have a little prostate doesn't mean you have a minimal symptoms. So where are you with all of that?
I think that that's kind of like the most fun part about urology in general, right? Is that if it was easy, everyone could do it. But I think that BPH, prostate cancer, are truly complex diseases, meaning that just because you have prostate cancer doesn't mean you need to be treated in the next way. And similarly, like BPH, just because you have a certain size prostate doesn't mean you're going to have urinary symptoms, etc. In general, there is a correlation between prostate volume. The higher the volume, the more likely you are going to have urinary symptoms. But again, that is not a one-to-one relationship at all. And as you know, and as you just stated, is that you can have a small prostate and tons of urinary symptoms and truly be obstructed by that prostate. So it is one of those where you have to understand that. And the cool part is I brought up is that it's not just the prostate, but understanding the other associated diseases that a patient may have contributing to urinary symptoms is also so important.
Here's another one. I don't find this to be my Bigfoot or UFO. I'm just gonna whine for a minute. So let me whine about this. So you got BPH, you got prostate cancer. And so I had to do this for the audience. I had to do this educational update for physicians. It was going to be on what you can do to reduce your risk of prostate cancer or aggressive prostate cancer. And then they also wanted me to talk about other urologic situations. So I decided to make a table of what might reduce your risk of prostate cancer and then a separate table for BPH, right? And I'm doing this table and I'm looking at it, I'm going, wait a second, this is the exact same advice. So I combined the table and I called it, this is the advice for reducing the risk of prostate cancer or aggressive prostate cancer and BPH. So all I have to say is I haven't seen another urologic condition that may be improved. I mean, of course, there are probably others that may be improved or reduced in risk and severity than doing heart-healthy lifestyle changes and BPH. But I hear crickets. I don't hear much about it. So do you have any comment on that?
I 100% believe that, and again, you can see my bias here, but I think that the prostate is the heart of the pelvis. It's the brain of the pelvis, the heart, but it's the most important organ there. And just like we treat our heart a certain way, our brain a certain, it's the same concept. We really need to focus in on treating ourselves right. We don't go out and eat a whole bunch of Twinkies and say, hey, my heart is happy and healthy. Same exact thing for the prostate. We have to keep that blood flow to the prostate. We have to keep it, happy and healthy. It's going to prevent all the inflammation. It's going to prevent it from growing. It's just every study has really kind of showed that. And actually recently, we showed and presented on that if you're genetically predisposed to BPH and you exercise, those men who exercise most, actually, they curbed the subsequent diagnosis and or treatment for BPH. So again, even if your genes point at a certain way, it's showing how lifestyle can modify that.
Absolutely. Heart healthy is prostate healthy, baby. Heart healthy is prostate healthy. Do you ever talk about with patients the importance of just knowing your prostate size? Because let me tell you why I find this very interesting. It's not like guys go out to a bar and go, hey, my prostate size is this big. How's your prostate size? But in reality, I find it very odd that there are not more commercials or advertisements about somewhat trying to find out your prostate size, because look at in active surveillance, we have this thing called PSA density, where you can't do the calculation, whether or not you think it's relevant. You can't do the calculation without an accurate calculation of prostate size. So you know the data where if you do a rectal exam, you can guess, but I think you got a better chance of someone guessing your weight at a carnival or something. You know what I'm saying? So we have all these imaging techniques. You have ultrasound, you have the PET CT, you have MRI, all these things that can pretty accurately guess prostate size. And it's such an important thing to know in general. Where do you stand with that kind of knowledge?
I'm biased. I want to have it on everyone because it is one of those that it just, in the interpretation of so many things, it helps us get our pretest probability. whether you're more prone to prostate cancer, if you put that in relation to PSA, as you just said, whether you're more likely to have urinary symptoms, the size, the shape. And these days you can do it in so many non-invasive ways. Like you don't need to have a transrectal ultrasound. You can have transabdominal. You can get it from a CAT scan, an MRI. You're gonna have at some point some imaging of your pelvis for something statistically. And so if you have that, just ask the provider, say, hey, can you just calculate what my prostate size is based on that? It puts you in the ballpark. Knowing it may change and grow throughout your lifetime, at least around that area, you can get an estimate.
I love that. I didn't know that you were pro prostate size.
Love image, love prostate.
The things I'm learning about you today. You're really getting a lot of favor with me. For the audience, they don't realize that he made me do this interview with him on the day of my wife's birthday. So, of course, I'm going to pay big time. I'm probably going to sleep in this chair tonight. But the reality is you were worth it. You're worth it. So I'm going to go to have a nice dinner. So I love that. So now let's move on.
A hard, healthy dinner. A hard, healthy
I saved this one because this is from a publication I did in 2003. Heart Healthy is Prostate Healthy. You know, I find it so interesting that the first drugs used for essentially prostate for BPH in terms of the alpha blockers actually really came from blood pressure medicine. You lower blood pressure, it's good for your prostate. Anyway, you know me, I'm not going to stand on this. All right, now I want to go to something for the audience, which is important. And before we start talking about the medications and aquablation and anything else, I want you to talk about the goalposts. And I'm sorry to bring up a football reference because your team is not good. But I have to.
You don't know. It's a new season.
I know, but now it's all the best team that money can buy, right? That's the only problem. So now we won the national title, so I don't care if we get clobbered anymore. I can now sing to my
grave. Had to bring that up. I see how you conveniently work that in.
It's only football, man.
That's right. That's right.
When we win, it's more than football. It's about life.
That's right.
When we lose, it's just football.
Completely.
All right. I want to talk to you about measurements because everybody's thrown out this vernacular, right? They're thrown out BPH vernacular. And I want you just to, in your opinion, tell me why this makes a difference. And this is why people with BPH should understand this. So you mentioned a questionnaire called IPSS. There's another one called AUA symptom score. And you fill this out. I've got it here. And then you've got one that you've talked about. And we won't go through them all. But, you know, it's important that when you're on a pill or being treated, that you see a change in these symptom scores, right? That they get better. I mean, can you comment on this? Shouldn't everybody fill this out before they think about even any treatment?
I mean, 100%. It's not only you should, it's recommended by our guidelines, et cetera, because it's the only quantified way to understand what is bothering you. Right. So you may have tons of bother, but it may be related to something we can treat or not treat, but it also serves as an objective way to see how you're changing and improving. And so that's really where it first helps us understand what is the severity of the problem. And if you do have treatment, or even if we're watching you, how bad is it getting, or how much did we improve you? It's really, and it's simple. There's no cost to it. There's truly no cost to it.
So why doesn't everybody fill this out before they go into the urologist? Why are people filling it out while they're there? Because your waiting list is so long, or your waiting time is so long?
In my clinic, you actually you learn to hate me because I have you fill out so many questionnaires before you even come in. They're all online, so you get a reminder several days before. You go online, you fill out all the questionnaires, then they're automatically dumped into our computer. So at the time I can say, hey, Mr. Smith, it looks like you have X, Y, and Z, and this is how severe it looks like. Let's talk about this for a second.
Yeah.
It really is a way, but I do subscribe that this should be filled out ahead of time by the patient themselves.
Thank you. I don't think anyone should go see the great Helfand. I just don't, unless they fill this out and they understand what they're filling out. It is such an important, in cardiovascular medicine, people have all these different risk assessments and questionnaires and Framingham risk score. We know all these names, but this is such a key component to tell the physician and the team, your medical team, how you think you're doing, right? And the higher the score, for example, here, the more the severe symptoms, the more possibly severe your BPH. So I'm so glad you've endorsed the idea that you should do the learn or whichever one that you prefer. Any more? I don't know if you have any other comment on that, because I'm about to chuck it.
Well, I think it's imperative you fill it out.
And we've already talked about knowing your prostate volume and size overall. We talked about that. How about this thing called PVR, post-void residual? Can you explain to me why that's so important to urologists, knowing your post-void residual? And isn't it okay to have a little bit of urine left after you go pee-pee?
Everyone has a certain amount of urine. Actually, almost no one ever empties. Even when it says 0, you still can find a little bit of urine in there. However, as men age and we say our prostates grow, that it can block your bladder, to some degree, that you start accumulating the amount of urine that you hold on to after you pee. And certainly for most men, even if you hold on to a little bit, meaning 100 or 200 milliliters, it's fine. But there are some men that, chronically will start accumulating many milliliters, so 1,000 milliliters, a whole milk jug of urine in there. And sometimes for some of those patients, that can be so much urine that it actually backs up into the kidneys and does some damage there. So it is one of those where we do pay a lot of attention to it. And just because you have an elevated amount of urine that you're holding on to, number one, doesn't mean it's always because of your prostate. But also, it at least serves as a discussion point for how we can better treat you or prevent it. And sometimes we don't even need to treat it, but other times we definitely do. So that is situational, dependent.
That's a really key measurement. And the last measurement I want you to mention, then I'll move on to my next questions for the sake of time, is this Qmax or flow rate. Why does everybody tie the success of their treatment to your flow rate? And can I just determine my flow rate at home? Or do I got to go see the great Helfand in order to determine my Qmax or flow rate? Why? So my first question is, why does flow rate make a difference? And how are you going to measure it? And can I do that at home?
All of this data, whether you're talking about post-void residual or prostate volume, we're all trying to accumulate evidence to say this is most likely from your prostate. Certainly, if you are blocked because you have an enlarged prostate and it's blocking the exit from your bladder, that you may have a slower flow, right? Because the amount of urine you can pass through a smaller opening at one time is limited based on that opening size. So we use that as evidence to help support it. Is it the most accurate test? No, all of these tests that we've talked about have some error in them. And if you don't have a full bladder, or the effort wasn't there, or there are other reasons causing, you may actually have a low flow and may have nothing to do with your prostate. But again, it's all serving as a piece of data that we want to help us better understand what the source of your urinary symptoms is from. You can do it simply, even if you wanted to do it at home. You could take a stopwatch. You can pee into a measured jug, and you can actually plot out how long it takes you to empty your bladder. It's possible. Is that the most accurate way? No, but it's a simple way that we can do it if you really wanted to. You can, when you go into the urologist's office, there's actually a machine. It's not invasive. You just pee into a funnel, and that can measure how fast your urination is going. There are even other devices in the office, again, non-invasive, that we can put a cuff, a little blood pressure cuff onto your penis that you can actually even more accurately potentially measures the pressures as you pee. But these days we're like so cool and so advanced. There are even applications on your phone that will listen to the sound that you make as you pee. And that'll actually kind of determine how fast you pee over time, that are more accurate than just taking a stopwatch and going. So there are a lot of cool things in that space. Again, to the patient, understanding that you can do this all by non-invasive techniques.
That is awesome. But clearly there is a relationship with the greater the flow rate. I know it's in mLs per second. The greater the flow rate, in general, the better you could be potentially doing and the better response you had to a treatment, right?
Correct. So it is another piece of data that you can monitor, meaning if you were slow before a treatment, we do some type of intervention surgically or medically, you have that person repeat the test, all of a sudden the flow is better. It's another piece of data to monitor.
Well, I think I've been sort of hurt by my flow rate. I think my flow rate is probably outstanding because when I'm in a public restroom, it's very loud, it's very fast.
Yeah,
And
you stand
there are
back.
other men, there are other people that look at me and I can see, I know what they're thinking. They're thinking, that guy's got incredible flow rate. What's he doing? One other thing that patients should be aware of, because this word's coming up more often, I thought you could comment, and you don't have to go too much, is that I saw on a number of websites from all these academic centers, they're starting to use the word, hey, if you go see a urologist and you're having bladder problems or prostate, you can get these things called urodynamic tests. And there's all these types of tests. I don't know if you have any comments. The word urodynamics has become such a word of, it gets people excited about measuring all the different aspects of your prostate and bladder and urinary flow. Do you have any comment on, are you supposed to ask for a urodynamics test? Where are you with this?
People have various emphasis on using urodynamics. I do use urodynamics in my practice. I use it to document a lot of times bladder function. So again, for people who don't know, the way that it works is you come into the urologist, you go into a separate room, you get undressed from the waist down, they insert little tiny catheters. So not like a normal size catheter, is generally not uncomfortable at all. In that way, it's slightly invasive, but they fill up your bladder with some fluid, and then they measure how your bladder responds in terms of pressures. And then they have you pee, avoid, and they can measure all that flow as they do that. There are certain times you can even get pictures, x-rays, as you do that, and we call video urodynamics. And that again gives us an idea, is it a low flow, high pressure voiding, meaning is your bladder generating a lot of pressure because it can't squeeze through all the urine out? Is it low flow? We can get all of that data. Is that really necessary for most patients? My belief is no, for most patients, it's not going to actually change what we do. On the other hand, there are complex patients, those who I believe had either had prior surgery, so we're trying to re-demonstrate that, hey, that surgery didn't work, or that patient has a neurologic disease, they have multiple sclerosis or Parkinson's, so we're trying to understand better of, is the cause of their urinary symptoms the neurologic disease, or is it actually the big prostate? That's the setting that we're trying to use the urodynamics for. So I traditionally don't use them on most patients, but it is that select few. For many places, they use it because they're trying to, get study information, and so that's a different discussion.
So it's not bad to go if you're going into your local urologist to say, are we going to do any urodynamic studies today to figure out what's going on? I mean, I think it's a little empowering.
Yeah, I mean, it's a little bit more scientific way to get that information that may help better choose the right treatment for the patient.
You know what the biggest fib ever told? I made this, and I want you to acknowledge this. The biggest fib ever told, and men are all guilty, I think, of this as we get older. I hardly ever wake up at night to use the bathroom.
Yeah, most men.
You look at the partner, then you probably look at the partner and go, what's the real answer?
Totally different story. We tend to underestimate. And the issue there is that we also, bother from nighttime voiding. Getting up in the middle of the night is typically the greatest. That tends to be the most bothersome symptom, most motivating symptom that men have. Understanding that as we age, we do make more urine at nighttime. Our position, laying down makes us have more urine. Many of our hormones change through we age, etc. So some of it's normal. I always tell men that 2 or less times a night is actually in the normal realm. So it shouldn't really, motivate in and itself if you have 2 or less times the sole reason for treating you. But there is, kind of even ways to distinguish some of that stuff out. If you have what we call primary nocturnal polyuria, you're making most of that nighttime volume at night. So there's fancy ways to look into that. But, for most part, we all should expect to get up at some point during our life to have to urinate, and that's okay.
I decided to make a list. I made 2 lists. It's a pretty extensive list. So can we go through these and just, I like the game called the Moyad Pro and Con game. Can we talk about the pro and con? Let's talk about, first of all, before we talk about any of this, I saw this online doing research for you because I had to update my BPH skills and just knowledge. I read in a few places that this is true, up to 30 to 33% of men fail prescription medication within 2 years. Is that true?
It is actually, and some studies would actually suggest it's even up to 67 or more percent. So it depends on your population, and you're like, hey, I went to the doctor and I hate their medicine, so I stopped it, right? This happens all the time, but it's okay because we are giving these medicines to improve your quality of life based on your urinary symptoms. And if they're not helping, talk about it because there are treatments for you. They just may not be medications.
That's an incredible statistic, you know? So let's talk about the first type of pills offered. You can say a pro or con or not say anything at all. I just want to make sure we cover this before we just talk about, again, aquablation and the other more invasive treatments. Although these can be kind of invasive on their own. Alpha blockers, right? Alpha blockers are the top of my list. They end in osin. In general, like alfuzacin, doxazacin, anyway, there's Flomax. So they relax the prostate. That's the good news. I don't know. You want to add any more good news or bad news about the alpha blocker?
They are some of the initial medical treatments for BPH. Again, as you brought up, and a lot of them were kind of coincidental because we said, hey, we're using these to treat your blood pressure, and look, you're peeing better. So they do relax the vasculature and certainly smooth muscle cells of your prostate. Which takes off some of the resistance from your bladder, so help men. Most of them have some side effects. The two main ones I always counsel patients is the possibility of retrograde ejaculation.
Oh, good point.
Possibility of, it's not usually orthostatic, but at least lightheadedness and dizziness. So certainly counseling, understanding that beforehand can at least help have patients more compliant with the medications, knowing that before they start them.
I want you to see if I can take you from the great Helfand to the super great Helfand. Do you notice that every single website that talks about alpha blockers talks about retrograde ejaculation, but nobody says what you're supposed to do about it? Do you have to quit your medicine? Do you get treated for it? Nobody ever says. They said, oh, you're going to have retrograde ejaculation. Gee, thanks. But it never, the website never continues. I don't know. And I haven't seen any website continue to say, well, what are you going to do about it then? What do you do about it if you have it?
You can't really do much until you stop the medication, and then it comes back. Now, there are other forms of alpha blockers, so not all alpha blockers have the same risk of retrograde ejaculation. Alfuzacin is actually a lower risk than tamsulosin, which is lower than silodosin, et cetera. So discussing that with your provider may help it, because there may be an alternative that can help alleviate your urinary symptoms and not give you such great risk of sexual dysfunction.
But if you have it, is it bad to have such a thing? Is it bad to have retrograde, or is it just
there's no harm unless you're trying for kids, or a lot of men will without any judgment will define their sexual prowess based on their ejaculate volume, and so for them there may be some kind of negative connotations there.
Yeah, that's understandable, but you just solved all the internet's problems in a couple sentences. Nobody ever tells you what you're supposed to do with it, but you just did. Thank you. 5-alpha reductase inhibitors. They shrink your prostate. They shrink your
prostate. They may shrink other things. So they shrink your prostate by altering the conversion of testosterone to its really potent and active form known as dihydrotestosterone.
Yes.
They are good in the long term in that they can reduce the possibility of progressing, getting worse urinary symptoms over time. They do improve urinary symptoms by themselves. They generally take about 6 months before they're actually fully working. They do have some negative side effects, meaning that there are a certain population of men, about 5% or less, that will have true new onset erectile dysfunction. That has been reported. Sometimes that's irreversible. So it is something that is important to know. Men can get breast tenderness on them and stuff like that. But They can also promote hair growth on top of your head. So it is one of those where some men use them for that at different dosages as well.
PD5, this is the other treatment for BPH Cialis. People think of them as erectile dysfunction drugs, but they may actually help with prostate enlargement. How did an erectile dysfunction drug become an option for BPH? And can you just clarify that this is not the same as sexual activity? You just take it daily as a medicine. There doesn't have to be sexual activity. So tell
Correct.
me
So
about.
it's taken at a lower dose.
Okay.
The FDA approved drug is the tadalafil, which for
Okay.
sexual activity is generally provided at between a 10 to 20 milligram dose. For the benefits of urinary symptoms, they have it on a daily dose at a lower dose at 5 milligrams, or in certain populations, 2.5 milligrams. And so that was initially noticed that, hey, men who were taking this drug also had a stronger stream. And when they looked at it and, kind of studies of the bladder, they said, hey, it actually improves because it relaxes the musculature of the floor of the bladder. And so it actually was shown to be an effective treatment. Again, they can be used alone, or they can be used simultaneously with, some of the other medications. They in itself also can help that nighttime voiding.
All right, you can just say something about why these overactive bladder drugs get a lot of attention with urologists. Here's ditropan, and then they got these other ones, these beta-3. So you've got these drugs for overactive bladder. Do you use them much? And what should I just know about that?
Certainly there is some caution and guidelines these days because of the association between a lot of the historic, what we call anticholinergic drugs. There is an association with, kind of potential future for dementia and, kind of altered mentation, that there is a kind of a red flag there. They themselves, because of their systemic side effects or interactions, they can increase your risk of dry eyes, dry mouth, constipation. So, kind of more recent versions of the OAB, overactive bladder guidelines, that in general, if it's possible, you should consider a beta-3 agonist first, because of the potential for lower risk side effects. So that's mirabegron, verbegron, etc. Those themselves, the beta-3 agonists, are great, but not always the most practical because of cost. Even though the mirabegron is an example, around for a long time, a lot of patients find them still very expensive or not covered. So again, should be discussed risk-benefit of each one of those. Those are intended to help urinary symptoms, but specifically, a lot of them for irritative symptoms, urgency, frequency, getting up in the middle of the night, those potentially can help. The question I always have there is the primary issue an overactive bladder, which those are great for, or is it really the prostate driving the overactive bladder, and should you just be addressing the prostate first? But that's a different discussion.
Do you want to say anything about Botox for overactive bladder? I mean, I know it's been around for a bit. I mean, I don't know if you give it. I just thought we get questions.
Botox helps a lot, especially if there's an underlying neurologic or other cause to it. Again, in terms of BPH, I always think that you should address the outlet, the prostate first. If you still have persistent OAB symptoms, then Botox is a consideration. Again, a lot of the therapies, especially according to the latest OAB guidelines, can be used as, sole therapies. You can start off by using, kind of medication or Botox, but certainly they can also be used in combination if those irritative symptoms persist.
Last but not least, I'm going to throw in the one that's going to just throw in some fireworks. You ready?
Here we go.
Extracts, big sellers in BPH, herbal products, saw palmetto, beta-sitosterol, pygeum. I mean, where do you stand on these? If someone comes in and says, hey, Dr. Helfand, I don't mind if you do aquablation or whatever you're going to do, but I still want to take my herbal product over the counter. I mean, this is a whole other lecture, of course, but where's your just sweet spot on this?
My stance is, in general, they're not considered harmful. Meaning that most of them, are safe to take. There are very few true randomized trials that have really evaluated their efficacy. The other problem is that a lot of the, kind of natural therapeutics are different. So there's not a standardized way that they're sold. And so you don't actually know the amount of any of those kind of active ingredients that you're taking, which makes the interpretation variable. But if they are helping, then please take it. I was involved and helped analyze the CAMUS trial, which was a randomized trial of looking at saw palmetto at 2 different doses versus a sugar pill. There you go. And ultimately, it's one of those where there was no difference in outcomes for most of those patients. So it's not one of those where it's wrong to take, and I certainly don't stop patients, but knowing that you have the expense of buying the drug, and while it's generally pretty affordable, if it's not helping, you can stop them.
Yeah. And I think they should be cost competitive, quality control, all this. I mean, like I said, I could give an 8-hour lecture on it. I just want to know where you stood. I didn't know that you were a part of this CAMUS trial and analyzing it.
That's where we got all that sleep data from. It was the analysis of the CAMUS trial.
A very famous trial for the audience in my world. And it was, but what we learned from these trials that I always try to remind people is that in the STEP trial, which was before the CAMUS trial of saw palmetto versus placebo, Bent et al., it was, they did this placebo run-in phase, right? And during the placebo run-in phase, there was a significant benefit in urinary scores during the placebo run, meaning that I don't care if it's a drug or a supplement, there is a placebo response rate in BPH, which is quite substantial, right? And it's not just the herbals, it's just with any of these pills and BPH. And so you recognize that there's a very large placebo response rate. What made my head spin last time we talked about whole lip, whole lip, it doesn't matter. You say potato, I say potato. I mean, when you look at the number of choices, I mean, this is just a partial list of BPH choices. And then I tried to put them in an abbreviation. I mean, come on, you got to admit, if you're a patient looking at this, you're saying, what kind of mess is going on here? How am I supposed to figure this out? So here's what we're doing at PCRI. It could be right or wrong. We're just trying to focus in on an expert that does what they do. You already talked about the others. And I just want to go through a checklist of what Aquablation provides or not. And then I think we're doing a service to the public. The idea that we're going to go through every single one of these, we would have to have 36 hours of tape. But it just goes to the point of doing your homework. And so I don't know if, let's just go through these and then we'll be done. But I want to go through questions that you might get if someone's interested in a procedure for BPH. Most of the, if not all the men you treat have moderate to severe symptoms. These aren't guys who have mild symptoms and it's just a little bit nagging. Is that correct?
Correct. I mean, most of the patients are treatment seeking, right? So these aren't people who are living in watchful waiting. These are guys who come in and saying, hey, I'm bothered by my urinary symptoms. I'm not happy with my current status, or I need help. So that's most of those are going to have moderate to severe symptoms.
Okay. Does it matter how old you are, being too old or too young to get Aquablation or some of these other procedures? Have you treated some very young guys and some older individuals? Sorry, you can't use the word older anymore. The word seasoned.
So we were initially limited because when the insurance approval happened, they based it on study criteria, and you never involve men 80 or older in studies. So we're initially limited there. Now that age restriction has been lifted for a while. So any man who is deemed a candidate for surgery is qualified. And certainly because of the low risk of side effects, that even young men who are determined to be obstructed from their prostate or have urinary symptoms because of their prostate are candidates for it, because they don't have the sexual side effects that are typically associated with most resective type procedures.
Next on the list is, and this scares me a little bit about Aquablation, maybe it shouldn't, anesthesia. It sounds like you're telling me I got to be wheeled in and get general anesthesia, right?
You can have spinal anesthesia.
Okay, you can have spinal.
You can have LMA, so kind of where the tube is only in the mouth, or you can have full general endotracheal anesthetic. The only anesthesia that is not currently used is a twilight MAC anesthesia monitor.
Okay, so Twilight's okay. But should that be scary? It sounds like this is not done in the office. This is done in the hospital.
You should be done in the hospital only because, and most men, in my experience, are actually happy with that because they just, when it comes to down there, they said it's a very sensitive area. I don't want to feel anything. And that's not wrong. And the only reason we do it in the hospital is because it's a lot more comfortable, because it turns out if you take a water, power pressure to your prostate and you're awake, it's stimulating. So to make that reasonable, we do it.
Okay. Antibiotics. Do you have to use them before or after? Like, what's the deal with do I have to take antibiotics?
Just like almost every other urologic procedure, we usually just give one dose right before surgery in the operating room. That's it. The only exception there is that for my protocol, that if you're in retention, meaning catheter dependent before surgery, I will send you home with about 5 days of additional antibiotics just to prevent any bacterial seeding of that freshly treated tissue.
Okay. So short course before, maybe some after. Big prostates. Here's what I don't get. You have to explain this to me. I found this article you wrote in the Canadian Journal of Urology. Brian Helfand, how I do it. Aquablation in very large prostates, greater than 150. I'm going, I didn't know aquablation. I know you say it, but I didn't know this is becoming more accepted for huge prostates. Is it, or is it just you?
No, actually, when you look at the trends across the country and you look and saying like, well, how do people really start off? The initial studies were all done in 150 grams or to less to 30 grams, or 30 to 150 is a better way to say it. And then, but in the real world, because it's a non-invasive and very easy way to treat patients, when urologists first acquire the technology and they start using this, most of the patients that are referred have huge prostates. So what is the real difference between 150 and 200 and 200? It's not. It's made so easy. So it's really kind of in that way, really size agnostic. I think the largest prostate that has been done with aquablation now is about 730 plus grams. So a huge, huge grapefruit. And apparently that was not done by myself, but that individual is urinating without problems. They were in retention beforehand and very happy with the results.
I think the dumbest thing that I ever see on the internet, sorry, it's not the dumbest. Maybe I don't like it. They say a prostate's the size of a walnut. Yeah, maybe when I'm 16, it's the size of a walnut, but I know that you're seeing people as the size of a football, not to throw.
Oh, not that football, not that one.
No, maybe not that, but it's just like, when did this become the standard?
Well, it is funny that we refer to most prostate sizes as like fruits or food groups.
When I'm watching videos or trying to learn more about aquablation, it says that one of its Achilles heels on my checklist is potential bleeding. Is bleeding or the need for a transfusion very different? Just because you have blood doesn't mean you need, just because you're bleeding doesn't mean you need a transfusion. But is that truly an Achilles heel of this procedure?
No, and I fault, and I was not part of, and I'm still not part of PROCEPT at this point, but when PROCEPT designed their trial, their second trial was known as Water 2, and they kind of had it wrong, right? So they thought that any type of cautery energy was going to cause retrograde ejaculation because they just didn't understand where the antegrade function was really coming from. It turns out it's from the veru, the apex of the prostate, because you can destroy the bladder neck. That's a whole different story. But because of that and the fear of having sexual dysfunction, what they did in Water 2 was they said, well, we're going to see what the worst case scenario is. We're going to take the worst, biggest prostates up to 150 grams. We're going to do aquablation with a water jet, and then we're going to walk away, put a catheter in, and call it a day. And there's no other thing that you would ever do as a surgeon to say, what I'm going to do is intentionally cause disruption of tissue, cause bleeding, and walk away. But that's what they wanted to do, say, what is the worst case scenario? And even in the worst case scenario, it was a 6% significant bleeding rate, which you said, oh my God, that's really high. On the other hand is now that there's protocols and the way we do it is totally different, that rate of significant bleeding is about 0.4%, which is actually lower than TERP, the gold standard. So it's not a significant worry or bleeding risk. It just initially, based on that initial study, which people didn't understand, was associated with it.
Okay. What about blood thinners? If I'm on a blood thinner, can I have this procedure or do I got to stop it?
If you're in my hands, and again, there's no written protocol, but most people would say is that I am okay with you being on a baby aspirin throughout the procedure, or ibuprofen or something on that. But if you are on a anticoagulation, a true anticoagulant like a Coumadin or Pradaxa or something in that space, that we usually have you hold it. I typically will hold it for about, depending on the blood thinner type, for about 24, 48 hours before the procedure. And then we restart that 4 days after the procedure. That type of protocol is really just based on more of historic what we do for other outlet procedures. So there's really no difference there. The only patients I won't actively offer aquablation to is if they've had a fresh cardiac stent. Heart stent, they cannot come off their blood thinners at any terms for a period of time. We will not do that procedure at that time. But I don't actually know of any real procedures that they do during that time.
If I'm a larger person, BMI wise, waist circumference, am I okay here, or is it necessary a larger operative time or anything? What about a very large individual?
I mean, there's the usual risks of any type of anesthetic if you have an increased BMI, et cetera. I haven't seen a BMI as a factor here at all, because again, this is all endoscopic with small cameras through the urethra. Medicare, I believe, has a limit there. I'm not sure what that is based off of, but I think they have some upper limit that they wouldn't allow us to approve or proceed.
Catheter. Do I have to have a catheter in?
Again, this is variable based on the surgeon. We generally leave it in at our institution overnight for just really about 12 hours after the procedure. The catheter is removed in the morning. There are some protocols based on surgeon preference that may leave it in for several days, but in general, it maxes usually about 2 days.
Okay. Do I stay overnight in the hospital, or can I go home the same day?
It again depends on surgeon preference. Right now, the company would say you should spend overnight in the hospital. Having said that, is largely based on COVID. We and others developed an outpatient protocol. So for certain patients we have with 150-gram prostate or less, it is possible, if motivated, you can go home that same day. There are now surgery centers across the world that are trying that out, that have had a lot of success with it. Again, surgeon preference and patient preference driven.
So not always. That's interesting. Insurance coverage, right? Major insurances, Medicare, the works.
Correct.
I don't want to be patient zero. I don't want to be the first or second person getting the aquablation. I want someone that's done it hundreds upon hundreds of times. Tell me if there's a learning curve. And if you say there's no learning curve, I'm going to go, what? There's got to be some learning curve, but I'm saying that, but tell me, how many procedures am I looking for when I can feel comfortable? I know it's really hard to pick a number, but if someone's done 100 or 50, can you just give me some guideline on this?
I always say that, at least talking to most urologists, is that the learning curve here is generally 10 to 15 procedures. Just because, again, remember, the technology involves things that urologists do all the time anyways. It involves an ultrasound. These days, especially in biopsy areas, we're so used to looking at prostate ultrasounds. It involves cystoscopy. So there's just the basic skill set that we have here is there's not a lot that is really needed.
How many have you done, roughly?
Just under, I think, 500.
Okay, so you've done 500. So I don't expect you to have any sort of reaction to this, but I would rather see someone who's done 500 than who's done 15. I'm sorry.
Well,
I'm not asking you to react. I'm just telling you. I'm telling you what everyone's thinking watching this, because I know that's what I'm thinking. But that's good that you've done 500. But I mean, what you're saying is you don't need that much of a learning curve, which I appreciate. But I love the fact that you've done 500. I had no idea you've done 500. I thought maybe you did 200.
It's one of those where that's with anything else. I do think that having specialty in a certain area helps. But it is one of those where the beauty is that it is compared to a lot of things like whole lep, where the learning curve is well defined. It's saying, hey, you need 250 or more, which takes many, many years to accumulate that for most urologists, that this can be done and learned very quickly.
Remember, my last interview was on whole lep. I was impressed. So, I was impressed by the learning curve of that individual, but that person was at Michigan, so I'm always impressed by anyone.
Well, there you go.
So, but the goal has to be, and this should always come up in a conversation. The goal in aquablation has to be the goal in other treatments that if someone's on medication, the goal is to have them come off completely, correct? Or am I wrong?
100%.
So if I'm on Flomax, I'm on Cialis, I'm on finasteride, dutasteride. Our goal is that when I'm done down the road, when I get my results, I'm not taking these pills anymore.
Correct. So the normal protocol that we have is that you would continue that medication for 1 month after surgery. Okay. That's not based on any real data. That's been our standard. And then you stop all medicines. And then, we continue to follow you. We keep track of everything. And the rate of retreatment in our series is really less than 0.1% a year. So very few patients ever need anything again that we can tell.
When you say retreatment, do you mean retreatment with the pill or retreatment with any kind of treatment?
Either any medicines or surgery.
Okay. Any comment on partner perspective? The only reason I throw that into my gigantic checklist on all these procedures is that do you ever have the partner fill out an IPSS or comment on, the true severity? I know we touched upon this, but I would think in a close partnership that I'm more likely to get the best answer when I get a combination, no?
One of my collaborators and colleagues, Kevin Zorn, who's in Canada, is actually doing this and having the partner fill out sexual function and urinary symptom questionnaire simultaneously. So we'll see what that data kind of reveals. On the other hand, what I've noticed is that, in the patient population that I treat, a lot of the spouses or partners come in at the first visit to talk about everything. And you never see the partner again. And that in a way is a good sign, because if there's a problem, you usually see the partner come back.
Average procedure time?
About 37 to 42 minutes. I mean, it's pretty quick. That's
pretty quick. Average reduction in prostate size?
So the volume itself is measured by the calculators we have, which are insufficient, is about 30 to 40% reduction in overall volume.
And how long does that take? Right away. So that's right away, right?
Again, imaging has been subsequent in various series. Stephen Kaplan has measured a kind of 40% or more reduction. He does ultrasounds more frequently. I, totally different side, have a large active surveillance cohort who have had this and kind of by MRIs. It's just a challenge to measure because they still have a big defect throughout the middle of it. So I don't know if we're really comparing apples to apples because it's more of a hollowed out ball, so to say.
Well, if you're getting 30 to 40%, that's a lot, right? I mean, and then
and it's similar reduction, or if not more, in PSA, which is another proxy.
That was my next question. So you must see pretty large PSA drops.
Huge PSA drops.
So, like what?
If you started off with 4, I would expect you to be about 1. A PSA of 4, and you go down. I mean, it's a significant drop.
Next time you and I talk, I'm going to spend an hour just complaining to you. And I'm going to complain to you of how this is the thing that BPH procedures in general don't get enough attention. It is really amazing to watch someone like a friend of mine have a PSA of 7, get a very prominent procedure. I'm not going to say if it was whole lep or aquablation or what it was. And now his new PSA is 0.7. It's 0.7. And it doesn't mean he's not going to get cancer. It just means it's just stabilized. And how many men have had these erratic PSAs from BPH. They end up getting biopsied and they end up being on active surveillance, which contributes to the overdiagnosis of prostate cancer. I also believe prostate cancer is underdiagnosed when it comes to aggressive disease, but how many men have had an erratic BPH, which led to a biopsy, which led to active surveillance?
And I'm now stuck following your cancer, which I don't believe will progress. And I tell these men this, I think your primary problem was you had a big prostate. No one factored in a PSA density or other kind of factors saying, hey, most likely this is what it is. Let's address this. And it turns out you're really bothered by your urinary symptoms. Why have we ignored it? Why are we so, and by the way, as an oncologist here, I'm so cancer focused, right? But I'm like, in those men, why are we so focused on your cancer? Your cancer is not your problem.
But it's creating a lot of problems.
It creates a lot of problems.
That's why to corral BPH has got to be as important as corralling anything else out there.
Correct.
My dog agrees. I don't know if you heard him bark. My dog.
I did.
My dog has a prostate. What's your average post-void residual improvement? Do you see we talked about PVR measurement. Do you see that improve?
100%. So the average volume for whatever this is about 150 milliliter improvement. What that equates to is I mean, also a significant improvement in urinary flow, all that kind of stuff. So there are significant sustained improvements in urination. I mean, in volumes and all that kind of stuff. Again, contributing to our success, supporting that it was a successful procedure.
And then what about flow rate, which we talked about was an important measurement? Do you see flow rate increase, or by what is it increase on average? Again, we were talking about that.
Average pre-op is about 5.7 mils per second, so greatly obstructed. Post-operatively, that average is between 15 to 17 mils per second.
Quality of life, do you measure that now after Aquablation?
By questionnaire, all by so many questionnaires, all significant. And this is the only procedure where I'm like, hey, I don't mind seeing you 2 weeks post-operatively, because the recovery is so easy because you don't have that added energy power. So there's no real cautery, there's no real lasers. So these patients are actually quite pleasant to see because I'm not torturing them in that perioperative period. Or I should say the Aquablation isn't.
So you have found, as you see these objective parameters improve, you've seen the quality of life improve.
100%.
What about radiation exposure? Does this involve any radiation exposure? People, I love it. No, okay.
No radiation.
Okay, because if you look on every advertisement for Aquablation, it says image guided. I'm going, well, what kind of image? Is that giving off radiation or not?
It's ultrasound waves.
Why don't people just say what it is? It's just like, I don't get it.
No fancy stuff.
Recovery period. How long does it take to recover from this? And is there anything I can do to speed up the recovery personally?
The prostate itself, it's raw. I don't care what procedure we do. If it's a resective procedure, even if it's even just implants, that it's irritated. And so this is about a 2-week recovery period. Where you may find yourself going to the bathroom slightly more frequently. There may be some pain at the tip of the penis when you void. You may have some blood in the urine. That's the kind of recovery, if you will. If you take Advil, even that irritative pain typically goes away for most patients, as long as you schedule that Advil for 2 weeks.
So I'm a busy person. You treat me. How soon can I go back to work and or driving? Or whatever I like to do.
As soon as the catheter's out, you can drive. Again, this is not a major pain procedure, so you're not on any narcotic pain medicine. So as long as you feel like you can step on the brake, you can drive right away.
Okay.
I always say take several days off work, probably 3-4 days. Not because, again, you're not functional. You just may be going to the bathroom more frequently. So if you had your procedure on a Friday, by Monday, you'd be ready to go back to work.
Okay, when can I start running again and or lifting weights?
I say start off easy. Take several days off of heavy lifting or working. You can walk post-op day 0-1, but resume exercise building up starting 4 to 5 days after surgery. So it's not one of those where I ever. Has been no randomized trial ever showing that if you start earlier exercise that there's going to be some detriment. And so historically people said, well, take off several weeks. I said, why take off several weeks? So we've always had a protocol to say, if you feel up to it, drink a lot of fluids during that exercise, but it is, in our opinion, safe to start early exercise, even several days after surgery. Don't push it. I don't need you running a marathon right away.
Yeah.
But things like elliptical, walking, fast walking, maybe hold off of bike riding for several more days, but that's really about it.
But again, say that again, lifting. If I want to get back to lifting minimal weights, like in the weight room,
4 to 5 days post-procedure. Even sexual activity, I say if the opportunity presents itself, don't pass it up.
So I want you to take me though through the top side effects you see just for balance. So the top side effects you see, are these from long term or short term? Can you just go back
So
through my
there's not
head?
a lot, unlike a lot of the other resective procedures where we worry about scar tissue and things like that. There's no really real risk that we have shown that you have bladder neck contractures or scar tissue there. The risk of kind of immediate thing is just blood in the urine. So as long as you're drinking fluids, most men can keep that clear, where you don't have to worry that you're gonna get blocked up because of a large clot. And the only other thing that people really are concerned about is that there's some dysuria or pain, kind of the tip of the penis when you void. It's all referred really from the irritation from the prostate. And then there's a 8% risk, or up to 10% risk of retrograde ejaculation.
Doesn't come back or does come back?
It can be permanent. We don't really know among that subgroup if there's kind of a recovery or not of that. I think that's still an unanswered question.
But I should be noticing that you treated me within, again, say that, I know I'm not holding you to this, but
your strength of your stream should be almost immediately strong.
Okay.
The frequency of urination and a lot of that urgency typically resolves pretty quickly within several, days to weeks afterwards. The last symptom to kind of recover, this is true of almost every outlet procedure, is your nocturia.
Getting up at night. When you say it's the last symptom to get better, so how long am I waiting for it to get better?
I mean, that could be not only several weeks to, several months to totally improve. I mean, certainly we see that if you've been getting up 3-4 times a night, that's going to go down to 2 to 3 times a night pretty quickly. But that last little bit, again, I think it speaks to its multifactorial nature.
You can do some procedures where it's safe if you're on active surveillance for prostate cancer. I mean, I talked to some folks who essentially they are, they're active surveillance, they have low volume disease, and then they go ahead and they get treatment for their BPH. Where are we with, I'm on active surveillance, but I've also got this bad BPH issue. Can men with prostate cancer get aquablation?
So yes, with a caveat that Medicare currently has not released they haven't lifted their exclusion on that, meaning that it's been shown to be safe. It was only initially excluded because initial trials, which are normal for all BPH trials, did not include men with prostate cancer. But since then, it has been done on many, many patients with low as well as even high-risk prostate cancer. It's been shown that it doesn't...
High risk too?
Even higher, before they would get radiation, etc.
Right.
It does not increase circulating tumor prostate cells after aquablation, and is generally considered to be safe. And actually, again, because of the easy recovery, a lot of clinicians offer it because they can start if they're going to, undergo radiation, start radiation sooner than if they had a HoLEP or other type of procedure. It is so effective, and again, it's so precise in the design of where you resect that there are currently 2 trials to actually treat prostate cancer that are ongoing right now with aquablation as a form of kind of almost like a focal therapy, although it's being referred to as a subtotal prostatectomy, because not only are you getting rid of the area of prostate cancer you can see on an MRI, but you can also then get rid of a lot of the other tissues. And again, you can do this in a way that doesn't increase side effects. Because unlike a lot of the other focal therapies, the more prostate tissue you treat, the higher likelihood of a side effect. This actually is being studied, but it theoretically should not increase your risk of side effects.
So some men with prostate cancer, some types of prostate cancer, can go on to receive this BPH treatment.
Correct.
How
As
about
a form
if
of
they,
treatment for not only their BPH, but also for their prostate cancer. Now, this is not every man, so
no,
don't
I just,
but there are certain populations that would be very amenable to this type of therapy.
and would you say primarily that's low volume active surveillance patients that would be good candidates if they wanted to check it out?
I think it is men with either a grade group 2, so a Gleason 3+4, favorable
Yeah.
intermediate risk, some higher volume 3+3, but in general areas that you can visualize on an MRI, that you can definitely go and target those type of areas.
Okay, then, oh, sorry, go ahead.
I was going to say it can also be used for the general patient with on active surveillance. And the thought there, and again, this may be the subject of a future study there, is to say, can you alter the natural history of active surveillance of saying that, hey, we know we're ultimately going to treat 30 to 60% of men on active surveillance. If we do aquablation, getting rid of that kind of excess at-risk type tissue, can we actually keep you on active surveillance longer?
Interesting. But what about if the prostates are ready to receive energy? What about if it's been hit with a certain type of energy, being radiation already, or HIFU, or cryo? What about those guys who already received some type of treatment to the prostate?
So for most of those, it is considered safe. I know that certainly we have looked post radiation and used it. It's done really well. I personally haven't done post cryo or HIFU. I don't see why that would be contraindicated. The only thing that we haven't done is post brachytherapy, because I don't know how we would respond. And most of those I don't think have really large prostates.
Yeah, it's already shrunk down. But you're not, but the hardening of the tissue, the fibrosis that occurs with some of these energies, that it's not
That's
an issue.
actually better. It cuts the water that actually goes through those tissues, even like it's really cool.
Come on, man. I did not expect that answer.
I'm sorry. That's just it's
That's interesting. You know, people don't write about that enough. But what about the other way around? What vice versa? What about if you've got aquablation and then your PSA is really low, it goes up, and there's clearly cancer there? I mean, is there any
easier to detect because you're getting rid of a lot of the BPH noise? So we continue to screen afterwards. 2 is that is the other beauty of aquablation. It does not preclude any therapy. I've done radical surgery after aquablation. The surgical plane's preserved. Very different than if you've had a whole lap or other laser procedure, or even sometimes TURP. Nerve sparing in those patients, still very easy to do. You want radiation? I mean, we haven't limited you. That's the beauty.
What about if someone wants to get a retreatment? Can a second aquablation procedure be performed in one that's already been performed if the tissue grows? Because I'll tell you, I always try to look for what the catch is. We've covered most of them. Another catch I saw from some speakers at urology meetings was, yeah, they blow out all this tissue, but then 5-10 years from now, that tissue can regrow in bad places.
We don't know. Certainly anecdotally, because of the initial trial, and again, this is way more information, I have done aquablation, a repeat aquablation on a patient.
Yeah.
And the patient only wanted another aquablation. And I will say is that is totally successful, and you can plan, and again, you can plan to meet any size or shape, even if it's asymmetric, etc. It works totally. And there are really cool ways that you can plan out your thing in that asymmetric prostate if they have that regrowth. So I don't think that it's contraindicated or should be. But from a practical standpoint, again, it all comes down to Medicare. Right now that they have it so it's limited to one aquablation procedure in your lifetime, just like a TURP.
So what a lot of people say about some other procedures like HOLEP is they'll say, well, you destroy that tissue, then it comes out and you can test it for cancer. But I never see anybody write anything good or bad about aquablation. I'm getting rid of all this tissue. Can I test that tissue for cancer?
You do get tissue out because, again, the most modern way that you do it is that you do the aquablation, you always look back in and you do what's called focal bladder neck cautery, meaning that you kind of get rid of a lot of the slough tissue, this kind of treated tissue.
Yeah.
And that can be sent off. In our series, about 1.7%, and this is a very screened population, will be found to have prostate cancer incidentally. So it's a low incidental risk, but this is a highly screened population beforehand. If we know you have prostate cancer and you were on active surveillance, about 30% of those patients, you can find cancer in their specimens.
I've seen a lot of aquablation videos and papers, and I don't see them going very far with the answers. Come on, I'm not that smart.
We collect all of these things. In general, it's the amount of tissue you send off is about 5 to 7% of the total prostate volume. So it's pretty low amount of tissue.
Oh, so it's low. So that's the catch. So the catch is all this tissue comes out, right?
Correct. And then you send it off.
You can test some of it, but you can't test a lot of it.
Right. I mean, it depends. Again, you're still going to screen these. You're not missing anything.
Right.
This is still a screened population. I'm not worried we're going to miss aggressive cancers. Even whole up studies, about 4% incidental, 3+4 type of cancer. It's rare. I don't feel we collect it not because I'm an oncologist by nature, and so I always want to test everything, but I'm not really worried about these men in cancer.
But the average person who gets aquablation, that the tissue comes out, it's your prerogative, isn't it? Can't they test some of the tissue?
Yeah, you can 100%. You should test that tissue if you take it out. I mean, we test everyone. We test.
Why doesn't it say that on some of the sites?
I gotta put it in. I mean, this is what
I'm not saying it's your fault. I'm saying these are the kind of questions that people watching PCRI have to know. It's like, I want to know if they can test that. I want to know if I have already been treated, if I can get this. I want to know if I get this and then I get cancer, what happens, good or bad. So I think you answered it. And it's a good thing I stick to time. I think I went only about an hour and a half over. I completely took advantage of it.
Well, listen, I don't have to answer to your wife. It's just tell her I say happy birthday.
Thank you. I will. My wife is very gentle. It's not a big deal. We're going to have a good time. She's going to be happy that I'm done with my interviews. And so, but I appreciate that. Feel free to send her an expensive gift.
I should. Yeah.
Speaking of gifts, that's a great segue to end this tonight. This is a random thing. It's not a football. I'm not going to give you this gift. We got you another cup. Can we show you? Peter, can you bring up that cup? There it is, an Aquaman cup.
Oh, that is actually amazing.
Really?
Oh my God, yeah. Do you understand how many people are going to be jealous of that?
I'm sure many, because it's a gift from us, including me, and people are just jealous of.
It is great. That is fantastic.
We couldn't find an Aquablation cup, so we thought the closest thing was Aquaman. And so if you're a man doing Aquablation, theoretically you are an Aquaman.
It is fantastic.
We go to no limit. There's no limit here. We miss mortgages. We give life-altering gifts. Nobody will ever give you such an amazing gift. With that, a big hug to you, man. You just completed 2 different talks with us in less than a year, and you were a good person about it. We definitely covered a lot. And for a reminder for the audience, all these other treatments for BPH, we will cover it. It's not just in Dr. Helfand's talk. We will continue to cover it so that you can pick the best procedure for you if you need it. Anything else I can add besides the fact that you're a huge Michigan fan?
No, I'm just excited, and I appreciate the invitation, because I truly enjoy this. So
good. I really do too, Brian. I've really enjoyed our 2 talks together. I hope we'll do something else in the future. I still feel more comfortable the fact that you've done 500 Aquablations versus the person doing 15. I'm never letting that go. You can never take that away. Anyway, awesome job. For those people who are watching, go watch that first half of his talk when he covers all the other types. I could not have done that better. It was beautiful. It was objective. Thanks for being here, man. Have a great year. I'm so happy you've been a part of this.
And thank you for the invitation again, and certainly we'll be in touch.
Great. Thank you.
Thank you, Dr. Helfand, and thank you, Dr. Moyad. That was so helpful. If you would like more information on any of our speakers, Dr. Helfand, Aquablation, or the resources that they talked about, please check out our website at PCRI.org, and you can click on the Men's Health banner on the front of the website, and it'll take you to our conference page where you can learn more about our sponsors, who we would also like to thank, Bayer, Janssen, and Dendreon. Thank you so much for supporting this conference and allowing us to make it free. But it's just a really great way to reach out and get some resources. You could also reach out to our helpline there if you guys have specific questions about your prostate cancer case. Now, we are going to have Mr. Shannon Sharpe. He has 6 million followers on his YouTube channel with his podcast, Club Shay Shay. He's a 3-time Super Bowl champion, and he's in the Hall of Fame. It's absolutely incredible that we were able to partner to have him here today. We're so excited, and Dr. Mark Moyad is doing an incredible interview with him. We're so excited, so welcome to the conference, Mr. Sharpe.
Okay, I gotta sit back. This is a dream come true, baby. Dream come true. You know that? I want to welcome Mr. Shannon Sharpe. Can I call you Shannon, or do I call you Mr. Sharpe?
You can call me Shannon.
Okay. Shannon, thank you so much for being a part of our program, the PCRI, the Men's Health, a message getting out there globally to men and their partners, and make sure that we do the right thing. But first, if you don't mind, I want to talk about some things before we talk about health. And we only got about 30 minutes. I wanted to make sure I bring up a few quick things. I got a couple quick signs for you. I've noticed you for a couple of years, actually, and I've been able to interview a lot of pro athletes. I've noticed you should have a nickname called Mr. Shannon, always looking sharp. And I want to say happy birthday, because I was looking at things, and it looks like you had a birthday in the past few days. Did you have a good birthday this week?
I did. My birthday was Wednesday. Turned 56 years around the sun. So life is good. God is great. Life is good. Families, everybody's in great shape. And so I'm very, very happy and very excited.
That's great. Did you get any nice gifts? Anything nice we can send you? But
people, they always ask me, what do you get the person that has everything for a gift? I say more of everything. So no, I'm good. I'm good. The kids called and checked in on me. My brother and sister, my mom, everybody checked in on me. So that was all the gift that I needed. Everybody's healthy. So that's a great gift.
That's awesome. So I just want to say happy birthday, and thanks for letting me call you Shannon. The reason I said always looking sharp is not actually a joke. I've always found it interesting that when I watch television and I watch a little of other people commentating, it doesn't matter. It can be doctors, it can be athletes. You always seem to have just the finest clothes. I mean, you just seem all trim, neat. Like, where does that come from? I mean, you look like you're in your Sunday best.
Well, it helps when you stay in shape, and when you spend the kind of money that I spend on my wardrobe, you want to make sure that they're fitting nice. Obviously I have a great tailor that makes sure that everything is fitting the way it's supposed to fit. I want to look professional when I'm on television. I want people to know that there's someone that there's a professional, that he takes his job very, very serious. And so that's one of the things my grandfather dressed impeccably when I was growing up, and I always wanted to kind of be like my grandfather when it came to dressing and the way he cut his hair. So I just transferred over, and once I started making good money, I started putting a lot more money towards my wardrobe.
I mean, it looks incredible. It's interesting. Some people will go with all sorts of things, but you always seem to be in that suit and tie or bow tie, and I like it. It's very classy. So I just wanted to say people are noticing. All right.
Thank you.
Now, if I had to ask you one question over the next 30 minutes or 25 minutes, one question only, I thought, what's the question I want to ask you? Now, keep in mind where I work in general. I'll tell you if they haven't told you. Here's the most important question of the day. And this is what I do. I hold up signs when I interview other doctors or other guests. Most important question that Dr. Moyad can ask you today. Did you think you showed enough love to the University of Michigan football team when we won the national title? Do you think you did? Because I watched that segment after the Alabama game, and you seemed a little bit hesitant. And I just thought, come on, Shannon Sharpe's got to be showing us some love, and I just got to ask you that question.
No, I think you guys proved this year that you were the best team in college football. You got to been knocking at the door over the last several years, and the team hadn't been able to get over the hump, but you guys got over the hump. once you guys got past Alabama, it kind of like a situation where it's like, okay, many people thought it was a foregone conclusion. But you've got, you look at what you guys have been able to do. Continuously beat Ohio State. But the problem that you guys run into is that when you get into the bowl games and when you stepped up, you weren't able to meet that level of competition. But this year, 15-0, it's hard to argue what you guys accomplished this year. So congratulations to Coach Harbaugh. I know he's moved on. Congratulations to the Mission program. It's been 27 years since you last won a national championship. So I think it was it was a very earned victory for you guys.
No, I appreciate that. No, you gave us plenty of love. And since you gave us plenty of love, this is just actually a costume. This is the love I want to shout out. I got your jersey on, so I just put
I appreciate that.
Look at that.
Look
Look at that, baby. 84. There's only one 84. So yes, I thought as long as he's semi-nice to us, I'll show him the jersey I've always had.
Well, thank you. I appreciate that.
Absolutely. So yeah, I grew up in the town of Ann Arbor. It's rah-rah Michigan all the time. It's been my only job, but so because you remind me a little bit of Michigan. And I'll tell you why. When I look at your stuff, you seem to be the Tom Brady at the tight end position in the NFL. And I don't think people understand that, because for our audience, I'll let you explain it, but you were a 7th round draft choice. You weren't really on the radar, and you get drafted. And before you tell us that story, look at this: 8 Pro Bowls, 10,060 receiving yards, 815 receptions, 14 seasons, 62 TDs, NFL Hall of Fame, maybe the best Hall of Fame speech I've ever seen. You can get it as a transcript. We're going to link to it. I mean, it was incredible. But do you want to talk about that? Like, how did you sneak in there? Thank God. And what was going on at that time?
Sometimes all you need is an opportunity. I always felt that I had the ability to do it. I knew I had the drive. I knew I had the work ethic. I knew I had the discipline. But sometimes you need more than that. You need someone to give you an opportunity. And when you get the opportunity, what are you going to do with that opportunity? And so you don't know how many opportunities you're going to get. You don't know how few and far between they're going to come. And so I was just always taught that when you get an opportunity to do something, you take full advantage of it. And so I was very fortunate to go to the Broncos. Coach Reeves believed in me, who was my head coach at the time. And I got an opportunity to get on the field, and the rest of that, they say, is history. I just took off with it. But I just, my desire to be great and to provide for my family was undeniable. And that was the only thing that I really cared about. Fame was not what drove me. It was being able to provide for my family, mainly my grandmother, and get her out of that environment. So there's something to be said for a person that has a desire and to have something greater than him or herself.
But what would you have done had you not been drafted? Because I've got to remind people, it's 7th round. I don't know how many picks are left in that 7th round. I couldn't find it. I don't know how many people are left.
Back then when I came out, Doc, there were 12 rounds when I got drafted.
Oh,
it just recently went to 7 rounds. It was 12 rounds when I came out.
Okay, but when you went into draft day, I don't know what they told you, but what was Plan B? What was, they don't call my name?
Well, even if they didn't call my name, I knew somebody would give me an opportunity. For no other reason, my brother was in the NFL and he was an All-Pro. And so even if I didn't get an opportunity, people someone was going to give me an opportunity as an undrafted free agent. So I was going to get an opportunity. I felt I was going to get an opportunity to get into someone's camp. And then it was going to just be left up to me what I did with that opportunity. Kind of like when being drafted in the 7th round. I didn't get the money that a 1st or 2nd or 3rd round draft pick got, but at the end of the day, I got a helmet and a pair of shoulder pads. And that's all I needed to show what I was capable of doing. Everybody was going to get the same equipment. Nobody else had a better understanding of the offense. We were all starting from ground zero. And so I just needed an opportunity. All that other stuff, but once you move away, you're not at Michigan, you're not here, you're not there. We're now on the Denver Broncos. Now it's about my talent versus your talent. My desire versus your desire. My will versus your will. And we'll see who has the stronger of the wills. Given how I grew up, given the situation that I came out of, it was going to be hard pressed for me to find if there were 3 spots available and there were 15 guys going for those spots. It was hard for me to believe that all 15 guys came from a situation like I came from,
Uh-huh.
overcame what I came from to get to where they got, and had the desire, the discipline, and the dedication. So I felt very comfortable that once I got that opportunity, that I could seize the moment.
And then the first year in the NFL, was that a wake-up call? Were you playing right away? Because the only thing I can relate to, again, sorry, I played Division III basketball, and I remember getting there and going, I was pre-med, but I remember going, wait, these players are just at another level. And this is Division III, man. I can't.
Well,
make it.
I remember going to the bowl games, and there were a lot of guys from bigger schools. And I remember calling my brother and said, even the guys from the Notre Dames and the Michigan, I was like, they're not better than me. They just went to a bigger university than me. And so I just felt that once I got an opportunity to show what I can do, because I've always had supreme confidence in my ability. I never lacked confidence. I just wanted the opportunity. Once I got the opportunity, and so now it's because that's what pro football about. Football is about moving a man against his will, doing something, making him like, he doesn't want to go here. I'm going to make you go there. You trying to beat me, my desire to beat you is greater than your belief that I can't beat you. And so once we got those helmets and shoulder pads, and then we got into the game, and I got an opportunity. It's like, man, he's like fast, he's big, he's strong. He'll try hard. If he make a mistake, he's going all out. And so that's really all I wanted, was an opportunity. That was all I could ask for. And if I didn't seize that opportunity, if I didn't take advantage of that opportunity, that's on me.
Yeah.
But at least I got that opportunity. And then once I got the opportunity, I took off from there.
Oh, I love it. I love it. But Denver's not an easy place to play. I remember when I would go running there as a kid, I'd be out of breath after a couple, I used to run track too, and I would be out of breath just running a mile in Denver. I guess you got used to it, but.
Yeah, I mean, and the Broncos had just come off the Super Bowl loss. They had just lost to the 49ers the previous year. And so they was pretty much bringing back all their receivers and things of that nature. So I really had my work cut out for me, but I just went out there and gave it everything that I could. And at the end of the day, and that's what it goes, because my competition, even though I was competing against those guys, my main competition was me. Because if I gave it everything I had and I just didn't have enough to make the team, I can't be mad at anybody. I just didn't have enough to make the team.
Okay.
But I felt very confident that when it comes down to it, if someone is just more talented than you, there's nothing you can do about it. And I felt that, look, there might be someone more talented, but it's hard for me to believe that God gave somebody more talent, more a harder work ethic, more desire, a greater discipline. He didn't give somebody all four of those things more than me. He might have given somebody one or two of those more than I. But all four, well, then I don't really have a chance, because if somebody's more disciplined, more determined, more dedicated, and had more God-given ability, well, I got no chance.
So when the season ends, the first year, whenever, there's this off season, it's a period of time. What did that look like for you lifestyle-wise? Was there a group that partied a lot? Was there a group that was super disciplined? I mean, what happened in off season, or was this just go off season, just working out and taking care of your body?
Well, I tell people this all the time. Success is an addiction also. And when I tasted a little success in my rookie year, I became obsessed with it. That was my passion. That was my desire. I was really never a partier, but they told me they wanted me to gain a little more weight, which was no problem for me. That just means I needed to get into the weight room even harder than what I had done it the previous year, because I was trying to control my weight. Because I was a wide receiver. I got drafted as a wide receiver, and they moved me to a tight end halfway through my rookie season. So they told me coming back that I was going to be full-time tight end, no more wide receiver. And so now that gave me an opportunity to get into the weight room. I took my diet a lot more serious. I had an understanding of the things that I should eat, what I shouldn't eat. My training ramped up. And so for me, once I tasted that success my rookie year, it was really easy for me to go into the off season knowing what I needed to do to come back a better Shannon than I was my rookie season. So when I came back my second year, I was a totally different player. I had a greater understanding of the offense. I had a greater understanding of what they expected from me. I had a great relationship with John Elway, who's the quarterback. And so our relationship just took off. We kind of clicked a little bit my rookie year. But once I got back that second year, it was just like everything just slowed down for me. And I was able to just go to the next level because I wasn't thinking anymore. I can just let my God-given ability take over, and I can just react and just go play the game of football.
Oh, I love that. So I'm going to give you some quick separate little questions here. Kind of has to do with your playing years. And then I'm going to shift it into just taking care of yourself to finish that section off. And then we'll talk about your campaign at the end, if you don't mind. So these are some random questions I thought of. And again, I just thought they would be fun. Who would win in an arm wrestling match between me and you, for example? You think you would beat me? I think
Yeah, I feel comfortable in my ability against you in that situation. So I don't know if there are very many doctors that can beat me in an arm wrestling competition. I'm sure there are some out there somewhere, but I don't think you're one of those guys.
No, I appreciate that. I'll take that as a compliment. I should have said, how about you and Paul Feinbaum, or like you arm wrestling Stephen A. Smith? I should have just said that.
I definitely think I can get Paul. I definitely think I can get Paul.
I think you could probably get almost anybody. Hardest hit you ever absorbed. Do you remember that day? Do you remember the hardest hit you ever took? Like a hit you went, oh man, I don't know if it was a concussion. I just wonder about that.
Yeah. I've taken a couple of those. I took one, I think it was 96 from Orlando Thomas, rest his soul. I took a knee to the chin.
Oh.
I took another, I took a couple of hits in 96. I took one from a linebacker. I can't remember his name, from the Raiders. Knocked my helmet off. I'm quite certain I had a concussion in that one. I took one from a guy named Gary Jones in 96.
Wow.
That was 96 was a great year, but it wasn't a good year for hits because I got my clock cleaned a couple of times in those. But you know, the thing is that as the game of football has evolved, they do a better job of diagnosing concussions. Guys have a better understanding and guys will come out of the game now when they get concussions, and so they do a better job of evaluating that. Back then, they didn't have the knowledge and the understanding of the severity of concussion and continuous head trauma. So they do a better job. The NFL has done a better job of diagnosing it, treating it, and allowing guys to sit out the remainder of the game and even take a week or two off once they get a concussion. So, but yeah, I've taken pretty serious hits in my time, and but I was able enough to bounce back.
So what I wanted to know is, watching these tight ends, you know, Michigan, Ohio State, you know, they're big guys, and I always wonder, is there smack talk going on in your day? When you lined up, would you talk to your opponent because someone's lining up against you sometime, or would you just run your route? Because I've never seen that on an NFL film, someone hooked up as a tight end, but I'd like to see it, and maybe it's happened.
Oh yeah, guys talk. I mean, obviously we go in. It's very competitive. It's macho y macho. It's mano y mano. They're saying you're not going to do this. I said I'm going to do that, and so yeah, it gets heated. But that's the level of competition, and the higher the stakes, the greater the competition. And probably for the most part, I don't know how everybody does, but I was a talker on the field. It got me going. It got my team going. And yeah, but I was a talker.
You did seem to be a talker. I watched this film on YouTube. I think it had 30 of your best touchdowns. And you know what I noticed, besides the fact you scored a lot of touchdowns? Has anyone ever told you this? I didn't understand your touchdown celebrations. Will you explain it? I didn't get it, which means, what I mean by that, one time you were slapping high fives with the mascot.
Yeah.
Right. Another time you're writing it with a Sharpie, and then another time you're doing this dance. And I'm going, did you have a signature move when you scored, or was?
No, my favorite comic book superhero was the Hulk. So I did that a lot. But it just all depends. I mean, one time I was by the mascot. Our mascot, obviously, with the Broncos, was a horse, and I ended up giving Thunder a kiss. I remember, you know, pretending I was on the phone. I was calling my grandmother, telling her I had scored another touchdown. So it just all depends on what was in close proximity and what came to my mind at the time.
It's interesting because today, you know, a lot of people have these patented moves, but you had.
Yeah. I didn't have time to rehearse all that stuff. I was too busy focusing on trying to win football games. So there was no rehearsal during the course of the week. Like, if I score a touchdown, this is what I'm going to do. It was just spontaneous, and I went with it. But I don't have a problem. I mean, the celebration that some of the guys do are now very entertaining. I like it.
Favorite coach, player, friend. Is there someone that sticks out when you play ball? It doesn't matter if it was at Savannah State. It doesn't matter if it was at your high school. Is there someone that just you go, man, they're one of my favorites of all time? Maybe the way what they said, what they did, they were just, I love them.
Well, yeah, my high school coach coached my mom. And he's had a very personal relationship with my family for over 50, 60 years. And so obviously he coached my mom, he coached all my uncles, taught my aunts and them, in high school, coaching my brother and I. Coach Davis, who was my college coach at Savannah State, was very instrumental in me. He believed in me and thought from the very first time that he saw me that I could go play in the National Football League. Coach Reeves probably, although, Coach Reeves was my first NFL coach, drafted me, believed in me, gave me an opportunity. Wade Phillips, all my coaches, for different reasons, I got something different from all of my head coaches, be it Coach Reeves, Wade Phillips, Mike Shanahan, Brian Billick. Obviously, my first two head coaches were Coach Hall in high school and Coach Davis in college. I took a little something from each one because each one was different. And I appreciate every bit of wisdom they gave me. And I took that, I took what Coach Hall had taught me at Glenville High School to Savannah State. And then I took what Coach Davis taught me at Savannah State to Denver. And each coach along the way, I took a little bit of each one. Obviously, my two best friends are Darryl McCormick and Keith Burns. Bucket's been my friend. We were college teammates. And Burns was my teammate in Denver. So we've been friends probably 30, 40 years. We still talk 2 or 3 times a week. It's a rarity that you have friends for that length of time. And we don't see each other much because, one's a coach, the other's in the trucking business. Obviously, I'm out here in California and I'm here, there, all over the place. But that relationship, that bond that we established 30, 40 years ago is undeniable.
Oh, that's great. So I hate to paint you in a corner, but I always ask this of the students because, it's funny. We sometimes live in such a negative world. And I think of my dad. My dad was tough, man. We were scared of him.
Yeah.
But I remember he made one comment to me one time and it never left me. I always ask people, I don't know if they've thought about it. Can you pick out the nicest thing that anyone's ever said about you? I mean, where you went, where did that come from? And so as you're thinking, I was with this, my partner, and I brought her home and this and that. And my parents weren't sure. And finally, one day, my dad brings me into the garage and said, you picked a winner. I just can't believe it was the nicest thing. And I just went, that is the nicest thing. And I always am curious, is there something that stands? Someone said something to you, you went, darn, that is really kind.
Well, I think the thing is that when people say my grandmother did a great job with my brother and my sister and I, I'm a hard worker. Nobody is disciplined and as hardworking as I am. It's just things like that. It's not so much where he's a great this. Obviously you want to be a great, great person, a great friend, but you have to realize that you're not going to be everybody's cup of tea. And I think for the most part, anybody that's ever encountered me, the one thing they can tell, they take from any conversation is that they can tell that I'm a very hard worker. I'm very determined. And I like to think that I'm a good person, but to each his own if you don't believe that. But I think the biggest compliment is that my grandmother did a great job raising my brother, my sister, and I.
So that's Mary Porter.
Yes.
So this is a good segue to the last part. And I'll tell you why. I've interviewed a lot of people just for medical meetings, and it's been a really fun part of my job. And I was probably the most excited, at least in my top 2 or 3 of my 30-year career. I was most excited to interview you. And I'll tell you why. It's not because of the talk. It's because I work in the lifestyle game. And what I've noticed about a lot of doctors, and what will happen is like a patient will go to a doctor and say, he's telling me to, or she's telling me to lose weight and do this and that, but look at my doctor, he doesn't do anything. And my point of that is I've been around a lot of athletes. I played a little bit of ball and a lot of people let stuff go. And I understand people get injured, but what I've always noticed about you, and maybe this goes back to your grandma and just kind of doing the right thing, is that you were always kind of, it wasn't about talk, it was about action. I mean, you look the part. I'm 59 and you're just a little bit younger than me, but you look the part of fitness. And so has it been that way your whole life? I mean, I don't know. I mean, you got to correct me, but I don't know a single pro athlete that I have interviewed that at 56, 57 still look like they could play ball. It's stunning. And so I don't know if there's a question in there, but that's what I think when I think of you.
Yeah, I think that goes back to the discipline. That even though I'm not, competing against top tier athletes, I still wanted to look like. I just always thought that, like, once I was done with football and a father walked by with his son, he would tell his son, that's Shannon Sharpe. He used to play in the NFL. And his son would say, "Dad, what position did he play?" And he would say tight end, and I would look like a tight end and not an offensive or defensive lineman. So I was disciplined enough that I understood that although I was not working out, a lot of things have to change because you can't have the same eating. Me, I was very disciplined, so I could, but you can't have the same eating lifestyle if you're not going to have the same workout lifestyle. Right. And so I think that's where a lot of athletes run into problems that they want to eat the same, but they don't want to work out the same. And as we start to age, you either have to eat less and work out harder, or you have to do both. So sometimes you can eat the same, but you got to work out the same, or you could eat less and still carry and still work out. But I found that I wanted to do both. But I don't look at it as a task. I don't look at it as a chore. I enjoy it. That's my escape. That's where I get away. I don't have to think about anything. I don't have to worry about the job. I don't have to worry about anything. My mind is on that 1 hour that I get to myself, that I can get in my own world, my own little cocoon, and I can just focus on me. This is my me time.
That's beautiful, because when my kids were crabby or somehow I didn't get along with someone, I would say, you know what, you're just one workout away from being in an excellent mood. So why don't you go work out, right? I think world leaders should work out before they discuss things. I think partners should work out before they have a fight. I think it's the ultimate solution. So let's talk workouts here toward the end. You could hire me as maybe a PR person that works with your team. Here's what I thought of you, because this is the ultimate compliment. I just am amazed at your age and what kind of shape you're in. I've watched some of your workout videos, but I thought, you know what? This is all about getting you in sharp shape, not ship shape. Honestly, I tell people, do you know what sharp shape looks like? Sharp shape does not look like the average 57-year-old. Sharp shape looks unbelievable. And then I thought the perfect tagline for you for sharp shape is where talk is cheap and action is the only currency you accept here, right?
Absolutely.
So that's what I think of. So let's talk about sharp shape in the last 5 and 10 minutes, because this is what people want to know. I want to know it. I went running 5 miles this morning. I felt pretty good, but I don't know if I'm in sharp shape. So what are we doing here to look like you? I mean, look, do you want to start? Like, what are you doing? Are you doing something aerobically that we don't know about?
Yeah, I do cardio. I have an assault bike. I have a row machine. That's basically, I've had both my hips repaired. So I can't do the plyo or the pounding, but I can do something that's non-impactful, like the row machine, like the assault bike. So I do that. I still lift about 4 times a week, not with the same intensity or ferocity, because I'm not training for anything to that. Now it's just to maintain a certain level of fitness. But I don't know what I would do if I didn't do what I've done for the last 40 years. And so that's the thing. Some people I couldn't wait till like when I playing football, I played football for free. They paid me to train. I was like, man, you mean to tell me I could do this and you're going to pay me for it? I really like this. Normally, you don't get paid to do something you like. A lot of times people have jobs. They don't really like the job, but they need the check. I really love work. I really love training. And you're going to pay me an enormous sum of money to do that? And so even though I don't get paid, it's so ingrained into who I am as an individual. It's the fabric of me. And so I couldn't imagine myself not working out. And so I look forward to it. I look forward to getting in the gym. I look forward to doing cardio. things of that nature, because it's just a part of my everyday routine now.
So if you have to do something today or this week, you're doing cardio. Let's say how many times a week you doing cardio and for how long?
I'll probably do cardio. I'm about to get back into a routine because I want to see something. I want to see what I can do with my body at 56. So I'm gonna start doing cardio. I'll do cardio 4 times a week. I'll lift 4 times a week.
Wow.
I'll do that for a month, and then I'll have a good sense of where I am. Do I need to back up the cardio? Do I need to pick up the cardio? Do I need to pick up the intensity in the weight room? So I need about a month of 4 times a week, each cardio and lifting, to gauge where I need to go the next 2 to 4 weeks. So that's kind of how I do it. I have a very good sense of my body, and my body will respond. Just an hour. That's all I need. I don't really have much time to do anymore. I don't have the time like I did when I was playing, when I was in the gym 2 hours a day, or I was training basically 2 to 3 hours a day as far as weights and run speed work. Now all I just need is an hour. I get an hour in, I'm fine.
So you're talking about an hour almost every day of the week?
Yeah, about 4 days, 4 or 5 days. It all depends if I'm traveling or not. Like right now, I'm about to be stationary for a better part of 2 months. And so, yeah, I'll do 4 to 5 days a week, cardio and weights.
Okay, so the cardio you do, it sounds like you do all sorts of cardio.
Yeah, I'll do interval training. I really like HIIT. I like interval. I like doing something for 30 seconds, a minute. Then I'll take 30 seconds or a minute off. I'll do that, or then I'll do like a volume where I'll do say 1,000 meters on the row, or 1,500 meters on the row, or 500 meters on the row. Take a little more time, so I'll do that. Or I'll do the assault bike where I go all out for like a minute, take 2 minutes off. Just trying to switch it up, trying to keep my body guessing on what's coming next. In the weight room, I'll do some of everything. I'll do kettlebells. I'll do conventional barbell stuff. I do machines. I just switch it up, whatever I feel like. I'm a field type of guy now. I don't really have to do anything specific because I'm not training for anything specific other than just general health and fitness.
So you do upper body, lower body?
I do.
You do is it mostly free weights?
It's a combination. I don't do as much the free weights I do mainly is dumbbell. I don't really do a whole lot of barbell stuff anymore. More of it is like kettlebells, or I do goblet squats with a dumbbell or kettlebell. I'll do Bulgarian split squat, normally with kettlebells. I'll do leg press, leg extension, stuff like that. I don't do a whole lot of free weights anymore. Really, the only free weight for like barbell is probably like bench. I don't really do that a whole lot anymore. But I just enough to keep me tight, keep me tense.
Wow. I mean, so, okay. And then just lifting weights, how long does it take you to get through a routine just for your weightlifting? Is that?
I'm only going to do an hour. I'm gonna speed. I don't have that kind of time because I got so much other stuff I got going on. I just don't have time to just kill. I'm in the gym for a specific amount of time. I understand I got an hour. I got to maximize my time. I don't count time. I make time count. And so when I'm in there, I got a specific task. I know how many sets I'm going to do. I know the exercises that I'm going to do. I hit those and I'm done.
Yeah, it's so funny you say an hour. Do you know how many people our age, your age, my age, that put in an hour? I don't know anybody.
Well, that's all they have to do.
I know. I know.
I think people find the time to do what they find is important.
Yeah.
So right now, training, working out, whatever you want to call it, that's really not of the utmost importance to them. So that's why they don't do it. They find other things they're more interested in, maybe going shopping or going on vacation or whatever the case may be. But I still find that training, getting in the gym and hear my heartbeat and hear the weight clanging, that still does it for me.
Beautiful. I love it. Is there a certain song that gets you fired up? If you go into a gym and they're playing it, oh, you're just going to go. See, I've got a couple of those. It's like, oh, old school.
I don't really listen to music. Like I said, I just want to hear my heart. I want to hear my breath. I want to know, like, okay, I'm getting a good workout. I can tell if I'm getting a really good workout. I feel it. I've done it for so long now. I know my body. I know what my body is capable of doing. I'm going to push it, but I'm not going to overexert myself. I don't want to have surgery unless I absolutely have to. and tearing a pec or a bicep or something like that. I'm past that now. I'm past that. I'm not trying to have any surgeries because I'm trying to impress someone in the gym.
Yeah, and how many of your friends, how many of my friends do I know that think, 57's the new 37 and they end up ripping something?
Yeah.
I don't understand that. And I always tell people, if you saw a 57-year-old car, you wouldn't try to beat it up and take it 100 miles per hour.
Exactly.
You would be
Exactly.
nice to it. And before we talk about the prostate and men's health, how about in terms of anything diet-wise you like to enhance your workout with, a shake, a certain type of food? It doesn't matter if it's healthy or not.
I
It's
try to eat.
go-to.
I try to eat my calories. So I have someone to prepare my meals. So it's my staple is chicken and turkey, lean cuts of meat. So I try to eat my calories. I don't really like drinking them. I understand that
Yeah.
sometimes I have to get a shake because I can't be eating in a meeting or something like that. But for the most part, with my schedule, I kind of set my schedule. So I'm able to always eat solid foods.
So in terms of over-the-counter protein powders, anything else that people always look for a secret, that's not you, or that is you?
No, like I said, I try to eat my calories. I mean, obviously there are times that, you can't eat chicken, rice, and veggies, and you'll grab a protein shake. I grab a protein shake on the go. But for the most part, because I'm able to set my schedule and I build everything around my training, I'm able to eat solid foods.
Are you ever going to come out with this the Sharpe shape system? I mean, honestly, I'm just throwing this out there because do you know how many guys my age look at you? Like I watched your workout video outside using just the little hand weights.
Yeah.
And that was impressive. So anyone watching this, go look for Shannon Sharpe. It said the dungeon or something. I don't know what it
Yeah.
said.
Yeah.
Is that right? And you're doing
Yeah.
these hand weights, and I'm going, all right. I mean, I know you don't have to answer the question, but I just think there's a lot of 50, 60-year-olds out there going, I need someone to look up to. Talk is cheap. Shannon looks like he knows what he's doing. I hope you do that. Maybe you are going to do that. I don't know.
I was thinking about it, but the question is, are you as determined? I mean, is your desire to be in shape greater than your desire not to be? Because I mean, I can tell you what to do, but everybody always tell me like, man, what do you eat? What do you do? And then when I tell them, they got to drink their beer, they got to eat their pizza, they got to eat their burgers, they got to do all this other stuff that's not conducive for you wanting to look like you tell me you want to look. So, yeah, I mean, sure, I thought about it, and I might give it some consideration again down the road. But right now, I have so many other things on my plate that I'm just worried about trying to make sure I stay in the best physical condition I possibly can.
Well, I got to tell you, it's impressive. So why don't we finish off, unless there's something else I missed asking you, why don't we finish off with this campaign and why you got involved in men's health? What's the main message here? Like I again will think, you'll be surprised again, because I've been doing this a while. People will look at you, a whole new audience globally too, and they'll say, I hear what he's saying. He's in shape. He exercises an hour a day. And that's what you look like at 57. You're going to motivate a lot of men and women in their 50s and 60s. So anyway, I thank you for that. So let's talk your campaign.
You've been aging me a whole year and 2 days. I just turned 56.
Oh, I'm sorry. I didn't do the math right. I know, but you're 56. You look 40.
I just turned 56 on Wednesday. And that's the thing. And that's what that was so surprising to me when I got the diagnosis, because here I am eating the way I eat, train the way I train, get proper rest, drink proper water. And they say it's a silent killer. You're right, because I had none of the symptoms. I didn't have the frequent urination. I didn't have blood in my urine or anything like that. It was just a routine checkup that I was getting before I was going to relocate to LA, and they found it. So, and that was the thing. And I understand that prostate cancer is really, I think we're two times more likely to develop prostate cancer than our white counterparts. And so for me, I've always, like, when I found out I had it, I didn't tell a whole lot of people, but the people that was closest to me. But I knew I knew there were more people that had this disease, especially in my community, the Black community. Mm-hmm. And I wanted to let them know that it's early diagnosis probably saved my life. And don't be afraid. Growing up, a lot of times we didn't have the access, or we didn't have the means to go get checked out or to the greatest medical treatment. care. But early diagnosis and detection probably saved my life, and probably wouldn't be here had I not gotten a routine checkup like I had been doing since I was 35.
Wow.
And so I got diagnosed when I was 48, and knock on wood, I've been in remission since. So I just wanted to be someone that guys could look up to, let them know it's what you don't know that could possibly kill you. We already know the things that could kill us that we know, but it's what you don't know. And so don't be afraid to go get checked out. Don't be afraid to have a conversation with your doctor. Talk to your brother, talk to your uncle, your father, because it could save your life. And so when I got an opportunity to be a part of this program, this platform, thanks to Janison, I mean, it was, and they didn't know. They just wanted someone. Here I am, I'm Black, I'm on television. I could speak, I could, this is what I tell people all the time. I said, anybody can speak, but anybody can talk, but very few people can speak. And so when they asked me to be a part of this, they had no idea that I had been diagnosed and treated for prostate cancer. I didn't tell them till later. And I remember when I was telling them, they were all in the back. They couldn't believe it, because they just thought they were getting someone on television with a name that could get their message out. And here it is, the best spokesman for this, because he's lived it. He was one of the guys that got treated, went and got his checkup, got early detection, got treatment, and he's able to tell the story. So he's living proof. Here's someone that can not only can tell you what you should do, he's gone through it. There's something to be said for someone that's gone through something, because there's nothing like that. There's nothing like experience from someone that has gone through it.
You know who else didn't know you had it?
You.
I didn't know. Because, I have to interview all these docs. So I thought we would talk lifestyle. I thought we would talk football. I thought we'd talk Harbaugh. And, I went to Catholic school with him. And I thought we'd talk fun stuff and then talk a little bit about PSA, how easy the test is. And I didn't know. I didn't give it two thoughts to think about. I thought you were just, I didn't realize that. So that's an incredible story. So at 48, now you're 56. See, I gave you 56. You're doing fine. There's no cancer.
I'm doing great. None.
How's that?
I still get checkups.
Yeah.
I still get checkups, doing my blood work. I was doing it for the first 2 years, doing it twice a year. After that, I went to once a year. So I get my checkup, just got it in February. Everything was good. So far, so good. I've been very, very fortunate, been very blessed.
So they caught it early. It wasn't that aggressive. It's done.
No, it was just in the prostate. It hadn't spread to any other parts of my body. Found the treatment that was best suited for me and the type of cancer that I had, and the location in which it was situated in. And we got that done, and got the test. Was getting the test, came back good, and I've been good ever since.
You have a lot of people ask you about your experience. I
had a lot of people to reach out and says, man, I went through the very same thing. I'm glad you're speaking out. A lot of people have DM'd me. A lot of people have pulled me to the side. And so that's always good that you can share a story with someone.
Oh, I think it's incredible. Here I am. I mean, we're talking all this. I thought you were a big promoter of men's health, which I know you are, but I don't know if you have another story from that. I mean, it's a pretty compelling story. And so now you get checked regularly. I don't know if and the advances in this field are unlike anything we've ever seen in the past 10 years. It's just incredible. I mean, it's incredible. So the other thing that makes me think about now that I didn't know that is you're an incredible spokesman, because what we know is there's a consistent message right now. We can't do the trial, but the message is there in the data that heart healthy is prostate healthy, meaning the better you take care of yourself, including exercise.
Yes.
If you've been diagnosed, you have a lower chance of being diagnosed with aggressive disease. And if you continue to take care of yourself and you've been treated, you have a lower chance of it coming back.
Correct.
Right?
Yes. And I do. And that was the thing, Doc, that left me puzzled, because here I was so health conscious, trained, ate properly, nutrition, rest, drank plenty of water. But the thing that was working against me is my family history.
Exactly.
My father died at 39 from cancer. He had two brothers that barely made it to the age of 50. And so I knew I was working it. That was against me. So that's why I started getting tested at 35. They advise you to start in your 40s. But knowing my history and the close correlation between my father's and his brothers, directly traced to me and my brother, I started getting tested at 35.
I mean, it's kind of it's brilliant. It's because we've had 3 or 4 big studies where they knew the family genetics, including my family. We had some bad genetics. And what they've learned is when they follow the genetics, they find in these families, there is a higher probability of being diagnosed with a less aggressive tumor if you do something lifestyle-wise to combat those genetics. Like I always say, a pair of genes, everyone thinks genes means that's it. That's what you're going to get. But sometimes genes are the kind of type you put off and on, you know? In other words, you can do something about your genes. There's a probability of that. And so what we're seeing in families in these studies is that taking care of yourself heart healthy wise may essentially turn a really aggressive tumor into something that's a turtle.
More manageable, yeah.
More manageable. And maybe that was your story, but at the end of the day, you know, you were doing what you needed to do.
Yes. Yes.
And so maybe that's the message of the program, because I understand people want to eat their junk food, but if people say all the time, I got these bad genes in the family, what am I going to do? I'm going, well, actually, you know, we've learned a lot that you might be able to do something. Right?
I agree. And like I said, I knew some of the history with my father and his brothers, my uncles. And so I tried to stay away from that. And but like I said, I think the thing for me is that I'm not hard-headed. I was in a better situation probably than they were, as far as being able to get the treatment, probably being able to get the medical treatment that they probably weren't able to get. Me not being afraid to have a conversation with my doctor, that definitely helped building a relationship. And so, you know, I would talk to my doctor. Sometimes we would just talk about football. We didn't talk about, okay, my health. We would talk about football. We talk about sporting events. He would ask me about my family. I would ask him about his family. So I kind of built up a relationship where it was just more than just doctor-patient.
No, that's beautiful. That's just an incredible story. As we finish here, how do you think we overcome that barrier? Do you still think there's a lot of skepticism of the medical field for people in terms of just being tested? And or is maybe I don't know the solution, but maybe you have it.
No, I don't have the solution, but yeah, there's still some skepticism. There's still some that in our community we don't have the access to the medical that everybody should be. And you know, a lot of people don't want to put their family in debt. You know, medical is, you know, I'm very fortunate that I have medical insurance, and what's not covered by medical, I'm able to pay for it out of my pocket, no questions asked. But everybody's not as fortunate as myself. And so I understand, but yeah, there is some skepticism between, patients and their doctor. Hopefully over the next several generations, we're able to get past that, and men that look like me will not have a problem going to the doctor and getting checked out.
See, that just changes the game. Again, you're probably sick of me saying this, but the fact that I didn't know, and the fact that you're a spokesperson for it, and the fact that you take care of yourself is just incredible. Because I can't tell you how many spokespersons I've worked with, and you know, the idea of getting a workout in or taking care of themselves was just not on the agenda. It was just not there, right? So that's, like I said, your currency is action. It's like your current. I know you do a lot of great things with First Take and all that, but like, I don't know if I brought you over, and I'm sorry, but I think you kind of stunned me with, I didn't realize that you had been through it. It was 8 years ago. Is there a question you wish I would have asked you, or something else in your message that you?
No, I think you did a great job. I mean, we talked about a lot of different stuff, but I think that was the biggest message, that to make sure that we get men tested, black, white, especially in the black community, because we're 2 times more likely, or I think 1.5 or 2 times more likely to develop it. But it's, you know, it's a treatable form if detected, if we catch it early. Yeah. That's the thing. I mean, we catch it in its early stages, get the proper treatment, There's I think the 96% survival rate. I'm part of that 96% because it was detected early. I got treated, and here I am to tell my story. So yeah, it was when they asked me to do it, I was excited because this was going to give me my opportunity to share because I'm not so sure I would have ever shared the story had I not been asked to be a spokesman.
Yeah. Wow, just an incredible day. I really appreciate the time. I appreciate you giving the love to Michigan. I appreciate your stories. I appreciate the fact that you shared that. And like I said, it's a real honor today. Thanks for being a part of this.
No problem, Doc. Have a good one.
You too.
Thank you, Mr. Sharpe, and thank you, Dr. Moyad. That was awesome. If you would like to find out more about the campaign that Mr. Sharpe talked about and Club Shay Shay, his YouTube channel, we'll go ahead and link that in the description below. Now, we have an extended Q&A with our moderator, Dr. Mark Moyad, who's done an incredible job moderating this conference. He does everything from help us pick speakers to topics and just fill in the gaps of what we need to educate people in. He works tirelessly on these conferences, and we so appreciate him. And he's the Jenkins Poe Kempner Director of Alternative Medicine Education at the University of Michigan Department of Urology. And he does really just an incredible job volunteering for PCRI and helping us with so many different factors. And another volunteer for PCRI is our executive director, Dr. Mark Scholz. And he has, founded this organization over 27 years ago. And because of him, we have this YouTube channel. And because of Dr. Moyad, we have all of our speakers together. They just do a great job of really bringing the oncology and the urology, sides of life together so that we can get both perspectives and really just provide a lot of education for men all around the world. We appreciate that they volunteered their time today, and they are doing an extended Q&A answering your questions. So without further ado, here's Dr. Mark Moyad and Dr. Mark Scholz.
Here we go. That's all I got to say.
Hey, Marco, so good to see you.
How you doing?
How are you doing up there in the great far northeast reaches of our beautiful country?
Well, I am in perhaps the most beautiful area in all the state of Michigan. I'm not going to reveal where I am, but people know I like to spend a lot of time up north. I call it God's country or whatever you want to call it. All I know is I've never been happier watering plants. I mean, what does that say about where I spend my time? I water these Norway spruces and I think that I'm in heaven. And I think, wait, this might be a lot more fun than writing a book actually, or doing a journal article, but at least I think this all comes around to you because you still haven't come to visit me. And so I will continue to apply the guilt toward you.
Well, it sounds like I just missed. Don't you guys have a cherry festival or something like that going on up there? That I'm sure they have the best cherry pie.
Well, yeah, they have great cherry festivals every year around July 4th. That's up in Traverse City. It's a little bit of a ways away, but it's the big event sort of up north Michigan. And I don't want people to feel guilty eating cherry pie. Cherry pie is great, right? It's a nice reward. Did you know cherries actually have melatonin in them? So they can advertise that they've got a little bit of melatonin. You eat your cherry pie, you sleep 8 hours, your health better the next day.
Well, we should swing back and talk a little bit about melatonin. Insomnia and the patient clientele, the age group, aging people is a major struggle for many people.
Yeah.
But I think we're going to start off and talk first about wonderful Dr. Rice, who you invited and whom you've had a relationship with for many, many years on the topic of addiction, which is not the first thing that comes to mind when you're thinking of men's health, BPH. But what a compelling presentation. And the statistics, I think he said 1 in 7 people are basically a prisoner to this terrible situation. It was incredibly fascinating, and for me personally, I see the spin-offs in terms of all the things we struggled with. You talk about sugar addictions.
Yeah.
This is I used to smoke cigarettes, and that was I used to smoke cigarettes, and and I am more proud of having quit smoking than I am of having graduated from medical school. It was truly harder for me to quit smoking than it was to go through. I enjoyed medical school actually, but these sorts of struggles for us, I think we kind of all personally know that one thing that holds us a prisoner and that we'd like to get free of, whether it's too much sugar or maybe some of us struggle with anger issues or whatever. I think there's relevance to this whole addiction theme for all of us, and the applications for trying to get free, I think the principles are the same for all these different areas.
Well, I can just tell you that in all my years working with PCRI, which I think now is about 95 years, I think my whole life has been just dominated by this organization, but I have never felt so uncomfortable asking a friend to give a lecture, which is why I knew I had to invite him, because I don't need to go through everything in terms of who you know or who you don't, but we all know someone that has been devastated, and families that have been devastated by addiction. And we all have friends, colleagues devastated by addiction. And I just thought, that was the elephant in the room in cancer that we don't talk about, because we're not, like I said to Dr. Rice, we're not talking about someone having marijuana at end of life. This is not what we're talking about. We're talking about self-medicating. And if there's anything I see from a public health standpoint that worries me more than anything, whether it's in prostate cancer or any other facet of life, and it goes all through all the generations, young and old, I see this penchant for addiction that's hard to get out of. And I just want to give the background story. I just thought, I'd never heard a lecture on it at a cancer meeting, especially patient meeting, public meeting. It's time to do it. This is either going to be great or it's going to be not great. There's no in between, but at least we're going to now set a new standard for awareness. And that's what we did. And I didn't expect, like I told them, I didn't expect to be able to answer questions. What can I add? I'm this research doc, public health guy. Like, what am I going to add? But I can add the personal standpoint. So I know it's a long answer to your short comment, but it's so important for people to understand the background here, because I held up this sign with him and just showed him some of the common addictions, right? And it's not like we haven't in past PCRI meetings talked about some. So, for example, alcohol addiction. It's just incredible to me. Everywhere I walk in life, how so many people, including I think it could be colleagues, I think friends, somehow don't realize that they may have an alcohol addiction or are not going through it. And so we did this video at PCRI, if you remember, we did it many years ago that got a lot of looks. I called it ABV plus V equals OMG when it comes to alcohol. There's a phenomenon going on in society where you take the alcohol content and you raise it, whether it's beer or other drinks, and then the volume goes up, and when you and I were younger, the idea of having a beer or two, wow, that was a big deal. And now these beers have double and triple the content, and so do some of these spirits, and the volume being served is higher and higher. And what happens, and he explained it too, is that when you concentrate the drug more and more, you don't dilute a drug, you concentrate it, the chance that it affects receptors in the brain and creates addiction goes up and up. So what I think we're seeing in all throughout medicine, for example, and I wish we had more time with it, is an addiction, a penchant toward alcohol that people have a tough time escaping from.
I think what was really his professionalism and expertise was, it was so easy to see the organization and the presentation that he had, and the idea of it as a pervasive family problem rather than an individual problem. The person who's addicted feels very isolated, but in the context, it seems like the people that can move on and overcome this, change their lives, it's usually in the context of an environment of family or a team of people that care enough to reach out, and then the style of, or the approach that's needed to be successful. He talked about practicing, the intervention group practicing, and it's almost like a performance to create that safe environment. It has to go according to plan, very carefully thought out. and it's a risky endeavor, but you can save a life with these the life of someone that we all love deeply, someone in our family.
Yeah.
So it's so I am just so grateful for you introducing us to him and the techniques that he shared and that doorway to hope for people that are, that you talked about, the enablers, people who have kind of resigned themselves to this reality. We're going to have to live with this alcoholic or whatever the addiction may be, and then compensate for them just so that we can get through the days and living this sad suboptimal existence because we don't have a pathway out. It was nice to see the steps that he outlined that can give people hope of a change. Not that it'll come easily or that it won't be a painful and difficult process, but at least a pathway out of that situation.
I like the fact that he mentioned, we talked about finances and paying for it, that a number of the programs are actually low cost. It's just a matter of getting to those resources because we really are sort of inundated today by the sort of California rehab, at least from the Midwest we are, where if you go type anything into Google that suggests an addiction, up comes a treatment center. Look, I'm not making judgment on it, but some of these are incredibly expensive. How they work, their track record of working, we can figure that out. But the reality is you get this impression that unless you have a ton of money, that you can't get help. And he's saying that's not true. Actually, it could be low cost if you do your research.
The other thing that came across, which is understandable that it has come to mind immediately, is one word. He said surrender. That idea that we've finally reached the end. At one point he shared about how in the old days they thought you had to hit rock bottom. If you're an alcoholic, you had to be in the gutter, and then you could look up and see there's no more down. It's only up. I surrender. I give up. I'm going to try and rely on something outside. He didn't so much talk about a divine outside reliance, but the people around him. And I think it's probably both. But that was very encouraging when he said that you can decide to surrender at any juncture as you're going down the elevator to the basement. You don't have to go all the way to the basement to make that decision that I don't have the capacity, to humble yourself and say, this is time for me to adopt a whole new paradigm for life, is really what it is, where you surrender that ability to say, I'll figure this out sooner or later. I've got this. And when in reality, he pointed out biochemically, for certain individuals, there is no way out without help, just because of the power of the chemistry of the situation.
The power of the chemistry just absolutely terrifies me, whether it's fentanyl, whether it's marijuana, great. Everybody wanted it legalized, but there's no great control. If you read any of the research, there's no great control over concentration. So he was talking about how when we were kids, it was a 1% THC concentration. And now we're dealing with 20, 30%. And that, again, you're concentrating the drug, nicotine, vaping, right? The idea is you might be getting rid of other things, but you're concentrating the nicotine. So now the drug itself becomes even more powerful to affect the brain. Look at caffeine. Look, I like caffeine, 1,3,7-trimethylxanthine. I love it. But the reality is the drinks now are concentrating it more and more. So the chances for addiction, the chances for dependence go up more and more. So the equation is there sitting in front. It's like, if you want to create addiction, concentrate more and more of the substance to get people addicted to. So this is where it comes up in lifestyle. I brought up ultra processed foods. And this is why I'm not trying to be PC here, but this is why when we talked about weight loss drugs, I said, you know what? I'm not a big fan of the price and all of that. I said it's an embarrassing price. The company should be embarrassed for what they're charging, in my opinion. But I'm a big fan of people now have hope to fight back the addiction that you have to accept that's going on with obesity. This idea of just cut calories and, just exercise more. We can get into that nonsense, or it's not your fault, or it is your fault. Can we put that aside for a second? Let's talk about all the compounds, all the ingredients that's being put into unhealthy food to make you completely dependent on more of that to get pleasure temporarily, which you actually experience withdrawal if you don't get those chips or donuts on a certain amount and concentration. So it affects.
How did you know? You don't live in California. How did you know this about me?
Well, California is a mix. California's got some of the healthiest people who worry about every single thing they put in their mouth. And I think that's very stressful. Then they got people who are moderate. It's like everywhere else, but California is always ranked like Colorado, some of the healthier populations, but the
I'll confess, this is supposed to be good for the soul. So I studied biochemistry in college, and I understand how these, you get big sugar spikes after you eat concentrated desserts and things like this. So what you do want to do if you're going to eat cherry pie or something of that nature is have it after your stomach is full. That will blunt the evil to some degree. So that's my compromise for my sweet tooth, is I try not at least to eat them on an empty stomach.
The reason the weight loss drugs compel me is that people are being turned off to foods. If you talk to people on the weight loss drugs, they'll say, I can't look at a glass of alcohol anymore. I just am not excited. And I think that's exciting because I think they're testing it now, but the suggestion is in the laboratory that it's essentially affecting the areas of addiction and turning those off. So maybe it can help also people quit smoking. Maybe it can help them quit alcohol. And I love the fact that now we're leveling the playing field, because I don't think in our generation the playing field was level. I think it was all about concentrated food. It was all about unhealthy calories. It's still out there. And I just think when people say, oh, just fight it, again, that's why I gave Lee the story of when I was in college and we all got addicted to chewing tobacco. And I just thought, I'll just quit it, right? I'll just quit it when I get into med school or something, because I just needed to stay up late. And then I'm chucking it in the woods 50 yards. And 3 hours later, I'm getting withdrawal and I got to run and I'm looking in trash cans. I'm looking for this thing. I was like an animal. And I realized, this addiction thing and the withdrawal, that's why I wanted him to focus on withdrawal in the Q&A. Because people have to understand, it's not that they don't want to quit. The withdrawal is so profound, and it just essentially takes you like a magnet right back, because as the hours go on, you experience these just gigantic highs and lows. The toughest people I've ever worked with, Mark, the toughest people, and I knew they were going to be the toughest, were the smokers trying to quit.
Well, that's what I say. I think that
would bite my head off. That
was the biggest accomplishment of my life, was quitting smoking. You should just be, I know we're not going to spend a lot of time on this, but I'm in the exact same place you are with these new, I call them miracle weight loss medications. And there's hesitation. These are relatively new on the, when is the backstory going to come out where people's ears fall off or something of that nature? And the reason I've gotten enthusiastic about it is because even if something is demonstrated, some problem shows up a couple of years from now, in the meantime, we'll have saved many lives through the fact that they do indeed cause weight loss.
Exactly.
So it's called a risk-benefit ratio. So, as every year goes by, and of course, these things are being used in millions of people, they can't even keep it on the shelf. It's so popular and so successful that the exposure to all these people, if there was going to be some shoe dropping later of, it causes brain cancer or something dreadful, probably should have seen it by now. So I'm 100% on board with what you're saying.
I mean, what I can just tell you about this is that we're learning more and more. There's no question the shoe that could drop, whatever that saying is. Shoe drops, 5 shoes drop. I just made up that saying, 5 shoes drop. But in the meantime, people have to realize we are 5 years into very strong data. And you're talking about, we've said this before, this is not a Mickey Mouse drug. This is a serious drug for a serious issue and should only be utilized that way. Meaning, these are people that have to lose weight, like bariatric surgery lose weight. These are people that have to lose weight now, or it's life-threatening now. So when people tell me, well, 5 or 7 years from now, your ears might fall off, yeah, that's possible. But the reality is, what was going to happen in those 2 or 3 years that they were taking it? If you're looking at the clinical trials, a lot of people were going to die. There were going to be mortality issues
because of the weight.
Because of the weight, and because of all the havoc the unhealthy weight has caused. But we continue to be surprised. Now, the surprise that happened in the past few weeks came from the European data. This is now being released. To make a long story short, the trial that got Wegovy, I still don't understand some of the commercials, but that's a whole other thing. I don't understand who writes these commercials. The trial that got semaglutide or Wegovy approved for reducing the risk of a cardiovascular event was called the SELECT trial. And so you're going to continue to hear more and more about the SELECT trial. It reduced these risks by 20% in just a matter of years. And so now they're getting an indication like this is heart healthy. So what happened was they've gone back and they've completely looked at it. And now before they've published in the European abstract, they said, think about this. This was so profound and it got caught up in politics. You know, it got drowned out by other subjects in the past month. It says, in the cardiovascular outcomes trial of semaglutide or Wegovy in patients with overweight or obesity, but without diabetes, okay, a reduction in major cardiovascular events was achieved, ready for this? Get ready to fall off your chair. And this is, I bet you, the first time an advocacy group has reported it, was achieved regardless of the level of baseline adiposity. In other words, it didn't matter where you were on the obesity scale as much, and it didn't matter necessarily. Of course, the more weight you lost, the lower the risk. But for even the people who lost a little bit of weight that saw very little change, there was something cardioprotective about it. That was a shocking finding from the most recent.
You know what it was that was cardioprotective is eating less.
Exactly.
I mean, it starts immediately. Today, I have a choice to eat less, and the benefit starts immediately.
Yes. To get ready for this, just to show you how coincidental this is, to get ready for this meeting, I was in the middle of a million other papers and meetings. We had a big thing from an international organization we had to get out on the prevention of prostate cancer. So I probably had the least amount of food I've had in the past 2 weeks. I got down to my college freshman weight, which is why my neck's skinny. I didn't think I had to lose the extra 7 pounds. Suddenly I step on the scale and I'm 7 pounds lower, and I take my blood pressure and it's running low. Well, my family blood pressure runs high, so everybody's got to start taking medication. So I'm just taking my blood pressure and it's running low. I'm actually feeling almost a little dizzy. And so that's happening almost immediately. And that's with someone like me. So what you're saying is right, that physiologically what's happening when you cut down 50% of your calories right away, the body's responding by saying, let's get cardioprotective. I think that's a really good point on your end. Really
it's exciting. Yeah. You're right. It's a gift from heaven, because we all know how, I mean, I don't carry extra weight, but I do, I am challenged by eating the wrong foods. And so I can relate very carefully. If I see someone who's overweight, I can't look down on them. I understand these forces and these urges that are so difficult to wrestle with, and to have a medicine that all of a sudden can erase that urge. I mean, what a miracle.
Yeah. But people don't realize every time they say the shoe's going to drop, I'm not saying it's not going to, but here's what people have not been told. And I just pulled this up because I wanted to make sure I got the date right. Liraglutide, which one of the first of these in the category, which has a short half-life, was approved in the European Union in 2009. In the United States, it was approved in 2010. It's already been out almost 15 years. They haven't seen a safety signal yet there. So yeah, we have new, more powerful ones. But
and you and I both know that we're not, we both know that based on the mechanism of action that we understand, which is just reproducing normal hormones that talk to our brain synapses and tell us that we're not hungry. It's not a backdoor artificial way to make your stomach feel full. It's actually the very appetite center itself is being impacted by a molecule designed to impact it, and it's doing nothing else. So we really, just from what we know about the mechanism of action, we don't expect the shoe to drop.
I hope you're right, but I just don't. I just look at it like this. I look at it as if we're in the early stages of trying to study exercise. And people go, well, aren't you worried if you go running outside? We don't know the harms of exercise. And you go, yeah, that's true. And you become completely focused on the fact that you could step in a pothole or get hit by a car. That could happen. But let's look at the benefit overall of, if that doesn't happen, essentially, the pros so far exceed the cons that of course I'm going to go exercise. You can always go find something negative. What I find so interesting is all these gurus out there that predicted in year 1 or 2 that all HE double toothpicks was just going to break loose. You're going to see high rates of this and that and thyroid issues here. And none of those have turned out to be true. Again, it's not that I'm a big fan of these companies, but I'm a big fan that we have a weapon to combat what people have been dealing with as an enemy for so long, and they had no weapon to fight it.
We've seen a lot of breakthroughs in the last 5-10 years, and because of the nature of modern research, where they're not, when I started off in oncology, all the medicines I used had been derived by trial and error. They boiled down some bark, they gave it to animals, and then they gave it to humans, and no one knew how it worked. Modern medicines, based on the understanding of the biochemistry of the human body, are like little software patches that they say, this is where the broken software is, and we'll just create a patch to fix it. And these miracle weight loss medicines are designed that way.
Yeah, let me bring up a couple new papers in my life, and I don't need to pull them. I've got them in my brain. And these all happened in the past few weeks. They looked at people on these drugs and the trials, and they thought, who gets the best results? Can we predict the best results? And one of the predictors of better results was if they added an exercise component to the drug. Because everybody knows you're already going to cut calories, right? So that component is very much taken care of. But the variable, the X variable that has lots of latitude is who's going to exercise and who's not going to exercise. So they have found, at least there's a signal that those people who exercise get a heart healthier benefit, okay, but also they're more successful at losing more weight. The paper that came just this week was looking at an older GLP-1 drug, and because what happens when you lose this kind of weight, not only do you lose muscle mass also, that's inevitable, 20 to 30% muscle mass unless you combat it with weightlifting, right? But you also can lose bone mineral density. So they broke it up into a bunch of groups, and they looked at who had the least amount of bone mineral density loss when they were on these medications. And the hint again was the people who exercised had less loss of the hip, less loss of the spine compared to the people that didn't move or didn't do exercise while on these medications. Which is why if anyone pulls the paper that I wrote 2 years ago on the pros and cons of GLP-1 agonists, I published it, it's on PubMed. What I essentially said was, let's quit pretending that these drugs are somehow getting rid of lifestyle. What they really do is they hone in on the fact that lifestyle changes lives. And it's just as important to make lifestyle changes when you're on these medications as to when you're not on these medications. So we should be embracing that. And instead, people are making it look like it's lifestyle against the drug. No, it's not. There's a symbiosis there. And the sooner we accept that is the sooner we'll be more successful.
Yeah. We've, of course, in the prostate realm, we've been facing that in such a stark fashion because we give medicines that take away testosterone, which cause muscle loss, and we've seen the incredible turnarounds that people have if they can get on a weight training program, and they had to stay on careful diets because of the tendency to weight gain.
Yeah, and let me bring up one more thing at ASCO, and for those people that know ASCO, American Society of Clinical Oncology annual meeting is where a lot of papers that you'll see in the future are presented. They presented an interesting series in breast cancer patients because breast cancer patients have to go through a hormonal therapy, just like prostate cancer patients. So they lose hormones and the metabolism gets out of whack, and weight gain is a big problem in breast cancer, right? They looked at people on these drugs, on these medications in breast cancer, and they found that they didn't lose as much weight as the average person would, but they still lost weight. And it's just interesting that when these medications, which are so important, but they also slow metabolism to such a point that hopefully we'll see the day where it gets approved along with these medications to help you lose weight when you're already dealing with a cancer plus a cancer drug that makes you gain a huge amount of weight. So let me tell you, this is incredibly relevant to the PCRI, this topic, and it's only going to get more and more interesting as the months go on.
Yeah, one last comment on this, because probably the number one reason, pushback that I get from patients when I mention these medications is that they'll say, I acknowledge that I'll lose weight, but I'm going to have to be on it for the rest of my life. And my answer to that is, well, if you arrive at your ideal weight, it'll be a nice problem to have to consider whether you're going to have the option of stopping it or not. But a lot of the successful pharmaceutical interventions that have become so routine, lowering cholesterol, lowering blood pressure, lowering blood sugar, unfortunately do require ongoing treatment to maintain that successful new level that's been achieved through those pharmaceuticals. So the idea that you can somehow the medicine is bad because you have to keep taking it to achieve those endpoints is not a very fair criticism. It's just so miraculous that you can make headway against an area that has been such a failure for many people.
Yeah, and along with your point, think about what we don't know, right? So if you look at the clinical trials of people stopping these medications, they gain about 66% back, or about 3/4 back within a year. But you're talking about an average. There's a strong minority of people in the first year, and there's been some in 2 years, that when they stop them, for whatever reason, which we haven't figured out, they don't gain that back, or they might gain 25% back. Remember, that also happens in bariatric surgery. A lot of people gain weight back, but they just never get to the point where they were. So in the end, it's still healthy. And I think what you're going to find with people who criticize, I'll be on this for the rest of my life, we're going to find out in the next year or two that there's these, what we can call them unusual responders, or unusual people who go on cessation of the medication, where they won't gain as much as it's showing on the graph for whatever reason. Maybe it's because they've learned caloric control. Maybe it's because of their exercise routine. Maybe it's because of other behavioral changes overall, but it's coming. I'm telling you, I'm seeing this data, and it's screaming at me that there's a minority of people, and we have to figure out who these people are and why they're successful, is that when they slow down the drug or they stop it, they don't see extreme weight gain right away.
Well, we've gotten used to that because of with all pharmaceuticals, we know that there's a component of trial and error, and and people don't seem to understand how different everyone's biology is, and that for some people, a little bit of medicine will go a long way, and then there are some people still that don't respond that well to these medicines. You're not going to know until you try it.
Hypertension, largest meta-analysis just studied in terms of alcohol. Okay, hypertension. Let me read this to you. Overall, our results lend support for a causal association now between alcohol and the risk of hypertension, which is linear. In other words, we didn't even accept a couple of years ago that alcohol was a problem in terms of blood pressure. Now they're calling it linear. So you go 1, 2, you can see it go 5, 10, 15 points. The reason I'm bringing up this point is to emphasize and to complement your point, which is, if you would have told someone on a blood pressure drug 5 or 10 years ago, wait, if you stop those 3 beers or 2 beers a day, you can drop 5 or 10 points and come off of your medication, people would have gone, what? I thought I'd have to be on this medication the rest of my life. So we've figured out lifestyle changes, and alcohol is one of the biggest that contributes to blood pressure increases. We've figured out in lifestyle what we can draw back on or remove that may cause a change in the cardiovascular number that may actually get you off the drug. So this idea that you'll be on medication for the rest of your life, look at type 2 diabetes and all the people who have been able to reverse through lifestyle. I think that's going to play out with these weight loss drugs. That's the point.
Well, how can it not? I mean, so if there's another factor that people don't realize is the successful loss of weight and the change of self-image that ensues, and a new sense of well-being, a new sense of self-respect, that, hey, I'm not the person I thought I was, and I'm actually a better person than I thought I was, I think takes people to a new plateau, which, as you're pointing out, in some cases they'll sustain it without the drug because the drug has shown them the way to a new level of psychology that they can hold on to.
Or it will take them to a point of utilizing less drug, right? Yep. So they won't be dependent on such a higher dose. So remember, what the big change is going to be in the weight loss drugs is not just more of them, but different delivery systems. So Wegovy, that company, again, I have no relationship with these weight loss companies at all. Wegovy is going to come out with a pill in the next year or two. Their data is looking very good in phase 3 clinical trials. So they'll have the option of taking a pill at home, and then those people will have the easy option of stopping it when they need to stop it. So there's just so much more happening here. And I think we covered it within the realm of addiction, and it crosses over into addiction, but it's a fascinating time to have a weapon against obesity. I couldn't be happier for the public. I couldn't be happier for patients out there.
Yeah, me too. And I've seen the changes in our own clientele that and the sense of peace and happiness that has happened in these patients who've had pretty much given up on ever being able to bring their weight situation under control.
Do you remember in the 1980s and 1990s? I mean, you're a lot older than I am. I mean, I think you're a good, 30, 40 years older than I am. So you probably remember this. Now, in reality, it's 70 versus almost 60. I'm sorry. It's just an easy joke to make because I'm the younger guy in the room. But do you remember? You have to share with the audience your 1980s, 1990s, because you've been practicing for so long. You've been seeing patients for long. Do you remember? And it still happens today. Every possible thing that could go wrong with statins was mentioned somewhere, someplace in the universe. You'd lose, your left big toe. This was going to happen. Oh my gosh, it was going to wreak havoc. Your memory is going to be, this is going to happen. Now think about it. We're 30 years or whatever since the approval of the first one. And virtually none of those came true. And all of this worry, right?
Well, there's still a big industry. And this is just part of the reality of the world we live in, is that anytime there's something that has the power to change things for the better, a counter industry always springs up that makes a living off of naysaying. Always. Exactly. So there's always, and in the statin world, of course, there's a lot of grist for them to talk about. If what is it, 7, 8, 9% of people get muscle aches or something, and they have to go to a different, and thank God we have other options besides statins now. But so if there's 80 million people getting statins, that means there's 8 million people that had a negative reaction to statins. That's a big audience to cater to. And so patients, when they're researching, as they should, before my doctor wants to put me on a statin. So go online, read about it, and you'll come across websites and resources that talk about how dreadful statins are to this day. Yeah. And the same analysis as we've been talking about with these weight loss medicines. They're not a panacea. There's some people that they don't work in. There's other people that do have notable side effects. The good news is that a professional can mitigate those risks by starting with a small dose, monitoring closely, seeing how each individual reacts, and then making changes accordingly. So the risk of creating some irreversible disaster is practically zero. If they're handled irresponsibly. These are powerful medicines that change lives and prolong lives, but handled improperly, like any forceful cars. Cars are a wonderful, powerful resource, but cause damage when they're used improperly.
Well, I was just going to say, I think it's really our job. It's my job in public health. It's really okay to mention limitations. It's really okay. And I know with you, I've belabored these points, but I want the audience to understand that we have no skin in the game. We have no skin in the game.
Yeah.
Again, I have to emphasize the price is embarrassing. I'm embarrassed for the company. I'm embarrassed. It's just an embarrassing cost. Now you can say whatever the reason is. I'm just saying it's an embarrassing price, and that's the issue. And so we have to also understand that the conflict of interest is a little bit embarrassing. I mean, there's a lot of people just giving out canned talks, and look, that's fine, but when you put all that aside and just look at the data for what it is and how it's changing lives, it's the preponderance of the evidence, like they say. It's the pros versus cons. They so far exceed the cons now that we just have to talk the way we're talking, because nobody was more skeptical of the weight loss category than I can remember I was at PCRI, because every other medication was almost an unmitigated disaster. So I never thought we would get to this point. But, that's what medical history is. You have doubt. The history is not that good. And then suddenly you wake up and something's invented. I don't care if it's immune therapy for cancer, right? If it's any of these sort of novel approaches, suddenly the world opens up. You turn a corner. Anyway.
Absolutely.
I think we covered that well. So.
Yeah, I mean, if we had more expertise in the world of addiction, we could go on this further, but this is not.
This is our way of saying we don't.
Yeah. So we have to be humble about that. I'm glad you got a true expert to educate us.
Beautiful,
so let's talk about, there was one comment I wanted to make about Mr. Sharpe, and it became so relevant as you two were talking, and it came up that he'd had prostate cancer at one point. And of course, in the context of us knowing that African Americans have twice the risk. And then he revealed that he, not in addition to that, had a family history, which we know further increases your risk. And I loved his strategy as a thinking man to take appropriate precautions. And we talk about in African Americans, start checking your PSA at 40. Well, he started at 35. I mean, that was, is that a bad thing? I think that the only downside with investigating more deeply into the possibility of an early stage prostate cancer is if you approach it as a neophyte, sort of, well, whatever the system tells me to do. That's, of course, what the PCRI was designed to compensate for that and provide balanced knowledge so people can use that. But if you don't get to the starting line, if you don't do a PSA, and if you don't catch prostate cancer early, then that's where you hear the sad stories. For, in my professional opinion, I think probably 90% of the sad stories we hear are unfortunately due to people who didn't get diagnosed in a timely fashion at the get-go. There are a small subgroup of prostate cancers that are just super bad actors, but thankfully that's not the norm. It's usually because someone gets a late start, and Mr. Sharpe didn't make that mistake. And I wanted to quote one thing from him. He said, "I was not afraid to have a conversation with a doctor." And we don't normally think, why would we have a fear? But the idea that the medical system has its own agenda is pretty strongly founded in truth. So when people go in and talk to a professional who may have an agenda, maybe they want to do surgery or something like this, you do need to be forewarned and forearmed. But he had enough courage to realize that to counterbalance those dangers, which are real dangers, that having the knowledge of what was going on in his body would accrue more advantage to him than disadvantage. Yeah. I thought it was such a deep, profound statement, and I think he was trying to speak to not only African Americans but all men over age 40 or 50, that if they can just take the normal precautions, get a PSA once a year, that they can pretty much guarantee themselves they'll never die of prostate cancer. And if they don't do it, then you've had what we would call a preventable disaster, unfortunately, that through the not getting a $30 test once a year.
I thought it was incredible he got tested at 35. Like, I think people should understand the pros and cons of every single test. But for him, if you look at the background, the family history of so much cancer so early, I could then argue, boy, I wonder if there's been other biomarker tests that he's had done, right? Because so many people so young. Yep. So, boy, he just took control of it there. And I thought that was incredibly, incredibly profound. But it stunned me because we went into it thinking he was just going to talk about men's health. Look, I know you can go online now and find that in these very little corners, he mentioned it. But like he said, he wasn't acting as a spokesperson until now. And so when he said it to me, all I kept thinking was, Mark, you're too old not to be candid. That's what I was thinking as he was saying, because I was so stunned during the interview. Because remember, this just goes. These interviews aren't, we're not stopping and starting. We're just going. And I said, do you know who else doesn't know? And I think he said, you. I don't remember what he said. I said, me. This whole interview, I thought we would just talk about football and we talk about lifestyle. And I said, I had no idea. And this is the very end. And I thought it was, what was also refreshing is you have to admit, I mean, as long as we've been together, it's okay to have the spokesperson for prostate cancer be 78, retired, but that's also not the face. The face is a lot of families and a lot of men of vast different ages. And we just don't have enough men in their 40s and 50s, and men who also take care of themselves, I would argue, that have become spokespersons. So that's why I was sort of in awe at the end. Like, wow, you're 56. I kept saying he's 57. You're 56 and you're taking on this role of awareness. Good for you. Good for you.
People do think about what the repercussions are. If I'm diagnosed with prostate cancer, am I going to have a radical prostatectomy? Am I going to become impotent as a result? Do I really want to know? I think these are the kinds of questions that cause people to wonder if they want to have that conversation with a physician. And he's the kind of guy that thought this through and decided to have the courage to follow through and get checked, and found something at a very early stage that it was like almost 8 or 9 years ago now.
Yeah, I think he said 8 years ago. No, we didn't talk about treatment. And I'll tell you why we didn't talk about treatment, because I didn't think that was my job. He did not go there. I thought he already did something so extraordinary that it caught me off guard. Look, It was so extraordinary, Mark, that I'm wearing his jersey again today. As you know, when we do Q&A, I never wear the jersey again the next day of the athlete that I interview. This is an exception, and it's an exception because he was exceptional. He was exceptional in the way that he just threw that at the end. He made sure, look, buddy, we're going to talk all this fun stuff, and I'm going to tell you that I can beat you in arm wrestling, but let me just end with the most poignant point, which is I went through this. So you think I'm so healthy and you think I take care of it, but just so you know, I'm also the face of prostate cancer. And I told my wife last night, I said, I'm still trying to get my head around this whole thing. So I'm just going to wear his jersey again the next day.
Well, let me make a comment, because he was so exemplary in his diet, in his fitness, and
Yes.
People who pursue this as diligently, almost religiously, the way he does, are often surprised that they come up with a health problem. And I think it's good for us to comment on what a health problem is. His health problem turned out to be a manageable and curable health problem.
Yeah.
People who are not as diligent as him could have come down, as you were talking about, with, it's not just the genetics, it's also what you do with the genetics in terms of your lifestyle, your exercise, your diet. And this has been shown in a number of studies that in all probability, if he hadn't been pursuing a healthy lifestyle, the situation, his type of prostate cancer, actually could have been much worse.
Exactly.
So yeah, we're all in a declining, slippery slope towards that inevitable day when we're going to go meet our maker. But the activities and choices, we can slow that slope, postpone those things with wise choices. But none of us are going to get out free. I mean, it's something due to age and just the own frailty of our human condition. We're going to face a problem someday, but we can postpone it and we can minimize it.
But the initial reaction of someone healthy who gets cancer often is, look at everything I did and I got it. And to me, the answer is very clear in the data. Look at everything you did and look what it could have been, but you got that.
Yep.
It could have been far more aggressive. And that's what the data is showing. And we're learning that now. You know, there's a paper by Zhang. It's called Healthy Dietary Patterns and Risk of Prostate Cancer in Men at High Genetic Risk. So it's one of the largest looks just published in 2024. And I had to review this for physicians, okay? And what I found so striking is here they're taking some of the best epidemiologic data, and they're realizing that people have some of the highest genetic risk, including even for fatal prostate cancer. So far, observationally, there's a suggestion that what they do makes a difference, that just because you are given genes doesn't mean you're going to have to wear those pair of genes the rest of your life. You can change your pair of genes. You can actually alter them. And so here was one of the most, when I was reviewing, I found one of the most compelling moments of the paper, which is what I was trying to tell Mr. Sharpe, but I didn't have the paper and we were running out of time. And I'm going to tell the audience what I meant by that. He said, yeah, I understand that. I've heard about that. I agree with you. And I'm saying, this is becoming profound. And what they concluded was when they looked at all these lifestyle factors in these men who were high genetic risk for getting aggressive prostate cancer, it said, however, compared with healthy weight, exercise, and not smoking, very little else made a difference. In other words, other things made a difference, but the major factors. And when I think of Mr. Sharpe, I don't think of someone who's smoking every day. I think of someone who's absolutely right at a healthy weight. And he's saying, I only work out about an hour a day, and he's 56. I'm going, no, So what the paper's saying is the big stuff matters. The other stuff makes a difference. But in these papers, they're saying if you take care of your stuff with the most important things, and they mentioned those three, staying at a healthy weight, being physically active, and not smoking was the most profound items they found among these men that helped them combat their genetics. It doesn't mean that diet doesn't make a difference. Diet impacts all that, but they're just saying that's what the group had in common, including the healthcare professionals that they saw lowered their risk. And that is just mind-blowing to me. And that's what I was talking about with Mr. Sharpe that I didn't get a chance to quote on at the very end.
Yeah. Well, it was a great interview that you had, and it was obviously, as you told him directly, an honor to have him. And he's an inspiration to right living and how it pays off. I was amazed at his diligence and his work ethic, and the his character just shines through the screen to very, very inspiring individual. Such a pleasure to have him.
And what I said at the beginning, I ran through too quickly. If you ever get a chance, look at his 2011 transcript or his actual speech when he was accepted into the NFL Hall of Fame. He gave one of the greatest speeches in human history of a pro athlete being accepted into a Hall of Fame. I don't want to ruin it for anybody. I actually read the whole transcript. This is a transcript of Shannon Sharpe's acceptance speech, or watch it online. I think it's 11 or 12 minutes, and it is so profound about family and giving back and honoring people who honored you. I don't want to ruin it, but every time I try to bring it up in the past 24 hours with friends, I get all gushy. Someone brought onions in the room. He talks about his grandmother who raised him, and all she really wanted was she wanted a house that wasn't wet inside when he became famous and rich. She didn't want to put out pots and pans and raincoats in the house because it was always dripping her whole life. They lived in abject poverty. He says he remembers eating animals from the woods that just died. I mean, you read this and you think this life he came from is just, I can't even believe he got out of this life. It was such an intense period. So I hope people read that. But I made him a fortune, and his team got very excited. And I told him that he needs to come out with a workout plan, and it's not called Ship Shape, it's called Sharp Shape. And he loved it. So Alex took a couple of pictures. The Sharp Shape Secret System, where he actually goes through his routine. I've watched that online with his weightlifting, because there's not many 56-year-olds that look like that and have a clear weightlifting routine and aerobic routine in their mind that other people don't want to learn about. And I was darn serious that he should do what's called the Sharp Shape System. And people want to be like Shannon Sharpe, but you got to show us what you do. And I'll tell you, I'm waiting for that phone to ring. They got really excited about the name Sharp Shape.
Well, he is an inspiration. And this is a theme. I don't think we failed to touch on this theme of fitness in pretty much every time we have a meeting. And like you say, this is one of the essentials. Why don't we go and spend the rest of our time talking about the BPH world? I think that the overview that Dr. Helfand provided was incredibly valuable. And this is an area that's, in terms of numbers, even substantially bigger than the prostate cancer world. And there's so many parallels. You brought up the idea of watchful waiting for BPH, which is something we call it active surveillance in the prostate cancer world.
But nobody talks about it in the BPH world.
Yeah. Yeah. And so I think the challenges from the PCRI's point of view are very similar to that of prostate cancer, is because we struggle with the fact that in many cases, the proceduralists are the ones who are deciding and explaining what the treatment should be. And inevitably, there's a conflict of interest. And that makes it very difficult for the consumer, the patient, to really understand, what's going to be best. And talks like this are incredibly helpful, as he went through and objectively explained all these different options to people. And the other thing that came out in your talk with him, of course, is that doctors who do these procedures, you really want to be talking to one who does this particular procedure, whether it's aquablation or something else, a lot, if not exclusively.
Exactly.
So that they have tremendous expertise, because they're going into the sensitive area of your body. You got one chance to get it right. The problem with that, of course, is that inevitably they'll be a little bit slanted towards thinking that that procedure might be best for you. And it's not disingenuous, it's sincere. It's just what they do. They're comfortable with it, and they think they can make it work for you. From the patient's point of view, that's difficult, because you're getting a slightly tilted field, and it's not intentional. I don't think it's intentional at all. It's just a reality of this space. And so I think it's good for you and I. Neither of us are urologists. We are not in the business of treating BPH in any way, but we're heavily exposed to it through our prostate cancer exposure. Men are already talking to us about their prostates. And by the way, Dr. Scholz, my prostate's big. What do I do? And so I think I would start probably talking about, to counterbalance the procedure-based idea, which was that wouldn't it be nice to solve this urinary problem really good once and for all? And I think that was probably the most compelling aspect of his presentation, that the something like aquablation or a transurethral resection, which is one of the more thorough approaches and more durable approaches, and perhaps one of the more proven approaches, is attractive for that guy. And we run into these patients. I just want a solution. I want to move on with my life. I don't want to think about this anymore. Fix it for me today. And I think that the aquablation might be right up there at the top of the list. The disadvantages, of course, is that anytime you do a procedure, there is a potential for side effects, even in the best hands. And there is a component of general anesthesia, which in men in our age group entails a small but real risk. And if there was either a watchful waiting or perhaps a mild medication that you could kind of postpone and maybe wait for better technology to come along. The men that have waited for aquablation to come along, that hasn't been out for that long. So perhaps they were taking a medication or doing watchful waiting. So this sort of push-pull, this is a shared decision between the patient and the doctor. And this is the essence of the PCRI, is to educate the patients so that they can be on an even keel with their physician and have a real back and forth about this, the pros and cons of these decisions.
Yeah, that's my job. My job, it's just simply, we're here to tell you the pros and cons. In the end, you make a shared decision with the person that you trust in your medical team. That's what it's all about. But to go there with less hands on the deck is unfair, right? Because I always like to show this. I always like to show this because if I'm just Joe patient walking out there and all of a sudden they go, well, how many minimally invasive options do you have or just invasive? And I showed you a sign, only this many right now, but actually we've got more than this list. This is as many as I could fit with this font on the paper. Only this many, just go research them all. I would look at my doctor and go, are you kidding me? I'm not doing that.
And does that include, show the list again, Mark, does that include pharmaceuticals, supplements, all that as well? Or is that just procedures?
No, this is just the invasive stuff.
That's just the procedures.
Oh, right. Yeah, no, this is not the full list.
Yeah, so now you have medicines, you have supplements, you have
you have lifestyle, you have watchful waiting. But just think about this is overwhelming. And I don't know if you saw in the moment, I've known Brian. I love Brian. I sound so PC. I do. The people we bring on are people that I know. They're already heavily vetted. I just know they'll be good. Imagine he's going to talk about aquablation. He spends the vast majority of his time talking about every other option under the sun and the pros and cons. That's a beautiful presentation. That's an objective presentation. I mean, and I made that clear behind the scenes. I said, we don't want this to be an ad. We want you to cover it. And when we were done filming, what people don't realize is I said, Brian, you covered it more comprehensively than anyone I've ever seen. And he goes, well, that's what you said I have to do. And that's what I do. And I was like, of course I would, you big dummy. That's how and it was just a beautiful moment that he covered all that. But the point you make is right. This is an overwhelming field. It's even overwhelming in the medications, Mark.
Yeah.
It is.
So let me just to try and simplify as a non-urologist, the way I'm thinking about these BPH, and he was very good about talking about that there are many different types of urinary problems. It's not just a big prostate. But if you look at the options that we have and the problems that men have, and it could be a big prostate, it could be an overactive bladder, that keeps people up at night. In bad cases, people block off altogether and they have to have a catheter placed. I mean, these things can get serious. And the way I tend to think of BPH, and just in simplistic terms, is first, if people have some symptoms that they can live with, I'm perfectly comfortable with watching them. If people have symptoms that they can't live with, I'm perfectly comfortable trying some medications. I'll just he mentioned like things like finasteride, Avodart. Turns out Cialis has activity.
Cialis has activity.
Flomax, Sildesin, Uroxetrol. These medicines can be tried in small doses, big doses, one at a time, in combination, sequentially, and you can fiddle around with these things if you have the patience for it. Sometimes that isn't enough, and then you're on to doing possibly some sort of a procedure. I tend to think in terms of small prostates and big prostates. And if I'm to the point where a patient says, we've got to do something. Right now, for small prostates, I like to do some of what he called more minimally invasive things before you start taking, hunks of your body out, which is, the TURPs and the aquablations and the more definitive. I mean, they'll even do surgeries to cut your whole prostate out if people are in a bad way. And so I tend to think of something like maybe Optilume for the men with small prostates and urinary problems, where they just put a device in your prostate and stretch it out and leave a catheter in to keep it from growing back for a couple of days. And we'll see if that fixes it. And the men that have ginormous prostates, I tend to think first, and he'd mentioned this, but kind of in passing, in terms of blocking the arterial supply with prostatic arterial embolization. Why am I attracted to that? Well, you go to an interventional radiologist, they put some stuff in the bloodstream in front of the prostate. You don't have to have a catheter afterwards. You don't have to be put under general anesthesia. Yeah. So those are the sort of the things. And then if someone's been through those things, an Optilume or has been through a prostatic arterial embolization, he pointed out that those may not have as durable effect as things like transurethral resections and aquablations. Then I would, at that juncture, be thinking of a more major procedure. And that sort of stepwise approach is, I think, a conservative one. I don't like putting people in the hospital for a procedure if I have other plausible alternatives. I've had patients die going into the hospital for routine procedures. I don't know if you've experienced that. I've had a big practice for a long time, and it's not one patient. I've had patients that have gone in for a routine kidney stone operation or a routine and died. And of course, that's not the only bad thing that happens when they put you to sleep and give you general anesthesia and things. So I don't like to put patients at risk for something bad happening, albeit may be rare, when we have other less invasive options. So that's the way I tend to think of it, sort of a scalar approach. I'm excited about the aquablation because what he's saying with that presentation is that quite possibly we're not going to have to do any more simple prostatectomies anymore. That used to be the fallback position in men that had these really big prostates that were blocked, and you'd have to do an operation and cut into the abdomen and go in and surgically remove the gland. And you're talking about a 40-minute procedure instead of having to do a major prostatectomy for these men with big blocked prostates. I think that's a big breakthrough.
I couldn't have said any of that better myself. I mean, the reality is, and where does the future lie? I was so surprised he's talking about it now for treatment. It crosses over into prostate cancer. Maybe these people have minimal disease. And so these BPH treatments are going to open up some areas in prostate cancer, which are going to be mind-blowing. I'm sure of it. But I think, again, it's a pro-con game. There's a lot going on. It's highly confusing, and people need to take their time with it. But the funniest moment I had in the interview, I don't know if you noticed, or the audience noticed, is that I ended by saying, and I meant it, I understand when people get up there, they say, you need to do 15 or 20 and you're good at it. And I said, I'd rather have you, the guy who's done it 500 times than the guy who did it 15. And I know that people say, well, the 15ers and the 20ers and the 30ers, they're really good. And I still said, at the end, I don't know if it was caught in editing or what went down, but I said at the end, I'd still want the 500 person. I'd still rather have you do it. And I think that's the only message I add on to your wonderful message, which is, at the end of the day, with all these procedures, I still want the man or woman, I still want the person that's most experienced. And I'm not saying experienced over life. They're still doing it on a frequency and intervals on a regular basis.
Yeah, after you've done your homework and you've decided what you think probably is going to be the best procedure, your work is half done. Right. Now you have to do the other half of your work, is who is going to do it. Right. And to be willing to get on a plane and fly to a different city should be a small consideration in this issue. Whenever you go in for an operation, if you can find a talented center, an individual who's doing that one thing all the time, over and over and over again, is on at the forefront of their field and part of the discovery process and how to utilize this new treatment optimally, that's the doctor you want to be doing your procedure.
Well said. So at least what we're doing at PCRI is we had whole lip, That was with Dr. Dow. He did a good, and he'll admit. I thought it was interesting too that Helfand said that one of the limitations of HoLEP is you got to be really experienced. And I'm going, well, that's true. But to me, you got to be experienced in all of these. I couldn't agree more, but that's the word that keeps coming out over and over again. So
let's have you, before I don't want to move on from this, before you talk to us a little bit about whether you think some of the supplements that are out there. So we're talking about this scalar approach, watchful waiting. Maybe try some supplements. That doesn't work. Maybe try some pharmaceuticals. That doesn't work. Maybe try a minor procedure. That doesn't work. Maybe go for something like aquablation, something more definitive as a scale. We haven't really talked too much about supplements in terms of like saw palmetto and there's a number of different things, some of which I think might not be working directly on, say, prostate size or shrinking prostate, but maybe because of their anti-inflammatory effects. I think there's a lot of confusion. We forget that not only do men get big prostates, they also get something called chronic prostatitis or inflammation in their glands as well, which can create symptoms that are unpleasant, just like a big prostate can.
That's why we talked about urodynamics and having a specialist really figure out what's going on, because it could just be overactive bladder. It could be a combination of overactive bladder and BPH. These doctors that do it full time, these urologists, they're good for a reason. I mean, they do the testing required to help figure out the etiology or how best to go after this. So that's why we brought up, because you and I had talked about this privately, I brought up a sign that said, this is what's done in urodynamics. Ask your doctor about urodynamics, and I think that was a very helpful point. I think the area of over-the-counter is interesting, but I think the area that's been missed the most in this category is not just prevention, but slowing the progression of it through lifestyle. And I know people probably watch all the time and goes, Moyad thinks lifestyle fixes everything. Well, I don't know if it fixes everything, but it complements almost everything, right? So I told Brian the story, and this is a true story. So for the American Urological Association, I got to write a definitive paper to educate doctors and future doctors on what to do lifestyle-wise when it comes to BPH and some other things. And I had to also talk about it in the realm of preventing prostate cancer. So I started listing all these things that had data to prevent prostate cancer and to prevent BPH. And then when I looked at the list after working 100 hours on it, I go, wait a second, this is the exact same list. It's the exact same thing. So whether we're concerned about alcohol or diabetes or dyslipidemia, high cholesterol, or inflammation, hypertension, this is actually from the actual obesity, can contribute to aggressive prostate cancer, can contribute to an enlarged prostate, right? Tobacco, smoking, whether some are on the fence or not, they all sort of have a hand in being prostate unhealthy when you're being heart unhealthy. And the reason I wanted to emphasize that is I remember in 1998, I was all excited. There was this article that I found because it was one of the first articles of healthcare professionals looking at what could prevent them from getting a BPH procedure, right? And so this is one of the largest epidemiologic looks. And this is 1998 when no one's talking about lifestyle and BPH, trust me. And so this is Platt et al. From Archives of Internal Medicine. And it was one of the things that really got me excited about lifestyle. So these are men who walk 2 to 3 hours per week had a 25% lower risk of BPH, okay? Physical activity was inversely related to total BPH, and that included surgery, which means the men that were most active and who were the heart healthiest had a lower probability of needing a more invasive procedure. And it's that kind of stuff that just continues to echo. So then this is more and more papers came out. And now we are here in 2024, and they're seeing it's a lower risk of nocturia, a lower risk of getting up at night if you're being physically active. So we have all these papers over the past, since 1998, and here we are in 2024, and it doesn't just whisper, it screams that lifestyle, wherever you are on the continuum for BPH, trying to prevent it, trying to prevent the progression of it, plays some kind of role that we can no longer ignore. Now, what I love to see in the Mark Moyad world, this is when I come back in the next life, and I'm you or who knows, anyone. I come back in this next life and I want to do a study that will get funded, not have to worry about getting funding. I would love to see aggressive lifestyle changes up against medication, up against the supplement, because I don't know what would happen because it hasn't been done and it hasn't been done well, but I would love to see that. And then I would love to see those same supplements and I'd love to see those same medications where someone was also aggressive with their lifestyle, how much did it make the supplement work better? And how much, did it make the medication work better? I think one of the biggest takeaways, and I think then we can go on to some general items, but I know you wanted to cover this. This is probably a 3-hour lecture in the Moyad world. I first want to emphasize safety. When you're dealing with an herbal, let's just say saw palmetto, let's just say it could be pygeum. When you're dealing with an herbal, the first thing I think to check, besides check with your medical team that you might be trying it, is check for one that is low cost, but has great quality control. So what I always taught the students, including the other day, I said, remember, I want you to all repeat this saying with me. Herbals are a different animal. And everyone go, herbals are a different animal. Herbals are a different animal. What's that mean? Herbals are about the stem, the root, the leaves, all these different sources coming into the bottle. Could it be high in mercury? It could. Could be high in cadmium? It could. It could be high in arsenic. We don't know. So that is where you have to make sure there's some kind of third-party verification system that says what is in this herbal is exactly this herbal, and it doesn't contain contaminants. It doesn't contain bacteria. There's no other kind of heavy metals we're concerned about. So the first step is actually not trying something. The first step is making sure that you're not doing harm to yourself and spending too much money for something. Well, what are third-party quality control groups that we'll talk about in the future with Alex and other people as we do the diet series that's going to be released soon? There's a group called NSF. There's a group called UL. There's all these different labels that are called, there's one called in Canada called ISURA, ISURA. You're looking for a company that's allowed itself to be tested by a third party, unrelated to them, to walk in, test their ingredients and say, not only do you have what you advertise you're having, it's also safe. It's also a safe product to take. And that is one of my biggest concerns of all, believe it or not, when it comes to the BPH realm overall. The interesting thing, I'll leave you with this, and then if you don't mind, we'll cover some general stuff. The interesting thing about saw palmetto is it couldn't be steeped in more drama right now. Here's the drama. You have 2 major phase 3 clinical trials, essentially driven in the United States. I call them phase 3. One was called the STEP trial by Bent, B-E-N-T, and he was from UCSF. I think he's still there. And then there's the CAMUS trial, big government-funded trial, where you dose escalated on saw palmetto versus placebo. Both those trials found that saw palmetto was perfectly safe. That's the good news. They also found that the placebo response rate is very high. I think they also suggested. But they found that they didn't work any better than placebo. So then you think, okay, is the story over? No, because in Europe, there's a prescription saw palmetto that for any negative study or neutral study that's happened in America, they have positive studies against pharmaceutical products, other prescriptions, including tamsulosin, which is Flomax. And you're going, well, what's the difference between these European prescriptions? Is it a quality control issue? Is it the way they prep the compound, which is different? They prep the active ingredients differently. It depends what camp you're on. You're going, is this the greatest placebo that's ever been invented? Or is it just that the Europeans, and there are some companies in the United States that make a more quality control product that gives it more of a pharmaceutical hit? That's why you have to work with your medical team. It's kind of like the invasive options. There's a lot to think about, but I just want to leave the audience before we go into it further in the future PCRI meetings, that the first thing we should be thinking about is not the dosage, it's not the product, it's that you are moving into an area where quality control is paramount. It's absolutely paramount. And learning that what you are buying is cost effective and also essentially been tested. Like I'll get questions all the time, such as, let's just get out of BPH for a second. I go to Costco, let's say. I get this question, well, Costco has really cheap products over the counter. They can't be as good as the most expensive. And I'm going, all I can tell you is Costco has great quality control in general. They have a third-party group that actually tests for them. And so sometimes there's not a relationship between what you pay and what you get. Sometimes if you pay less, you do actually get more. So it's a matter of doing your homework. CVS has a program called Tested to be Trusted. It's revolutionary. It means that they're not going to sell anything in there, including their own products, unless it's been tested by a third party. Why they don't advertise that more, I have never understood it. I have never understood why they don't advertise that more. So doing a little bit of this kind of homework is absolutely critical to at least starting something, working with your doctor that's safe, to then gauge how you're doing overall. So that's a long answer to a short question, but I have never seen another category in urology, and maybe in all of medicine, where I think lifestyle makes a difference, except for cardiovascular disease, maybe, than in BPH. Even the BPH experts out there agree that lifestyle changes things. You know what they found interesting too when I was writing this paper is that as you gained weight, the medications for BPH in some cases became less effective because the physiologic change in the receptor happened. So in other words, when you talk about finasteride and dutasteride, they noticed that some people who gain weight or are obese don't respond as well. And then when they tested their tissue, they found that the actual mechanism of action or what it had to attach to in order to be effective had changed. So we're learning from pharmaceutical studies in BPH that the drugs are probably far more effective, or you have a better chance of them working if you are also working for yourself. So
yeah, and I think
that's my speech for the day.
Yeah, and just to close out this whole BPH section, the actual cause of BPH is, if you look at the official, textbooks, is unknown. But probably the leading theory is that it's a secondary effect of low-grade chronic inflammation. And low-grade chronic inflammation is the same thing that is what we call heart disease. Low-grade chronic inflammation of the blood vessel walls is what causes atherosclerosis, hardening of the arteries, leading to heart attacks, strokes, and whatnot.
Yeah.
And so the idea that chronic inflammation in the prostate occurs commonly in almost the majority of men is indisputable. I mean, you see the inflammation in the background when you do a prostate biopsy looking for prostate cancer. It's never been proven that the inflammation itself is directly the cause of the enlargement problem or the BPH problem, but it's, for now, as good an excuse as any that this chronic inflammation causes a reaction that causes the cells to replicate and the prostate gland to enlarge.
Yeah, and inflammation becomes systemic, right? And
yeah, so if you're, as you're pointing out, that lifestyle, if that is indeed the underlying etiology of benign prostatic hypertrophy and an inflammatory mechanism, how could diet and lifestyle not have an impact on mitigating that problem?
Absolutely. And it's funny, I find most of my inspiration in BPH of lifestyle from the pharmaceutical studies. You'd be shocked. When one of the most famous studies of Avodart, dutasteride, and to see if it could prevent prostate cancer, they decided to look at prostate volume and how that changed over time in this trial, in the placebo group and the drug group. What they found were people that were on cholesterol-lowering drugs, for example. I'm throwing out one of the findings that didn't get enough attention. It was brilliant. One of the cholesterol-lowering drugs actually slowed the growth of the prostate itself compared to people who weren't on them. Now, ultimately, is that going to make a dramatic difference? I can't tell you. And they would say, well, it's a little bit. It slows the growth a little bit, but it's statistically significant compared to placebo or compared to another group. But that's just one little hit going after inflammation, right? So what's the cumulative response? The cumulative response of slowing the prostate from growing. You know what the cumulative response is? And you're going to love this. And then I promise you, I'll get off my soapbox. How many men around the world have been diagnosed too early or have been diagnosed with prostate cancer that could never harm them because they had a rising PSA that had to be investigated that was the result of BPH?
Hundreds of thousands, millions.
Millions, Mark, meaning that when you control BPH, I think you also help control objectivity of your body.
Yes. And just one, because we talked briefly about cholesterol pills, so-called statins, and, I've had patients who had normal LDL levels. That means that their bad cholesterol wasn't really elevated, but who had bad atherosclerosis detected on CT coronary angiograms and CAT scans. And we proposed putting them on a statin or a cholesterol medication to lower their risk of heart attacks. And their logical issue is, well, my cholesterol's already low. Why are we taking a cholesterol-lowering medication if my cholesterol level's already low? And people often don't realize that there is also a built-in anti-inflammatory effect from the cholesterol pills. And it's inflammation that causes this damage to their arterial wall. So there's still an advantage for the statin medications. Even if you have a normal cholesterol, at reducing the risk of coronary events. And as you're pointing out, you're seeing a spillover effect in the prostate, where it's probably also inducing a mild anti-inflammatory effect.
One of my favorite papers, you make me look way too good. You make me look way too, it's not just from wearing ties like you would wear, but one of my favorite papers this year that is just getting published, and this comes from a variety of different universities, including Fred Hutchinson Cancer Center in Seattle. So here they're looking at breast cancer patients being treated and their adherence to cholesterol-lowering med while they are going through the process. And this will be a paper that in my world will shout, but I don't even know if it will get any attention. So they followed people that were adherent, semi-adherent, or not adherent. And essentially, they found out that maintaining in breast cancer patients good adherence, they're going to find the same thing in prostate. You know this is going to happen. And adherence means at least 80% of the time you're taking your cholesterol-lowering medicine. After breast cancer treatment is overall beneficial for cardiovascular health and cholesterol. But essentially, the suggestion was there also that it reduced their risk of cardiovascular events, right? Or something that could also be increased from treatment itself. So what they're finding, whether it's in HIV, they're finding in breast cancer, I think they're going to find it in prostate, that when you take care of yourself under these enormously stressful conditions, which contribute to inflammation, the treatment can contribute to inflammation, that you're giving yourself a chance to reduce your risk of the #1 cause of morbidity and mortality in Americans, which is cardiovascular disease. So the question becomes, have we reached the point like in HIV, and now they're talking in breast cancer? And I've talked to friends about this. If they're getting treatment for these different cancers, you need to talk to your oncology team about going on a cholesterol-lowering med or doing things that are anti-inflammatory. And they'll go, but my cholesterol is fine. And I say, no, no, no. It's like what Scholz says. We're cutting down inflammation. We're not allowing it to take over. And I really think in 2024, we are at the point, I don't care if it's hormone therapy, I don't care where you are in the journey, if you're getting treated, these things can be hard on healthy. There has to be a discussion about what can I do to combat the inflammation that's about to be caused by the treatment that you're giving me, which can eradicate my cancer, but paradoxically, can increase my risk of a cardiovascular event. When Mark Scholz and I talk about statins, it really is a general word meaning heart healthy. So that means exercise. It means changing your diet for the better. It means cholesterol. It means blood pressure. The most ignored cardiovascular metric, which is done poorly in the United States, and we have to reteach how to do it. All of these things is the buzzword for statins. It's not just about the pill. It's about anything in lifestyle that reduces your cardiovascular risk. That's the buzzword, and I hope the audience knows that's what we mean. That's the buzzword.
And just as you pointed out, and you're already aware of all this data, but it's good to repeat it as you're showing the advantages for statins in breast cancer. The men who have prostate cancer undergoing radiation for cure for unexplained reasons have higher cure rates when they're on statins compared to when they're not on statins.
Yes.
And that phenomena has been reproduced in multiple different observational trials. And so in men that have gone through radiation and who are keeping their fingers crossed that they're cured and they're believing that it'll never come back, study after study shows that if they're taking a cholesterol pill, that they're more likely to remain cured than if they're not taking a cholesterol pill. And I don't have an explanation for that. It's just an observed phenomena in several trials.
I have an explanation for it since I've been publishing about it since 2003, but my explanation helps drive the point of what we're talking about. That's a buzzword. It's an association. It's not causation, meaning that it's associated. That when someone takes advantage of their health system, when someone takes a statin, this is like the multivitamin users we watch.
Yep.
People want to just bet their entire amount of money on the roulette wheel on one number. That's not how it works when it comes to lifestyle. The people who are willing to take that statin and adhere to that statin, gee, they're also the ones who don't seem to smoke. Gee, they're also the ones who are sensitive about their weight. Gee, they're also sensitive about their diet. Gee, they also, for example, eat more plant-based foods. What you see is it's an association with an overall lifestyle or a pattern that then ultimately they pay off. Now, what the statistics do and the statisticians, because I was a statistician, I mean, that's my background too, is statistics and epidemiology, is we always want to tease out the one factor that gave them the biggest hit. Like, what's the one thing that gets you to 100, And We always look for it, but you don't realize that in statistics, those are called confounding variables. There's always these variables associated with taking care of yourself that we'll never be able to pick up on, because the average person that takes care of themselves in 1, 2, 3, 4 ways, they look for way number 5, 6, 7, 8, 9, right? They continue. That's why when you see people who exercise more, tend to be less risk at taking up smoking. People who tend to exercise more tend to eat healthier overall. People who tend to exercise more have a relationship with their doctor. And so I think the relationship is not just statin-wise, it's what the statin user's doing in general to reduce their cardiovascular risk. This is what makes me wacky about diet too. People will go, well, what should I get in my diet? So people will go, Mediterranean diet. And I'm going, the Mediterranean diet is not a diet. It's a lifestyle. It is a lifestyle. It is a pattern of behavior. It is not about, if you really want to believe it's about something called olive oil, you will not get there. Olive oil is extremely high in calories. I like it. It's a processed product. I love it. But if you look at the average person who's getting that olive oil in the Mediterranean diet, they consume more fatty types of fish, for example, with omega-3 fatty acids. They're more likely to walk in the day. They're more likely to take a siesta. They're more likely to socialize, for example. They're more likely to eat fruits and vegetables. They're more likely to eat less processed foods. If you could just literally come up with a checklist of what the lifestyle pattern is in the Mediterranean, the people that do well, and they go through a Moyad checklist of 25 things that are healthy. And the idea that I'm going to tease out one of those and say, that's the reason they made it to 100 is naive thinking, and it will not get you to where you want to. What I've learned visiting all these places and seeing all these data, again, it's a lifestyle. Why did I live close to work? Why am I moving away to go live in, the woods and other places in the next few years? It's because what I also learned that at a point in time, you got to start reducing stress. And that's what also they do with this lifestyle. They find ways to reduce stress. But seeing their doctor is what they do. Eating healthy is what they do. Exercising is what they do. They are not big smokers. They're not big into alcohol drinking, even though it's associated with red wine. They're not big drinkers. It's a moderate game. So we come full circle here. And that's why I think, again, when we go back to the word statin or this pill, or some people want to talk about metformin, it's what are you doing around that to give you the advantage, right? What are you doing around that? So I hate to belabor that. And I know you've heard that speech from me probably 50 times in 20 years. But to me, it never, ever, ever, ever gets old.
People chip away at this. There's low-lying fruit in terms of, you can't change your whole lifestyle overnight. You try and identify the number one thing that can be worked on, and try and make some progress, try and have some success, and hopefully build momentum with future successes as you build through these changes. People are not going to have a religious experience and all of a sudden they're committed to taking good care of themselves. But there's as we go through and discuss these things, people can identify the thing where they can show the most improvement and get the most rapid feedback in terms of augmenting their future prognosis.
If you look at the compliance just in the United States with the 5 Bs, I brought up the 5 Bs when we used to have conferences. I'll bring it up again in the fall conference. I just tried to want to simplify life. And the reason I said 5 Bs, and 4 of them are objective, is essentially that if you look at the number of people in the US that have conquered just the 4 or 5, it's a very small group. It's a very tiny fraction of society. And you think, wow, I'm ready to write down the 5 Bs. What are those? So this is BMI or belly. It's your weight, right? How many people have conquered or been able to say they've been able to achieve a healthy weight most of their life? It is that alone will keep you busy the rest of your life, okay? But that's just number one, just being at a healthy weight overall, okay? And these are just measurements that you come up with. And then blood cholesterol. How many people have actually conquered their cholesterol, so now it's normal, it's in control? That's hard. How many people have conquered their blood pressure? That's extremely difficult. How many people have conquered their blood sugar? That's extremely difficult too, right? So just those 4 alone. And then let's just say about lifestyle. How many people can say that they have an optimum diet or they're doing over well diet-wise? Or how many people can say that about exercise? How many people can say that they don't have a vice? They're not drinking too much alcohol, they're not smoking. Okay, that's number 3 overall. And how many people are saying they're getting adequate sleep? So, gee, I wonder why the American Heart Association have come up with 8 lifestyle factors, which virtually nobody has conquered, but they found in their research that it conquers heart disease. We're going to find this throughout medicine. We're making this hard. We got to go back to the simple items because the simple items alone are hard enough. I'll just give you a standard. When I just think of you, and this is a compliment, I just give you a standard. How many people have you put on abiraterone? Okay. How many people have you put on that medication? I'm just picking that one out. How many people have you put on that medication that now have gone on to buy a blood pressure cuff from Omeron or another company that's accurate, and they take their blood pressure at home because one of the concerns, as you know, with abiraterone and a bunch of other drugs are the blood pressure changes. But blood pressures are already in the United States, the #1 killer of men and women in terms of cardiovascular disease, in terms of its contributing to the events. And now you've got a drug that's going to increase the chance of it can help cure your cancer, but increase your chance of your blood pressure going up and becoming hypertensive. My point is that how many people on abiraterone right now take their blood pressure every week or two, are making sure they're monitoring it, are working with their GP to make sure it doesn't increase anymore, or actually the goal why they're on prostate cancer drugs is to lower their blood pressure. I'm asking you actually outright, how many people are you sure of have conquered that while they're on this medication? I just am wondering.
Well, I mean, it is routine. Abiraterone has an impact potential on liver function. It can cause, damage to the liver. So monitoring after initiation is critical.
But not you monitoring. I'm talking about them monitoring at home. I know you monitor. I'm just saying.
It has to do with patient education. That the rise in blood pressure with Zytiga or abiraterone is probably half the patients. So it is critical to monitor blood pressure as people initiate that. And there's abiraterone's not the only. There's other medicines that can cause blood pressure rises. So
exactly.
People. There is a proper way to monitor blood pressure, and that is to check it more frequently at home, because that's the real world, at different times. And then run those numbers, get 10 to 20 data points, the high number and the low number, and then average them. And that's how you find out what your real blood pressure is.
Yeah, and it's learning the basics. Blood pressure is, in all the Bs, in all the most important measurements, is the most often, and the American Medical Association will say this, it's the most often probably simplistic test that comes up inaccurately because it's not done accurately. So people have to learn how to properly take it at home. So you can go to the AMA, you can go to the American Heart Association. You have to go through a variety of steps on how to take it accurately. Now, I can walk you through all those steps in the future, and I will. And then you have to learn about the devices that actually have been validated, so they're accurate. So that's why I bring up the company Omeron. You'll see them at CVS and Walgreens. They always pass the accuracy test, and they're fairly low cost. That's the one that I own when I take my blood pressure once a week. But when you got the majority of Americans now pre-hypertensive or they're hypertensive, and then they're walking into all these treatments, as you describe, that can raise their blood pressure even further. And now just remember hormone therapy and the gaining weight and the blood pressure. So blood pressure takes on a paramount, massive meaning in the patient being treated for prostate cancer, which means they've now got to embrace the reading of it and the controlling of it, not just their doctor. And I guess that's some of the stuff that I wish would get passed on in the men's health meeting. And I think we do when we talk about it.
I think too, that if you think about it, running a pressurized system 24 hours a day, 7 days a week for the rest of your life, there's going to be less wear and tear if you're running your blood pressure at a lower level. So there have been discussions about, what is an optimal blood pressure, and it keeps going lower and lower as people, studies come in. And probably anything short of feeling dizzy every time you stand up, the blood pressure almost can't be too low if you're an otherwise healthy person and have normal kidney function. So I think you're right that we talk a lot about lowering cholesterol as a way to reduce vascular inflammation, heart attacks, and strokes. Blood pressure is equally important.
Yeah, I mean, think about everything we've learned in 2024 now that affects blood pressure. We talked about alcohol earlier. We talked about all the people that are already hypertensive, and now we have drugs that are increasing their risk of further hypertension. We talk about the enormous impact of just a little bit of weight gain on blood pressure. It's just profound. Some people are so sodium salt sensitive. Takes very little to increase their blood pressure overall. We talk about the effect of stress. You know, there's a product out there that actually reduces your stress, and they're allowed to make blood pressure claims because we know the effect of stress temporarily on blood pressure. On and on and on it goes. And this was the primary goal of the men's health meeting, that the people watching, that we make sure that this stuff is not trivialized. This stuff is critically important for longevity and quality of life. And then you taking control of it. I firmly believe, Mark, I firmly believe that every man being treated for prostate cancer, for example, and every man who engages in any sort of systemic treatment has to know the ABCs of blood pressure, has to own their own blood pressure machine, has to understand the medications, has to talk with their primary care about making sure it's under control. They should do that anyway, but this should become mandatory for anybody that is put on any of these medications that could even be slightly risky. So anyhow, do you want me to leave you with the best study that I'm reviewing right now?
All right. Yeah, wrap it up with your best study.
So there's one that's just coming out now. So it's looking at people in their 80s in China, and they're trying to, and this is a very common theme. They're looking at, okay, when you hit 80, how could we predict that possibly that you would then make it to be a centenarian? You'd make it to be 100. So they're really trying to figure out this longevity secret. So this is in JAMA Network Opens. This is this week or last week. And I'm reading it and I'm going, okay, this is a preliminary look. And I'm going, all right, what are they doing? What are the 80-year-olds doing to get to be 100? Okay, yeah, maybe they have a little bit of genetic advantage, genetic rocket boosters. And I'm going, here it comes. They're not smoking. They're hardly drinking. They're exercising regularly. This is literally their finding from following 80-year-olds. And this gets published in the Journal of the American Medical Association. They end up eating a diet that's diverse. So they're eating fruits and vegetables. They're getting fish. They're getting, the point is, overall, it's a majority healthy diet. They're not absolutely consumed like some people of everything that goes in their mouth. They learn that it's a pattern, that the overall majority of what they're doing is healthy. Oh, and by the way, their body mass index is in the normal range, or they're in a healthy weight. And these are literally the 5 that they came up with to help predict. They were the greatest predictors of longevity. And then they gave it to a statistician and said, well, which one of those 5 is the most important? And hallelujah, the statistician said, well, I'm not so sure which one, because all of them seem to be profound. So that just kind of drives the point today that don't let someone fool you that if you just get on a treadmill all day long, that's the only thing you have to do. It's about balance. It's about diversity. It's about moderation, but it's about all those little things that don't get a TV commercial, that should be getting a TV commercial. I don't know if you want to add to that, but I thought that was a great
No, Marcos, you've been our TV commercial today. Thank you. I appreciate it. This is stuff that has to be said. And this is what you and I observe in our clients that are manifesting extended longevity. One of the things that we have about 50 patients in the practice that are in their 90s. And the one memorable thing when you meet these people, and these are people that are driving into the office, and you know, some of them have jobs and whatnot, is all you have to do is just shake their hand. And when you get the pressure back, you feel like you're holding the iron claw. These people are fundamentally strong. I think there's something that Moses told us in one of the Psalms. It says, you know, we've been allotted 70 years, 80 if we're strong. So underlying strength, fitness is something that accrues to longevity.
Yeah.
And this is something that's universal. You know, I'm sure there are people in nursing homes who are 90 who are frail and they're about to check out. But the people that are still viable and some of them, as I said, employed, the strength, you would not anticipate that someone in that age group would impress you. And these are not people who are trying to impress you. I just shake a lot of hands. It's part of my day-to-day life, and it catches my attention. They're not trying to impress me with their strength. It's just, you can feel it. And so that very much matches what you've told us.
But what you're saying there is so profound. Let me just tell you, every year from what I've learned from the studies, and you're learning from the public, and you're learning from all of these meetings, is I've learned again that it's this pattern of behavior, and you keep wanting to add another little nugget, something else that's healthy every year. And I tried to learn it. What I began to learn as I'm approaching 60, because I'll be 60 pretty soon, is that I began to learn that the people who are really doing strength training, like you talk about, resistance activity, especially as they get older, it becomes a huge piece of the puzzle. Well, I wasn't thinking about that at 50, and I really wasn't thinking about that at 45. It's not that I didn't lift weights, but I kept getting inundated by studies that would suggest, here's a headline, skinny leg runners face higher rates of knee arthritis. In other words, the implication was, what we're forgetting is that 40% of our muscles, 40% of our muscle mass goes away by 70, 75, unless you do something. And that is just an unbelievable change. So, you know, I'm a runner, and people always tell me, well, you're going to need your knees replaced by 50. And they tell me all these things. What I noticed about the runners that were still running in their 70s and 80s is they had very big quads. They had very big hamstrings. They had very big supportive muscles to support their joints, and they were still working out. What I noticed is my muscles were getting thinner. So I started to get some hip pain. I thought, here we go, knee pain. The smartest move we made in the past year is we bought a Life Fitness machine. It's called a G4, and it allows you to do a variety of leg weights, and I do them every other day like I watch people do my whole life who became stronger. This entire year, I'm probably running 5 to 7 days a week, almost 7 days a week, which I never did except when I was in high school, and the pain is not there. And what I'm trying to say is that this is what I've picked up now coming into 60. People say that strength training, but I'm talking about lower body, upper body, maintaining muscle mass, because once you hit that 60, 70, there's an acceleration of sarcopenia, an acceleration of age-related muscle loss. And one of the smarter things that we know we can do it is buy your own machine if you can. Some of these are low cost, and put it in your house and make it a part of your routine. And now we know it reduces your chance of total knee replacement. We know it might reduce your chance of a hip replacement. We know that your knee replacement and your hip replacement will last longer, building your muscles. So what you're saying about your patients is screaming in the data. And that was the latest change we made. I never thought in a million years, Mark, that I would buy a leg machine and an upper body machine and put it in my basement in front of a TV. I thought I'm always going to go work out once in a while. But this has become as important as my diet.
Yeah. Well, I should have shown a picture of my weight machine, which is right by my bed. And I try and get on that machine before I think of a reason not to do it, right when I get up out of bed in the morning. And it's a battle. We can get into talking about the psychology of how to fool yourself into exercising perhaps in the future. Anyway, I just want to say thank you for inviting these amazing speakers who have been so helpful to us. Thank you for your very clever and apropos, drawing them out, showing their strengths, and exposing us to this wonderful wisdom and knowledge, as you've done so many times. Maybe you should say a quick message about our first in-person meeting coming up this September, which you will be moderating for us in I believe, the second Saturday of September.
That's right. It's this has come from the staff. This has come from Alex. There was this idea. You remember that meeting a few years ago? We're in the midst of the pandemic, and these I call them young kids at PCRI. They are young. They're impressive. They want to have it in person. I'm thinking, but I think they made the right choice. I think Alex, Peter, the rest, they make the right choice. I think there was a certain magic about the in-person meeting that unless you've been there, if I even try to describe it, it's a tragedy. I don't even want to even try to be that eloquent.
Yep.
It's the camaraderie. It's the getting your personal questions answered. It's something I used to just crave in medicine, going to a meeting where people didn't hold back. They weren't worried. They weren't worried about someone looking over their shoulder. They spoke their mind, but they also spoke the data. They were very candid. It is the most refreshing health meeting, medical meeting I've ever been a part of, which is why I love being a part of it. And we invite the top people in the world, and the top people are going to be there. Elizabeth Heath, which is, I think, one of the greatest oncology speakers and knowledgeable people, apart from yourself, of course. I've just never seen anybody that good. She's just that good. Lori Klotz, who is the emperor of active surveillance. I mean, what needs to be said? Daniel Margolis, who you actually introduced me to, who's the emperor of imaging, right? He was at UCLA and now is over at Cornell.
Yeah.
Then we have a guy named Dr. Brady. It's not, I always want to call him Tom Brady because of Michigan, but he's a reconstructive urologist because look at all the side effects that people deal with. And he spent his entire career as doing reconstructive work and changing the quality of life overall. And then how about the radiation oncologist, Mac Rhodes? I mean, world famous. You know, he just got a Lifetime Achievement Award from the the large radiation group. I mean, Lifetime Achievement Award. Of course, he sent it to me, and I made fun of it because we have that banter. But that is an all-star prostate cancer lineup like I have never seen. And then you and I will be a part of it. And
the in-person aspect of it is that the patients will be able to have direct questions and answers with these people after their presentations, which they make themselves available for extended periods, and which is always a very popular part of the in-person experience.
Yeah. So think about it. You're covering treatment, you're covering imaging overall, you're covering active surveillance. We're going to cover, as they know in my Q&A, we'll cover a ton of lifestyle, and we'll talk about supplements, the good, the bad. And it's, again, I'm just going to say it. It's the most comprehensive educational day. And the next day we do Q&A live. It's the most comprehensive educational day I've ever been a part of, which is why it's so difficult as I kind of move towards slowing down. It's hard to say no. And I just want to also say, apart from this meeting, the staff currently at PCRI, so Alex's team and just the whole staff, they're not just young and vibrant. They know their stuff. They've really learned their stuff, and they're good. And I'm not just talking about knowledge. I'm talking about the media, the stuff that you see, the videos that you produce, the information that goes out there. It's as good as I've ever seen. And all of this comes together in one day at a meeting. It's really phenomenal. In fact, for people who don't know, for the past 15 years, after the meeting's over, we always go into a room and we sort of decompress. It's such an overwhelming amount of overstimulation and information that first thing we do is decompress. And it's one of my favorite moments in all the years that when the meeting's done and we've worked for an entire year on it, we can just breathe and we know we did the right thing. So I think we're going to have a full house this year. I really do.
We'll be at a hotel near the Los Angeles airport, and I believe it's going to be 2 days, Saturday and Sunday. And we're certainly inviting you all to join us in person in September.
Buckle up. I don't think anyone's going to be disappointed. It's going to be really fun. Anyway, I don't want to get too effusive, but there it is. Thank you. It's always a pleasure. Don't get mad the conference is over. There'll be another conference in about a month or month and a half. What's the big deal? We get to hang out. We don't have to work so much now. I don't have to do this moderation stuff anymore and ask questions. I get a little bit of a break. So Grazie and Daddy gets to hang out. Okay? Okay.
Thank you, Dr. Moyad, and thank you, Dr. Scholz. We so appreciate you. I'd also like to give a big thank you to all of you for watching. We thank you for your support, for watching our channel. Please subscribe if you already have not done so, because we come out with new prostate cancer videos every week and information on men's health, BPH, prostatitis, and so much more. It's a wealth of information. So subscribing is a great way to support our channel. Also, we have a big conference coming up this September, and it's in person. It's a great way to meet some of our speakers and to get your questions answered and be part of the prostate cancer community. Now, I'd also like to thank our sponsors, Bayer, Dendreon, and Janssen. It's because of them we were able to make this absolutely free. Please go ahead and check out our website for our Men's Health Conference, and you can find out more information about the services that they provide and the information that they have when it comes to the treatments for prostate cancer. Now, if you would like help with your particular case, you can contact our helpline at pcri.org/helpline. We'll go ahead and put a link in the description as well. But most of all, please remember you're not alone. Reach out if you need help, and we so appreciate the fact that you watched this conference, and we appreciate your viewership. Go ahead and give us a thumbs up and leave any questions and comments in the comment section. I hope you have a great week.
Why do we come? Because knowledge is power. And knowledge provides hope.
And this is a place of hope and healing. And that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
The key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up to date all the physicians are.
And they're very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging. I mean, this is not a dull conference. This is I don't want to use the word entertaining. I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.